Check one, two. Good morning, everyone.
Good morning.
Allie, let me know when we're live. We're good. Good morning. Welcome to the Insurance and Real Estate Committee's public hearing on Tuesday, February 27th. I'd like to jump into the public hearing, but first I just have an announcement to make on the order. We have an addition to the speaker order. We're adding Deputy Commissioner Jared Kofsky from the Connecticut Insurance Department. So I just want to make that announcement on the order. Any remarks from the co-chairs, Vice Chair, Barry, Ranking? Great, let's get started. First speaker is Dr. Deirdre Gifford from the Office of Health Strategy, followed by Cindy, are you gonna go? Okay, thank you. Welcome, Dr. Gifford.
Good morning, everyone. Representative Wood, Representative Barry, Representative Meskers, and Representative Pavlak-D'Amato. I'm Deirdre Gifford, Executive Director of the Office of Health Strategy. Very happy to be here this morning to offer testimony on 3 bills, including House Bill 5054, Senate Bill 210, and House Bill 5248. And I'm happy to take any of your questions. First of all, to support the governor's bill. We good? All right, thanks. Very pleased to offer testimony supporting the governor's bill and act addressing healthcare affordability, House Bill 5054. The bottom line rationale behind this bill is that healthcare remains unaffordable for too many Connecticut residents. And this bill outlines a number of strategies that are focused on making the healthcare more affordable for our residents. As you all know, first of all, Connecticut established a cost growth benchmark program in 2020. And this bill offers several strategies to strengthen that program. We have set a cost growth benchmark beginning for 2021 through 2025. I'll note for the committee's interest that at yesterday's cost growth benchmark steering committee, we recommended and the steering committee accepted a recommendation that we slightly modify the 2024 benchmark based on inflation in 2022. Nonetheless, we know that when we first reported our outcomes for the cost growth benchmark for the 2020 to 2021 year, we exceeded the statewide benchmark by a significant margin. The benchmark was 3.4% growth in total medical expenditure, and we had a 6% increase. This was an unusual year coming out of the pandemic. Nonetheless, we know that this was driven by an 18.8% increase in overall commercial spending per person. So this bill builds on that program and strengthens it, and really is the result of a lot of feedback that we've had from stakeholders across the spectrum as we've rolled out the first year of this program. So what would the bill do? First of all, it establishes performance improvement plans for entities that exceed the benchmark. I want to note for the committee that these performance improvement plans would not go into effect until 2026. We've heard from stakeholders that they want a little bit more time to understand the benchmark program, to work with the Office of Health Strategy on our data collection, et cetera. But this bill would put the future performance improvement plans into place so that we would all know we were working towards that. Those performance improvement plans would identify strategies, expected outcomes, and implementation timelines for staying within the benchmark in future years. We would also like to note for the committee that we think, in reviewing some of the bill language, particularly Section 5, that we could clarify some language pertaining to the entities subject to the performance improvement plan. So we would be interested in speaking with the committee further on that issue. And the last thing I'll say is that this language is modeled on the performance improvement plans that are already in place in our neighboring state of Massachusetts. They have implemented a performance improvement plan with one of their healthcare systems, and their target is an 18-month saving of $176 million as a result of the plan. Second, in this bill, would allow within available appropriations, the Office of Health Strategy to conduct what's called a cost and market impact review. That's in essence an in-depth study of a healthcare entity that is contributing significantly to exceeding the benchmark. These studies help OHS identify financial factors that may be contributing to exceeding the benchmark and would just be another tool in the toolbox to getting to solutions to meet the benchmark. Another element of this bill is that it strengthens OHS's ability to compel participation in our annual hearing. You may recall that the statute for the benchmark includes a report in March, a hearing in June, and a report to the legislature in October of policy recommendations. Although the statute currently states that entities that are called to the hearing shall participate, there's no penalty for them not to appear. And in fact, when we held our first hearing last year, we had one a pharmaceutical manufacturer who chose not to participate in the hearing despite being required to do so. So this simply adds the ability to compel individuals to appear at the hearing and seek the assistance of the Superior Court if an entity refuses to comply. Finally, we would establish something called the Cost Growth Benchmark Oversight Commission. And as we add elements to the benchmark program and give the program additional enforcement authority, the bill thinks that it's important to strengthen the program by adding an oversight body with expertise that would be statutorily established, would vote on recommendations for the office, and provide expertise on things like how to set the benchmark, determining compliance with the benchmark, analyzing data and drivers of healthcare costs, conducting our annual inflation reviews, and adding quality measures. Currently, there is no statutorily established oversight body for the benchmark, and we think that this will strengthen the program by putting this into statute. Another section of the governor's bill permits OHS to establish so-called affordability standards for the Connecticut Insurance Department's rate review process, and you'll hear from my colleagues at CID about this. The bill provides authority for us to establish these standards that would look at indicators of the insurer's affordability efforts at the time that they submit requests for annual premium increases. And OHS would establish policies and procedures for making this affordability assessment. It might include things like the efforts on the part of the carriers to meet primary care spending targets, the number and type of alternative payment models that the carriers are putting into place, focused on affordability, cost, quality, and equity. Efforts to reduce unnecessary utilization. How are they helping individuals, for example, stay out of the emergency room for non-emergent conditions? And how are they incorporating standards from centers of excellence? After OHS completed this affordability review for each request, we would transmit that information to the Connecticut Insurance Department, who would then be able to consider the assessment in their review of the rate increases on an annual basis. And finally, part of this bill addresses something that we all know is a very significant contributor to affordability challenges in the state, and that is the cost of prescription drugs. So the governor proposes establishing what's called a Prescription Drug Affordability Board. These exist in a number of other states. They would evaluate ways to lower drug prices in a number of ways. First of all, exploring strategies to reduce out-of-pocket costs for consumers, studying the prescription drug supply chain and pharmaceutical pricing practices to identify opportunities for consumer savings, monitor prescription drug prices in the state and in other states as well, and promote innovative strategies for the use of more affordable drugs. And then the PDAB would make recommendations to the Office of Health Strategy and submit an annual report to the committee, including these recommendations. So that concludes my testimony on the governor's bill, and we respectfully request the support of the committee. Briefly on Senate Bill 210, this bill seeks to include hospitals in the cost growth benchmark and adds hospitals that requires hospitals that exceed the benchmark to participate in annual hearing. OHS generally supports the addition of hospitals to the benchmark program, as our data indicates that hospital and pharmaceutical prices are the two primary drivers of healthcare cost growth in the state. We would like to note, however, for the committee that the methodology currently in statute for measuring compliance with the cost growth benchmark is not directly applicable to hospitals. The current metric is something called total medical expenditure, which would include hospital, but also non-hospital costs. So we would be happy to work with the committee to modify or clarify how hospitals may be included overall in the benchmark program. Section 8 of Senate Bill 10 requires the listing of national provider identification, so-called NPI, on hospital claims, both on campus and on campus. OHS supports this recommendation. This would assist us in monitoring and evaluating the facility fee legislation that passed last session that we worked with you all on. Would give us the additional information that we need to monitor both on-campus and off-campus facility fees. And finally, House Bill 5248. This bill would add OHS to the review process for mandated health benefits in order to provide additional information on quality and cost impacts of those mandates. Currently, our understanding is the reviews are completed by CID and are due in August. We generally support the goal of looking at cost and benefits of any proposed benefit mandate. However, we note for the committee that as we understand the deadlines in the current drafted legislation, they would be very difficult to meet, essentially conducting the entire evaluation within the session that the mandate was proposed. And we would suggest that a longer period of time would be needed to conduct the analyses that are described. Furthermore, we know that this would require both an actuarial assessment as well as a cost benefit analysis, both of which require a certain expertise and would be costly to implement. It certainly can be done, but given that there is no provision in the governor's budget for OHS to conduct these studies, we're unable to support the proposal at this time. Thank you very much. That concludes my testimony, and happy to entertain any of your questions.
Great, thank you. We will open it up to questions. I would like to ask a few questions to get us started. First, on the PDAB setup or on the PDAB goals, would you entertain adding a provision to support or look at ways the PDAB could support local Connecticut companies or grow this sector here? Is that something that the PDAB would be interested in doing?
Yes, Representative. And in fact, if you look at the language in the proposal, we explicitly call out that the focus of the PDAB would not be on new and innovative products. And in fact, the goal is to look at places both in pricing strategy, in the supply chain, and in particular drugs that are not new and innovative. So we'd be happy to work with you on either reviewing the language that's already contained in the bill or thinking about additional ways to clarify that the intent of the PDAB is really to focus on things like generic drugs, drugs that are off patent, on patent extensions, et cetera, and not on innovation.
Regarding the affordability standard, so it sounds like OHS makes that definition and then submits that to CID. Is there any other input that goes into defining what the affordability standard is?
Yes, and in fact, there's language in the bill, Representative, that suggests that we would need to, I believe it's by January 1st of next year, make a proposal and have public input and stakeholder input on how the affordability standard would be assessed and measured. So that we explicitly contemplate a stakeholder process for that standard. And then OHS would need to publish kind of the rubric by which the affordability assessment would be done.
My final just comment is, and I have expressed this to OHS as well, is that, similarly along the lines of, some of the bills we're proposing have additional staffing requirements and cost. I see a lot of additional staffing requirements and cost in here that directly, get passed on to the plans that we're trying to help. So I hope we could just continue to have those discussions on where we're finding ways to pay for this. And it's not through assessments on carriers. It's not through, the insurance fund. We can get creative in how we're creating this new oversight board and new PDAB and make sure that we're not, ineffectively rising costs onto the, premiums of the people that we're trying to help.
Understood, Representative. I will note, and we'd be happy to submit the details for the committee, but I will note that there are 3 positions in the governor's proposed budget for these affordability activities. However, there is a net gain to the insurance fund overall because of positions that were budgeted for in the biennial budget and were not hired by OHS. So actually, there's a net decrease in the amount of insurance funds necessary, despite the fact that we are increasing staff through these proposals.
Thank you. We're going to go to questions. Senator Wong.
Thank you, Madam Chair, and welcome, Commissioner. Thank you for your work. Let me go to the first point, which is your sections 1, 2, and 3 related to the prescription drug working group. Can you talk a little bit more about the structure and how it's going to address issues relative to the federal legislation in regards to prescription drug, the 10 most utilized, and the price marking of that, and how we're going to deal with on a federal basis? But also, I don't know if you submitted written testimony yet, but even your conversation, have you looked at how the interaction of that body would be relative to PBMs, which obviously are the largest market determinant in regards to prescription drug cost? Can you offer some insights on where you see that prescription drug board addressing these 2 issues?
Yes, and thank you, Senator. I didn't realize you were on remotely. I would have greeted you in my opening remarks, so nice to see you. Yes, so both of those things are explicitly contemplated in the legislation, Senator. The board is directed and empowered to look at both federal and other state strategies for reducing prescription drug costs. So we know that there is a lot of activity in this area, as you noted, through the Inflation Reduction Act gave Medicare the power to negotiate prices for prescription drugs for the first time, and that many states are looking at whether that is a strategy that could be in some way borrowed or utilized at the state level to extended beyond Medicare. So the PDAB would be empowered to look at that. Other states are also looking at how to use other types of benchmark, for example, Canadian prices, VA prices, Medicaid prices, European prices. There's a number of benchmarks that other states are looking at, and the PDAB is explicitly directed to seek the input of other states on how they are approaching prescription drug prices. With respect to PBMs, last session or the session before, OHS was given the responsibility of publishing a study about PBM practices. That study is underway. We anticipate that if this bill passes, the PDAB would take that PBM study and use it in formulating their recommendations. The way that the governor's bill is crafted, it's meant to direct specifically that the PDAB look at pricing practices that may not be adding value to consumers, but are simply adding costs through the supply chain. So I think both of those are addressed in the language of the bill, Senator.
Thank you, Commissioner. And you did mention the study, and we did, in a bipartisan basis, address the PBM concerns. Was there a deadline for that study to be submitted? And I think that's one of the questions I had is, for us to kind of take a look at contemplative prescription drug cost containment and measures, it'd be very helpful for us as a legislative committee to have that study and report and be able to base some of the policy making that we're undertaking or guided by the proposal of the governor. Do you know when that study will be completed and when the deadline for it was to be completed?
I believe the deadline is December 31st of this year, Senator. I can confirm that and get back to you, but I know that we have released a request for proposals and are in the midst of conducting the study now. So I anticipate it'll be available to you by the end of this year.
And I appreciate that timeline, which leads me to the question of we're making proposals and creating bodies and contemplating this statute without the necessary study background information. Maybe we're a little too early and we need to wait for the basis of that study consideration. That's just a question on that. The second point related to prescription drug, we've seen some of the testimony, and has the bipartisan co-chair of the Bioscience Caucus. I'm concerned to address the concerns of research and development and market competition of our pharmaceutical companies. Has there been any consideration in regards to how this body has proposed would engage and get viewpoints from our bioscience industries, which are significant employers and innovation leaders that exist in our state?
Thank you, Senator. And yes, there's language in the bill that suggests that the PDAB would need to consult with expert stakeholders, including those that you reference. We understand the need to balance affordability with innovation, and I think that's the point of the governor's bill and the way that this particular PDAB, which is somewhat unique compared to other states, is crafted because of some of the considerations that you name. But we also know that that we have residents of Connecticut who are skipping their medications, are not taking their medications, not getting their prescriptions filled because of affordability challenges. So we're trying to balance both of those very important interests with the way that the governor's bill is crafted.
Thank you. And with the indulgence of the chair, my second set of questions is related to the benchmarking proposals in this bill. This has been truly a bipartisan endeavor, first from the governor's executive order, but now to it being codified in legislative passage in the past number of years. But the challenge has been, and I'll just recite some of the offerings from our hospitals in regards to the kind of data processing challenges in benchmarking. Let me be clear, I fully support it. I think it's an integral part for us to be able to get data points to manage and understand the underlying cost to attack it. But how do you address the criticism or the challenges in regards to your benchmarking proposal right now in this bill related to the criticism of these hospitals? As said, the data processing has been incomplete, and there's a challenge in regards to implementing such a benchmarking requirement and mandate.
Yep. So thank you, Senator. Very important considerations. And as recently as 30 minutes ago, I was talking to a hospital colleague about data challenges. We had a robust discussion yesterday at our steering committee meeting on the topic. And we meet on a regular basis with our hospital colleagues to talk about the data and information that that is being produced by OHS. So I would say a couple of things. First of all, as I mentioned in my testimony, the performance improvement plans would go into place in 2026. And we did that, we made that proposal knowing that these conversations are ongoing about how do we measure compliance with the benchmark. It's a program that's new to Connecticut, although I will say there are states around the country that have been doing this work for a number of years, and our strategies largely mirror the strategies for measurement that are being done in other states. But we understand and appreciate that people want a little bit more time to get used to the benchmark process before these performance improvement plans would go into place. So that's why the 2026 date is in the legislation. And we think that's a reasonable time frame. We will have had 3 or 4 measurement periods by that time. And as I said to you, Senator, we are in regular communication with hospital colleagues about our data. Do we agree on every point of method? We don't. And I think that tension is appropriate and healthy. I will say that OHS has made a commitment to be very transparent in the way that we are making our assessments. We've met with individual hospitals. We've met with hospital systems. We've provided our methodology. So it's an ongoing conversation. I don't know that there will ever be 100% agreement on the strategies, but we are certainly transparent in the way that we're making measures, and we'll continue to have those conversations.
I appreciate that, Commissioner. And as I cited earlier in my compliments to your office, but also for your record of service in managing COVID as the Commissioner of Public Health. I greatly respect your opinion, and so I'll deviate. My third point was on commentary you did not make. One of the cost priorities is regarding healthcare costs, health insurance costs. One of the proposals that we're addressing here today is related to Employee Health Benefit Consortium Association, MEWAS. One of the challenges is that we need to create solutions to be able to make health insurance affordable for the fully insured marketplace for individuals and small businesses. There's been a lot of misinformation out there. I love to be able to get from your expertise and your professional opinion and experience the credibility of the MEWAS and the important role that it has in ensuring that any of pre-existing conditions are covered and that there is no differentiation in regards to health risk management, because these MEWAS are managed by our CID, the Connecticut Insurance Department, and also the Federal Department of Labor's ERISA regulations. I'd love to get your thoughts. I know you didn't share that, but in your expert opinion, what are your thoughts on MEWAS and the importance to addressing healthcare cost affordability?
Thank you, Senator, and I'm grateful for your acknowledgement of our public service. So you're always very gracious, and I appreciate it. With respect to the MEWA, I would offer a couple of comments. First of all, as many of you are very, very aware, last session there were a lot of conversations about getting to a place with that legislation that offered the protections that you referenced, Senator Wong, making sure that people with pre-existing conditions or other high-risk individuals are not disadvantaged. I will defer to my colleagues at CID as to whether the current proposal contains all of those negotiated changes that we worked on last session. But I will say this in general, that fundamentally the challenge we have is that insurance design is not going to fix the problem that we have healthcare costs in this country that are too high. We pay twice as much as our other developed country colleagues for healthcare, and we have outcomes in terms of life expectancy and many other measures of public health that are not as good. So we have a fundamental challenge in addressing the underlying costs of healthcare, and we support changes in the way insurance products are administered and designed, as long as they don't shift those costs onto individuals that then results in individuals having to ration care or avoid care or have their healthcare bills sent to collections, et cetera. What OHS is about is working with our colleagues in the healthcare industry to address the underlying costs of care. So while we work on ways of designing insurance products that address the affordability challenges, we fundamentally need to work on making healthcare more affordable in the first place.
I appreciate that, and thank you very much. And I look forward to working with you and the your department in regards to facilitating exactly that. But also, we're also looking at many other incremental changes, and I think the MEWAS are one of the incremental steps that we can to make healthcare insurance affordable in light of the staggering increases in cost of delivering that cost healthcare. So thank you very much for your time. Thank you, Madam Chair, for the indulgence of these questions, and I really appreciate it. Thank you, Commissioner, for your great work.
Thanks, Senator.
Thank you. Senator Lesser?
Yes, thank you, Madam Chair. And Director Gifford, it's good to see you, and thank you for your testimony here this morning. I have to say I was thrilled when I saw that the governor introduced prescription drug affordability legislation. Long overdue, and it's really important to see the administration leading on this issue. There are some big differences, though, between the legislation before us and that in other states. Specifically, I know that other states have looked at things like reference pricing or setting upper payment limits, and I don't see language along those lines actually spelled out in the bill, although it's not excluded. And I just didn't know, you know, is this just simply a study bill, or is there a direction that suggests to us that there will be at some point real relief to Connecticut consumers?
Thank you for the question, Senator. You are correct that the PDAB envisioned in the governor's bill does not authorize the implementation of upper payment limits or other direct pricing strategies. However, the PDAB is directed to evaluate those strategies both at the federal and state level, as I mentioned earlier, and to make recommendations to my office and to this body about strategies to reduce cost. So it is more than a study bill in that it establishes a commission that is authorized and empowered to gather specific types of information about prescription drug pricing and prescription drug prices. It actually lays out some categories of drugs that the PDAB would be explicitly required to study, those that are over a certain amount, have a certain amount of increase year over year, et cetera, and then make a recommendation as to how the pricing of those drugs could be improved. So it's a hybrid of PDABs in other states, and but goes far beyond just being a study.
And would either of those specific tools that I mentioned in my first question, would those be on the table at the moment for OHS in looking at what other states are doing? Is there anything that's not on the table, perhaps?
Senator, I think we'd be happy to discuss further things like reference pricing. I know that has been contemplated by this body in the past and not enacted. I think that some of the states that have moved forward on that are facing legal challenges, and there may be some benefit to our state in waiting to see how those pan out before jumping into the fray. But we'd certainly be happy to discuss with you further.
Great. I would welcome that conversation, and would just point out that there's a Senate leadership legislation that's along the similar lines that perhaps we could dovetail. Just with regard to affordability and rate setting, this is another issue that folks have been advocating for years, and so really thrilled to see the governor put it forward. How would that work? I understand you're developing the affordability metric, but would the insurance department be empowered to use that metric in rate setting or to reject rates? How would that work on their end?
Yeah. So I will allow my colleague from CID to speak more expansively on that question. But in general, you are correct that OHS would establish and publish through the process I described earlier, through a public process with stakeholder input, establish the affordability standard, what would be measured, how it would be measured, and how the affordability assessment would be done. With each cycle, OHS would conduct the assessment and transmit that information to CID in time for them to make a consideration of during the rate request for that year. Then the language of the bill specifies that the commissioner can consider our assessment in reviewing the rates. So there's an explicit opportunity to make a consideration of the affordability assessment as the rates are reviewed.
Great, thank you. And just in response to Senator Huang's question about MIWAs, I totally agree with your answer that there are real limits to insurance plan design and addressing the overall cost of care. But the safety and soundness of care is certainly or of insurance is important for whether or not people can access it. I think there have been a number of recent MIWA financial issues in New Jersey, for example. Are those things that OHS is tracking, the fiscal underpinnings of the system and potential risk to employers and patients?
Senator, I think I'm going to defer to CID colleagues on those questions. I know that in the early days of MIWA, there were some significant financial challenges that resulted in some federal changes, which are now again being contemplated as being changed. And so it's an evolving landscape. And I think there have been some legal actions as well, some judgments in that, but that is not my area of expertise. So I'm going to allow Jared to answer your your question when he testifies.
Totally fair. Thank you so much, Madam Director. Thank you, Madam Chair.
Thank you,
Thank
Senator.
you. Representative Meskers.
Thank you, Director Gifford. I guess I'll start with an observation on PBMs. I've sat through flow charts on pricing models. And if I can't figure out what's going on, something's going on. So I'm hoping that, as we explore the PBM and pricing transparency, that we get your input on that and thoughts. I'm concerned in affordability. I think the first observation you made, or the last one, I guess, at the end of the testimony, was that the models reflect the costs across the country generically. We're going to adopt best practices, but we'll start with that comment or observation that the costs are rising at a compounded rate that are unsustainable across the country. We're paying twice as much. So I guess I'm a little disheartened, not at you, but if the process, we have to really go outside the box, I think, to get somewhere on pricing and affordability. So along those lines, in your study, are you looking or advocating at all for pricing transparency in procedures, et cetera? I guess that'll be the first question. I've got a couple on the pricing issue.
So the responsibility of the Prescription Drug Affordability Board in the governor's bill explicitly talks about looking at the supply chain,
Right,
and at places where there may be costs that are added that are of no benefit to consumers. So the answer is yes, Representative, that the bill explicitly asks the PDAB to look at those issues and then make recommendations to you and to my office about how to address them.
And in relation to facility fees and hospitals, the same type of pricing transparency are we looking at?
Well, we as you may recall, we passed legislation last session that enhanced our reporting, our ability to oversee facility fees. We will be this year issuing that first report based on that enhanced transparency. So yes, there's additional, and then the provision in, I believe it's SB 210, that adds NPI identifiers and a site of service to hospital billing would additionally enhance our ability to get a handle on facility fee billing.
So on that, when I look at the hospital industry and the business, there's a fairly large amount of mandates that come through the state, and our Medicaid reimbursement rate is fairly low on procedures. And I know we're not maximizing our federal reimbursement. So it'd be helpful within the scope of the research is to look at what the cost would be to increase our reimbursement rate to attract people, maintain the quality of our care, and to make sure that we could maybe reduce the burden at the hospitals so that they're not cost shifting from patients at what I think the average rate is 52% or 53%. So not cost shifting to the fully insured market. I'd like to make sure that we can reduce our costs. And lastly, then, my friends in the insurance industry, if we get somewhere in reducing costs in the hospital industry, I want to make sure that that pass along shows up in the premium dollars. And I'm not sure how we regulate that. We have a perverse incentive with a medical loss ratio, which you only make money if the bill goes higher, in my mind. So I'm not thrilled with this. These are industry structures that I don't think you can disassemble tomorrow, but I've sat through this and I can't figure out why anyone makes money when prices go down, except that my premium might eventually go down, but everyone seems to make more money when my prices go up. So there's a hideous structural impasse in our industry. So I'm not sure how much you can look at that. And lastly, whatever findings you have, I would hope we go through the process in collaboration with our insurance commissioner because I believe he's chairing NAIC now, the National Association. I'd love to see recommendations at the federal level that would get us some solutions, because I understand a lot is outside of our own scope. But if you could comment on, either the hospital issue and, if we could get, I think, a commitment to look, would maximizing the dollar reimbursements shift the cost burden and reduce the healthcare costs? And you look at the net increment that the state would have to pay to get the federal matching dollars. I don't know if I've seen an analysis of that.
So Representative, a couple of responses to your comments. First of all, I know that colleagues in the Department of Social Services have undertaken a rate study. They've begun to share the phase 1 results with this body, and that study will be ongoing. The second thing I'll just comment on is that the widely cited 62 cents on the dollar figure of Medicaid, that's reimbursement as a percentage of costs, does not include some of the supplemental and other payments that hospitals receive. So we certainly want to make sure that we are reporting that number accurately. That comes from a study a report that my office puts together, and we'll be clarifying that number in subsequent years, because I want to make sure that there's a complete understanding of what that does and does not represent.
If I could, just if the case is it's higher, then because of supplemental, I want to make sure that runs through the system in terms of federal reimbursement. That would be my only suggestion.
Yes, everything that's paid through Medicaid gets a match. OPM and DSS are very careful about that. I can assure you. And then with respect to the issue of cost shifting, this is another topic that we discuss a lot between OHS and our hospital colleagues. The fact of the matter is that there is no clear evidence in the literature for cost shifting. I would refer you, for example, to the most recent RAND study, which talks a lot about this issue of cost shifting. That's a study on hospital costs, and really sees no direct evidence. And I will tell you, in our own state, that some of the hospitals with the highest commercial costs have some of the lowest percentages of Medicare and Medicaid discharges. So there may be there may be an impact, and I know that my hospital colleagues will have something to say about this when they testify later. There may be an impact to a certain degree, but not to the extent that there's a one-to-one correlation between the percent of Medicaid and the commercial costs. Furthermore, the last thing I'll say is when we see the percent of Medicaid dollars change, we don't see concomitant changes in commercial prices. So when we've had increases in Medicaid payment over the last, as we have had over the last several years under the hospital settlement, we have not seen a concomitant decline in commercial payment. So that also argues against a relationship between Medicaid payment and commercial costs.
Thank you. Representative Pavlik D'Amato.
Thank you. Just about the Oversight Commission, who would make up that commission? What types of individuals? What would their roles be?
Yes, thank you. So the goal of the commission is to provide additional expertise to the Office of Health Strategy, and to have a more formal oversight process for the benchmark. As we talk about adding additional responsibilities and enforcement authority, Governor's bill really felt like it was important to balance that with some additional statutorily defined oversight. So the individuals on the commission, I believe as 13 maximum, would be appointed by the governor, and they would be individuals who don't have a direct financial interest in the outcome of the benchmark, but they would be experts in their respective field. So for example, experts in health economics, in value-based purchasing, in quality measurement and reporting, in the relationship of payment to different types of payment, like we were just discussing with Representative Meskers, and individuals who understand pricing and payment policy. And their role would be to advise the executive director of the Office of Health Strategy, take formal votes on many of the important policy decisions that we make under the benchmark. For example, I mentioned earlier that OHS has recommended that we modify the 2024 benchmark based on inflation that we experienced in 2022. And this body would evaluate the data that was behind that recommendation and would vote on it, make a formal recommendation to my office. And we would be obligated to accept those recommendations unless within 30 days we provided a written and public reason why the recommendation wasn't being followed.
And has Massachusetts, I know the cost growth benchmark as adopted is very similar to Massachusetts. So as far as the increased enforcement authority and oversight, has Massachusetts done that?
Yes.
Okay, and how is that? I don't know if they've ever spoken about that specifically. I don't recall. I don't think so. So maybe we could have them come, but.
Yeah. So it's reflected in our written testimony. And as I mentioned, they have implemented their first performance improvement plan in Massachusetts. Much of the language that is in the governor's bill is modeled after the Massachusetts strategy. They went a number of years. I think their benchmark program started in 2012, and they didn't implement their first PIP until 2019 or 2020. Those aren't the exact dates, but a number of years elapsed before they implemented their first PIP for some of the reasons that I was sharing. But they did identify an entity that was significantly contributing to exceeding the benchmark in their state. They required a performance improvement plan. And that plan is, as outlined, targeted to save $170 million over the course of the 18-month implementation. So it's a significant reduction in healthcare costs based on the PIP.
All right, I appreciate that. Thank you for your testimony.
You're welcome.
Representative Barry.
Thank you, Madam Chair. Good morning,
Good
Director
morning.
Gifford. My question is regarding 5248, the mandate, the health benefit review. Each year, this committee receives 40 to 50 mandates to review. Lacking an intensive budget cost analysis, how would you recommend this committee to evaluate new mandates?
Well, as I mentioned in my testimony, I think in general, OHS supports the idea that there should be a cost benefit analysis before implementing new mandates. They're not insignificant. And the data supporting every single thing is not equivalent. So looking at the quality of the data, the number of individuals impact, the cost and the downside makes a lot of sense. However, having done that type of work, to do it well requires some time and some resources. So I think one thought would be that there was a built-in lag time between a proposed mandate and its actual implementation that would allow for the study. So rather than proposing a mandate and implementing it in the immediately following the session, perhaps having some period of time and some resources by which CID or OHS or some combination of the two could have a look at the objectively have a look at the risks and benefits of the mandate would seem to make sense.
Thank you.
You're welcome.
We have had all the questions. Thank you.
You're welcome. Thanks for the opportunity.
I just got a call from the principal's office because we have some students that have to get back to school who came here to do their community service and testify on a very important bill. And I would just ask the speakers that were a few before them to sit tight. We'll get to you, but I have to call the speakers up from the school: Morgan Reed, Finian Jennings, Catherine Downs, Elise Suffish, Claudia Panic. Please come up and provide your testimony. You guys can sit on either side too, and you can speak into the microphone. You can start.
Good morning. My name is Morgan Reed, and I'm a student at South Windsor High School, as well as a co-president of the Students Against Destructive Decisions Club. And I'm here speaking in support of House Bill 5249. The dangers of opioid drug misuse are widely recognized. In an effort to reduce the continued danger of unused opioid medications, the bill supports an alternative method for safe disposal. We hope that you will support this initiative. Thank you.
Good morning. My name is Finian Jennings, and I'm a senior and co-president of the Students Against Destructive Decisions Club at South Windsor High School. Our club has worked alongside the Governor's Prevention Partnership since June to learn more about and create a plan for the distribution of Deterra deactivation bags in our community. I'm here to support House Bill 5249 because it encapsulates the SAD Club's goal throughout the entire year, which is having easy access to drug prevention tools, such as the deactivation bags. So having these bags readily available at no cost to the patient makes the process so much easier and more desirable for the patient. There's a huge stigma around drug abuse, addiction, and prevention, and this bill will make a stride towards breaking that stigma. Thank you.
Thank you.
Hello, my name is Catherine Downs, and I am a senior at South Windsor High School, as well as a co-president of the Students Against Destructive Decisions Club. I'm here to speak in support of House Bill 5249. We have been working closely with the Governor's Prevention Partnership for several months, spreading awareness about Deterra pouches. We know that these Deterra pouches are extremely user-friendly and efficient. These will be an important step in limiting opioids coming from within the home, and an issue becoming increasingly present in our demographic. This is one small step that has the capacity to make a huge impact. Thank you. Good morning. My name is Claudia Panic, and I'm a student at South Windsor High School and a leader at SAD Club, also known as Students Against Destructive Decisions. I'm here today speaking in support of House Bill 5249. There's a major outbreak crisis due to the misuse of opioid drugs. In an attempt to reduce the recognized danger of opioid medications, the bill proposes a method for safe drug disposal and ensures that unused opioid medications are effectively disposed, reducing the risk of misuse. This approach will protect individuals as long as the community, making sure there is no contamination from improperly discarded medications. We hope you will take this into initiative. Thank you so much for your time.
Hello, my name is Elise Suffish, and I'm here today with the South Windsor High School Students Against Destructive Decisions Club to express the importance of House Bill 5249. This year, our club has been engaging in acts towards drug prevention, most significantly providing our community with an education on the Deterra drug deactivation pouches. I'm honored to be here to express how passing this bill is not only crucial for combating the opioid crisis, but also for promoting public health and safety for the people of Connecticut. By mandating pharmacists to provide personal drug deactivation and disposal systems to patients at no cost, the bill ensures that unused opioid medications are safely and effectively disposed of, reducing the risk of diversion and misuse. Without proper disposal of these medications, they can end up in the hands of our children and loved ones. On behalf of the Students Against Destructive Decisions Club, this piece of legislation will play a significant role in our battle for prevention and overall promote a safer Connecticut.
Thank you for coming. Before you leave, I just have a quick question, and I think we have some other questions as well. And for those on either side, you can answer by just pressing the button. Are your colleagues in school going into, their parents or grandparents' medicine cabinet and taking opioids and using them for incorrect purposes?
Yes, we see nearly half of kids who get access to prescription drugs and misuse them are getting them from their parents or grandparents' medicine cabinets.
Thank you. That's really important for us to hear. It's really important that after those, we're using them, we teach people to put them into a disposal package so that they are gone, they're deactivated. So your message, we hear you loud and clear. We thank you for sharing it. Representative Delnicki from South Windsor.
Thank you, Madam Chair. And I can't be more proud of you young people coming here today to testify. It's interesting. We received some testimony in opposition to this bill. And it's interesting that a constituent actually went to CVS at Town Center and asked for one of the packets, only to have the person there say, "What are you talking about?" "Oh, I think we got some a couple of years ago or a year ago, but never again." The point being is the fact that you are here, you're testifying, you're making it known that there is a problem, there is an issue, and there is a very simple solution. And I thank you for coming forward, and I really appreciate your involvement in making South Windsor a safer and better community. Again, thank you. Thank you, Madam Chair.
Representative Meskers.
I want to thank you all for coming to testify. I guess my kids are about 10 years older than you. And I don't know that any of them, if they've ever testified in a public hearing up in the Capitol. And, your involvement is super important, and it starts here and starts now. And being here and giving us testimony gives us things to think about. And you do have a voice, and you should see how we deal with the issue. And you're either registered or soon will be registered to vote. And your voice in the process is super important. So being involved, standing up, not just for the issue you care about, but making sure that the people who you elect support the issues and values you have are super important. So thank you for coming. It's a combination. You're taking care of. It's a horrible crisis, the opioid crisis. It's personally affected people that are very close to me. So I'm very sympathetic to this. So thank you for coming.
Senator Anwar.
Thank you, Madam Chair. I just wanted to echo what some of my colleagues have said. So proud of young individuals showing leadership, and we are going to do whatever we can to be part of the solution. So thank you for lending your voice to this important issue.
Thank you. We'll let you get back to school, but we appreciate you hanging out with us.
Thank you.
Next up, we have Sean King from the Office of Healthcare Advocate.
Good morning, Senator Cabrera, Representative Wood, Senator Huang, Representative Pavlak-D'Amato, members of the Insurance and Real Estate Committee. My name is Sean King. I am the acting healthcare advocate for the state of Connecticut. I know most of you know us pretty well, but for others who may be listening, the Office of the Healthcare Advocate, we're here to educate healthcare consumers and members of health plans to make good choices in finding health plans and enrolling in health plans, educating them on how best to use their health plans. When consumers are in dispute with their health plan, we're here to help intervene and advocate on their behalf to resolve denied claims and things like that. And we're also here to work with regulators and policymakers to identify and fix systemic problems in the healthcare delivery and health insurance system. I submitted written testimony on several bills today. I'm here to testify in person, remotely actually, just to highlight a couple of points regarding HB 5247, an act concerning employee health benefit consortiums. Some of the issues, a couple of the issues that I wanted to highlight were touched on in prior testimony. Last year, our office worked with members of this committee and other stakeholders to ensure that a similarly proposed bill included adequate consumer protections to prevent the MWAS, multi-employer welfare plans, from cherry picking good risk and shedding bad risk onto the fully insured group health market. And we're glad to see that this year, this iteration of the bill continues to maintain most of those protections that were proposed and incorporated in last year's bill. One change that we noted between last year's bill and this year's bill is that this year's bill removes some of the specific guardrails that were included in the underwriting protections that prevented drastic over or underpricing of new and renewed business to prevent overburdening risky employers with very high new or renewal premiums. This year's bill replaces that with some more generalized language around underwriting methodologies, but it doesn't necessarily avoid results reflecting in volatility and price disparity for riskier employees and employers that hire riskier employees who have very high health claims and things like that. We understand that the intent of the way that the bill is written this year is to implement methodologies that would curb that volatility and curb the disparity in prices that employers pay into the MIWA. But we think that the bill itself could better express that intent and make sure that the opportunity for MIWAs to price plans in a way that overly impacts employers who have high levels of claims and high risk employees to protect them from that price volatility and those disparities. The second area that we'd like to see some improvement in the bill is regarding the implementation of value-based plan design benefits and contracting. We understand that the intent is to make sure that the design of these MIWAs and the health plans that they put out is to put some downward pressure on prices and to protect member employers and their employees from high prices. We just want to make sure that the language better reflects that intent and doesn't create opportunity for these plan designs to save on costs by restricting access or providing other opportunities to disadvantage the employees and the members of the health plan. Ultimately, what we'd like to see is a design that is going to compete with the level funded market that has infiltrated the state of Connecticut and other states and resulted in a disparity where plans are able to cherry pick risk, shed that risk off onto the fully insured market, and disadvantage employers who have employees that have very expensive claims. And to do it in a way that doesn't undermine the consumer protections that exist in the ACA and that largely exist in the bill as written today. With that, I'll end my testimony today, and I'm happy to take any questions you have regarding this bill or any of the other bills that we submitted testimony.
Thank you, Sean. We appreciate your feedback and comments, and they are absolutely critical to making this bill the best that it can possibly be. And many of the statements that you brought up regarding, cherry picking risk and things are a foundation of this bill, and really having the ability to pool, which means that a small employer, small nonprofit with 5 employees, pooling now with, 500 or 1,500 or even 5,000 people would really help those swings in cost and promote quality in the plans. So we appreciate your feedback. Any questions? Senator Lesser.
Yes, Madam Chair, and thank you, Sean, for your testimony. And, I'm reading through it. One of my questions from the beginning for this proposal has been about how it intends to actually lower costs for market participants. And in your testimony, you argue that the only comparative advantage to fully insured plans will be that they are able to employ underwriting as a means of shedding high cost groups to the fully insured market. So that sounds like cherry picking risk. When you talk about underwriting on the basis of claims history, on the basis of age, on the basis of sex, on the basis of rate, gender, disability status, talk a little bit more about that.
Sure. When we're talking about underwriting, it can be on the basis of any anything that the underwriter deems to be relevant that might impact the cost of the premium. But in the ACA, the parameters that can be used for underwriting are limited to very minor things like age, and where, geography, where the plan is located. Level funded plans have the opportunity, because they're not as regulated by the state, have the opportunity to underwrite based on claims history and identify individuals or employers who have a lot of claims, and to increase the premiums and the cost of the health plan based on the history of those individuals, as opposed to pooling the risk among an entire group, like the group, the community, for example, that the fully insured group market has to have a community rating, and that claims history is across all of the participants, and not just not one individual impacts necessarily the pricing of those plans in that regard. I'm not sure if that answers your question, or if there was something else you were looking for, Senator Lesser.
Well, and are those, so just you outlined that you feel that the bill as written threatens the Affordable Care Act, and can you just sort of to how you feel that happens?
So yeah, so compared to last year, we tried to create some language that would put some guardrails on the underwriting that the MIWA would be able to engage in order to determine how much new participants have to pay. The newly participating employers and their employees would have to pay in order to get covered by the MIWA's health plan. And also that would put guardrails on renewals. So if a health plan that's already participating in MIWA, if they were to have an employee who had a lot of expensive claims over the course of the year, these guardrails would limit the MIWA's ability to increase the cost of that employer upon renewal the following year. Those guardrails, and I forget the specific numbers, but there were specific parameters that were put into the bill last year that would prevent too much volatility, too much of an increase in the price that a renewing participant would pay the following year. That language isn't contained in this version of the bill. However, I do understand that there is some intent that maybe could be expressed clearer, where in that situation where an employer was experiencing one or more employees with high cost claims, they would be able to use a portion of those claims to reprice the employer's renewal cost for the following year, but the rest of those high cost claims will be spread out to the other participants in the MIWA, and would be reflected in the excess or stop loss coverage that the MIWA would be procuring for the benefit of all of the participants. So there is, my understanding, the intent to utilize those types of underwriting methodologies in order to curb the ability of the MIWA to impose an unnecessary level of volatility and disparity on one single employer. We just think that if that is the intent, which we think would help distinguish these plans from level funded plans, if that's the intent, it could be expressed a little bit better in this bill.
In terms of liability to employers,
I had a question earlier of Director Gifford with regards to insolvency of MIWAs. My understanding is that the latest version of the bill does not contain language protecting small employers from liability. So they're potentially unlimited liability through at least through my reading. Is that something that you looked at, or do you agree with that assessment? The new version that's in front of us?
I haven't thoroughly evaluated it from that perspective. I know there are protections in the bill to address solvency, including having the reserves in the capital, and joint and several liability of the participating employers and things like that, are in there and designed and intended to, prevent the situation where, a really, really outlier year results in a lot of high costs and they're unable to pay claims. There are provisions in the bill that are intended to prevent that from happening. I haven't thoroughly explored whether those are sufficient to eliminate that risk, and I suppose you can't really totally eliminate that risk, but to minimize it to the extent that that everybody would be comfortable with it. I might defer a little bit to our colleagues at CID, who have a little more actuarial knowledge and experience to give a better answer to that. But to my knowledge, there are protections in the bill that are designed to address that. Whether they are adequate or not, we could take a closer look at that and get back to you.
Okay, thank you. I would appreciate that. And then lastly, and I want to appreciate the committee's time. One of the questions we've heard is just about a level playing field and whether or not plans that are sold subject to this provision are required to pay the same taxes and fees that exist elsewhere. At least with respect to funding of your office, I know you've been enormously helpful to me and to all of my colleagues in terms of assisting constituents. Are the funds required to pay for the services they receive from your office the way that every other insurance plan is?
Senator Lester, thank you for those comments. And unfortunately, I don't know the answer to that off the top of my head, but I'm happy to get back to you with that. I think it would make sense that that the MIWA would have to contribute equally with the other insurers who offer group health plans in Connecticut, but I don't know off the top of my head whether that specifically is included in this bill.
Thank you very much, and thank you, Madam Chair.
Thank you, Sean, for your comments. I don't see any other questions. Next up, we have Gretchen Schugertz, followed by Senator Kevin Kelly.
Good morning, Senator Cabrera, Representative Wood, Senator Anwar, Representative Berry, Senator Wong, and Representative Pavlak-D'Amato, and all esteemed members of the Insurance and Real Estate Committee. My name is Gretchen Schugertz, and I'm an analyst at the Commission on Racial Equity and Public Health here at the CGA. We're a nonpartisan legislative office and are charged with making policy recommendations to eliminate the impact of racism on health. I appreciate the opportunity to speak today. I'm here to testify regarding House Bill 5247, an act concerning employee health benefit consortiums. Research shows that there are stark race-based health inequities in our state. Data compiled by our commission, DPH, and the CDC confirm the existence of these disparities. Due to racial inequities, people of color have higher rates of chronic disease such as asthma, diabetes, and cardiovascular disease. Plans that use medical underwriting to set premiums are setting rates according to health status, a practice which was discontinued in the fully insured small group and individual market with the passage of the Affordable Care Act. This bill seeks to allow self-insured multiple employer welfare arrangements, or MIWAs, in Connecticut for the purpose of providing health benefit plans to employees of members. It's important to note that federal law prohibits medical underwriting on the individual level, but allows it on the small group level for self-insured plans. This bill would allow self-insured MIWAs to use medical underwriting on the small group level. This is problematic when you think of someone who owns a small business. If this small business owner employs mostly people of color, they'll likely be charged higher rates than a business with majority white employees. Since people of color are disproportionately impacted by chronic disease, if health status is used to determine rates, then people of color are likely to pay more and could be priced out of these plans. The point of underwriting is to assess risk and determine cost based on that risk. It's how you're able to secure savings for some. But those who aren't able to realize savings will likely bear higher costs, and due to current health inequities, the Commission is concerned that this will fall along racial lines. The Commission consulted with in-state and national experts. The consensus among experts is that rate setting by health status will further disadvantage people with disabilities and people of color. If the legislature decides to allow MIWAs, they should not allow rate setting by health status due to the adverse racial impact. We fully understand why businesses may want to participate in MIWAs. Insurance is expensive. We understand that. But a policy that exacerbates racial inequities is not the solution. I want to thank you again for the opportunity to testify. The Commission is happy to be a resource to create a good bill, not just for healthy people, but for all Connecticut residents. Thank you.
Senator Lesser.
Thank you for your testimony. Thank you, Madam Chair. Gretchen, just understanding what underwriting is allowed in the bill. As I understand it, individual underwriting is not allowed in the bill, but group underwriting is, and these might be groups that it could be as small as 2 individuals, 1 individual, very small groups. Is that so? You're saying that because the group underwriting is allowed, and that could be based on health history, that's a backdoor way of reintroducing. And I don't mean to put words in your mouth, but I just want to make sure I'm understanding this, that's a way to potentially bring race-based underwriting into the health insurance market in Connecticut?
That's correct. And it's sort of a way to circumvent the Affordable Care Act.
Okay. Thank you for that. And can you, in terms of one of the issues, and I've been trying to get this answer this morning, but I haven't succeeded yet. There've been some concerns about safety and soundness and potential liability. Obviously, if you think you have insurance coverage and then you go to your doctor and it turns out your insurance company is insolvent, you may or may not be able to get the coverage you were hoping for. So is that something that you've researched? Is that something you can speak to?
I've read the bill and I've looked into it a little bit, and this version of the bill compared to last year's definitely puts a lot more safety measures in place in terms of like fraud and insolvency. However, like we still have concerns about that. And one thing in particular that concerned me was that the MIWAs would be exempt from the insurance, from the Connecticut Insurance Guarantee Fund. So should the company go insolvent, they would be on the hook for the medical claims for its employees.
Thank you very much.
You're welcome.
Senator Anwar.
Thank you, Madam Chair. Thank you so much for your testimony. I just wanted to see if we were to move forward with this bill, what would be the aspects that you feel would have strengthened the protection of the communities that we are all concerned about?
Thank you for the question, Senator Anwar. The concerns are really about the underwriting portion. And as Representative Meskers mentioned earlier, like we have to think outside of the box. And so I don't have an exact answer for that right now. But I could just tell you that it is going to be problematic and disproportionately impact people of color if we start allowing, underwriting at the small group level.
Okay. I mean, your testimony is very useful because I know that the last thing our body would ever want to do is to harm anybody. The purpose is to identify a solution for people who are unable to afford insurance, but also see if there's a way around that. But if it is going to have some negative consequences for some of our community members. I think that makes it challenging. So if there was a way to get a little bit of more work done and then see if there's an opportunity to provide protection, that would be helpful. So I would love to learn more about that if there are some thoughts around that.
Thank you, Senator Anwar. One thing that we've actually been exploring somewhat is the use of possibly ICRA or QSERA accounts, which an employer could deposit money into a specific account for their employee, and then the employee can actually shop the exchange. And then once they do that, then they would have all the protections available through the ACA. But the employer would contribute what they can. There's no, as far as I know, and we're still exploring it, there's no minimum. It's just whatever you can afford.
Thank you so much. Thank you, Madam Chair.
Senator Lesser.
Thank you, Madam Chair, for the second time. There is a language in the bill on page 12 and page 13 that requires that plans state sort of a big bold-face 14-point disclaimer that the health benefit plan is not insurance and is not offered through an insurance company. This health benefit plan is not required to comply with certain federal market requirements for health insurance and is not required to comply with certain state laws for health insurance. Can you speak to, do you know about that section? And does that have legal import? Is there something that we should be considering about that and the protections for both for employers and for employees that that disclaimer offers or takes away?
Thanks for pointing that out, Senator Lesser. I do see the language in the bill, and there's a distinction for the language for employers and then the employee. I'm not an attorney, so I can't speak to the legal aspects of it, but just as an everyday citizen, if I read something like that, I mean, what's being offered is very much sounds like health insurance. And so for the average person, you are getting some kind of coverage, medical coverage from your employer. You think it is health insurance, but it's not. It's a health benefit plan. And apparently that's not insurance. And the fact that the disclaimer is in there is great, but it's also a very long disclaimer that I'm not sure if many people would read. So that's my thought on it.
Yeah, my word's actually the opposite. I think if we had that language out of there, that potentially this plan would have additional federal Affordable Care Act protections that would protect families. And I'm worried that putting that in there expressly says that the intent of this committee and this legislature is that the beneficiaries not receive Affordable Care Act protections. And I don't know that, I'm trying to figure out why that's there. And perhaps there's a consensus that if this bill were to move forward, we could remove that section.
That's a good point I hadn't considered. Thank you for pointing that out, Senator Lesser.
Thank you, Madam Chair. That's all I have.
Thank you. We don't have any other questions. Next up, we have Senator Kevin Kelly on. I'm sorry. I had him next on the list. We have Jared Prosky from the Connecticut Insurance Department. Deputy Commissioner, welcome.
Good morning, Senator Cabrera, Representative Wood, Senator Wong, Representative Pavlak D'Amato, and distinguished members of the Insurance and Real Estate Committee. I am Jared Kosky, Deputy Commissioner of the Connecticut Insurance Department, and I'm here to provide support of the Governor's Bill, HB 5054, an act addressing healthcare affordability. The core mission of the Connecticut Insurance Department is consumer protection, and HB 5054 is consistent with that mission. Specifically, sections 8 and 9 of the bill create a process whereby certain health carriers will annually submit to the Office of Health Strategy a report demonstrating efforts to meet the healthcare cost growth benchmark consistent with specified approaches. The Office of Health Strategy would then provide its findings to the Insurance Commissioner, who may consider the results in conjunction with our existing statutory health insurance rate review process. As required by law, the Insurance Department conducts an actuarial review of health insurance rate filings to determine whether they are excessive, inadequate, or unfairly discriminatory. This existing construct allows the Insurance Department to consider the cost growth benchmark and the proposed OHS report as part of that review, and may provide the department with additional insights as we continue to execute on our mission of protecting policyholders. So thank you very much for providing me the opportunity and support of this, and I'd be happy to answer any questions you may have.
Excuse me. Senator Wong.
Thank you, Madam Chair, and welcome, Commissioner. I want to thank you and Commissioner Mays for all of your hard work as we've traveled throughout the country. The Connecticut Insurance Department has a stellar reputation in the work that you do. So we really do appreciate your work, and your insight as we deliberate is important. So in regards to the discussion in regards to prescription drugs, that is one area that the Insurance Department has not really kind of gotten involved in, and perhaps you can advise us if indeed you have, we missed it, or it is kind of a separation in roles of CID relative to the governor's proposal on the prescription drug panels.
Yeah, so thank you, Senator Wong, for the question. So the sections, I believe, 1 through 3 of the governor's bill is specific to PDABs, which that is under the purview of OHS. With regards to the Insurance Department, we do register PBMs. They are registered with the department, and we do collect data as it relates to rebates, drug usage, and we do provide that report. I believe the first one went out recently to the Insurance and Real Estate Committee with regards to that report. But that's particularly the extent of the Insurance Department's role as it relates to prescription drugs and PBMs.
Thank you. And in regards to establishment of that review panel, what do you say to that as a regulator in the marketplace of being in that position? I know the federal government has some proposals in regards to prescription drug regulation pricing. What do you say to that from a CID role in the kind of regulation of prescription drug pricing?
Yeah, thanks, Senator. It is being handled primarily at the federal level as it relates to the pricing itself in various jurisdictions. Consumer protection agencies are brought in with regards to the drugs themselves. Some states, their insurance departments have more authority as it relates to PBMs. I know Commissioner Mays has made this mention before. That is been brought before various courts. There are concerns as it relates to ERISA preemption of any insurance department that does regulate the PBM industry. So there are some concerns with that authority.
Thank you. It gives me better clarity. I think the other point, if you could, and the important role of the insurance department is for many of our constituents, the insurance marketplace is not always well understood. Could you separate out in regards to a self-insured marketplace and those who regulate it, and examples of who they are, versus the fully insured marketplace in which our CID regulates, oversights, and have the annual rate review meetings that occur? I don't think a lot of our constituents fully understand the differences between the two regulatory insurance marketplaces, and how that fully insured marketplace with the mandates as well as the cost increases that we've seen that create such challenges for individual marketplaces, small businesses, that is addressed by the exchange. Could you explain a little bit the difference in the marketplace and who regulates it and how those costs are managed?
Great, absolutely. Thank you for that question. And I'll say, before I started work with the insurance department, I didn't know the difference either. But the insurance department has authority over the fully insured market. So what that is as it relates to health insurance are those plans where the risk associated with the insurance is taken on by a health insurance company. That is where we have the authority over. The vast majority of people who receive healthcare coverage is either through an employer-based plan, which is the self-funded market. In that scenario, you receive your health benefit. I believe the speaker before me made mention of this as well. It is a benefit, a health benefit. It is a benefit to your employment. The underlying risk of that is with your employer. The employer will oftentimes use a health insurance company to administer the policy, but it is your employer who is on the hook for the risk. Those plans are governed by the federal government through ERISA and through the Department of Labor. The insurance department does not have authority over those plans. In addition, if you receive healthcare coverage through Medicare, that is also a federal program that the insurance department does not have authority over, or Medicaid, which is a state-based program for which the insurance department does not have authority over. Most recently, I would say for those plans that we did a rate review of, it's approximately 190,000 plan members. So roughly 25% of the total insured population in Connecticut falls under the purview of the insurance department's rate review process. We do, however, have financial solvency authority over the companies themselves, so the insurance companies. But as it relates to your coverage, benefits, and rates, it is just the fully insured marketplace.
Thank you for that clarification, and it is important because the regulatory review, as guided by the Affordable Care Act, is what really governs these self-insured plans. Correct?
I'm sorry. Can you say that again?
I guess my point would be that these are programs that are regulated and ensure that healthcare risks and prior existing conditions are to be covered, and they are regulated by the CID as well as the federal government ERISA requirements.
There's a distinction. So for the fully insured market, yes, the rates, the plans are regulated by the insurance department, but these plans must meet certain specifications identified through the ACA for which they need to be established. For the self-insured plans, that is regulated, yes, by the Department of Labor through ERISA.
Thank you. And that clarification is important because in our work in the past number of years in regards to the MEWAs under discussion, it was many conversations with the guidance from CID to be able to craft a plan that ensures all the concerns that were raised relative to health risk discrimination and prior existing conditions coverage, financial solvency. These are the three criticisms that we've heard that has been articulated by opposition to MEWA. Those are three critical issues that are oversight by you and CID, and in some cases by federal ERISA, that could not occur. Would that be fair to say, or is that correct to say?
As it relates to MEWAs, they are regulated. They are overseen by the Department of Labor. However, the Department of Labor has allowed for state insurance departments to have oversight over those plans. And I think that's what you're seeing with regards to the proposal that has been brought to the General Assembly last year and again this year, and what you've seen in states who have adopted and who actually have MEWAs within their states. They do fall under the Department of Labor's purview, but the Department of Labor has identified where the oversight of those entities can be done at the insurance department level within the various states. And that is consistent, I think, with what you've seen within the language of those bills last year and this year again, where the Department of Insurance has the oversight with regards to the financial condition of these entities, including the ability to examine the financial condition of them, as well as conduct market conduct examinations of these entities as well. So our authority as it relates to the overview of financial solvency of domestic insurers within the state of Connecticut in the language of the bill extends to those MEWAs.
Thank you. And I appreciate that clarification because I respect and value the concerns that were raised related to MEWAs. But let me repeat again, there were concerns in regards to health risk discrimination, prior existing conditions being exclusionary, and then financial solvency. All three of those criteria is written into this language upon reading it, and in your professional opinion, those are all governed and regulated with input from our much valued and respected Connecticut Insurance Department. Would that be fair to say?
Yeah, I would say, and Senator, I'll just note that we are still reviewing this year's proposal to identify what, if any, changes that have been made to last year. I think our acting healthcare advocate, Sean King, made mention of some of the items that he noted. We are still doing the review to see if it's consistent with what was proposed last year. Yes, but again, from a policy perspective, I know there was a lot of input from various agencies, along with members of the General Assembly, with regards to the guardrails and what would be included in benefits within those plans. As the insurance department was brought into the conversation, it was with regards to identifying that they would be subject to our market conduct examination, financial review, and I think as was noted earlier, capital surplus requirements, reserve requirements as well.
I appreciate that, and it's important, and I hope that as we move this process along, that we get the guidance and the clarity of the Department of Insurance to be able to address the concerns, and if they be valid, obviously we should address them. But nevertheless, if they are misdirected or incorrect, I would hope that the respect that I have for the CID would be able to address and clarify them as well. And this is part of the public hearing, and I greatly appreciate you testifying and offer your input. And again, my appreciations to Commissioner Mays. And it is important to note that in the state of Connecticut, we should be extremely proud that Commissioner Mays has been elected president of the National Associations of Insurance Commissioners, which is a national recognition, and it's something that Connecticut should be very proud of for the caliber of talent that we have in the CID. So thank you, Commissioner, for your time and efforts, and thank you, Madam Chair, for your indulgence of time.
Thank you. I just have a few questions, Deputy Commissioner, for clarification. Is it correct that the MIWAs would pay the same assessments as all other self-funded plans?
My understanding, if that we're still reviewing, but that was part of the language that was noted last year, was that the assessments that go out to our domestic insurance carriers to fund the insurance fund, and I believe some of the additional vaccination assessments would also be included for the MIWAs themselves. I don't think that's changed.
Is it also correct that underwriting based on race is illegal?
Yes.
Is it also correct, and you mentioned this earlier, that all self-funded plans, including like the state employee plan and the partnership plan, are also not insurance, but an employee benefit?
Yes.
Thank you. Any other questions from the committee? Senator Lusher.
Thank you, and good to see you, Deputy Commissioner. Just with regard to what the state can and can't do, and usually with regard to ERISA plans, we don't have any authority here, but MIWAs are different, and we do have quite a bit of authority. Is that correct?
That's correct. They kind of fall into that area in between, specifically because the Department of Labor has extended an ability of oversight to state insurance departments with regards to those plans and whether or not they use it and can be done. So that is the ability. They fall in that interesting middle area, I would say.
And one of the critical powers of this committee and the legislature is to determine, as I understand it, what is and isn't insurance. And while that power that we have to do that, then the federal government will then come in and then provide ACA protections or not based on that. Is that correct, that we have that power to determine what is and isn't insurance?
The definition of insurance is identified within our statute. That definition of insurance has been reviewed many times by the court system. So there is, as with any basis of law, there is an area of common law, but then there is an issue of statutory law as it comes to the definition of insurance. What I'd say is, with regards to federal preemption of a state's rights to hold insurance, is this identification through ERISA of a health benefit plan and what that actually means.
But going back to my question that I asked earlier of the previous testifier, just understanding the import of that 14-point bold type disclaimer that says this is not insurance. My understanding, and you can correct me if I'm wrong, is that one of the sort of important aspects of that is that federal law and federal protections pursuant to the ACA only apply where a plan is in fact insurance. And that's something where the feds, normally we follow the federal government, but this is an unusual circumstance where the feds are actually following a state determination. Does that sound like I'm on the right track, or am I wrong there?
No, I think you are. I think that there is a distinction. It's based a lot of times on where the risk resides. So it is not insurance because it's not a transfer within an insurance company themselves. But certainly, as we again continue to review the proposed bill right now, we will take that into account. But it is, I think, a distinction between it being the risk still embedded within the entity itself as opposed to another carrier. But you're right, it is not required to be ACA compliant because of the self-insured aspect of it.
If we removed that disclaimer, would that make the plan ACA compliant?
I'll have to take that back. We'll have to review that.
Okay. Now, with regard to the language before us, the bill changed throughout the year, and there was certainly an amendment that many of us saw that came out towards the end of the session last year. My quick reading of the language before us suggests that there are a number of changes between that amendment and the language we have before us. Has the department reviewed the latest iteration of this, and can you comment to some of the changes between what we saw in, I don't know, May of last year and what we're seeing today?
Thank you, Senator. Yeah, we're in the process of reviewing it. I think as the acting healthcare advocate noted, I think they've identified a few changes within the bill, but the insurance department is still in the process of identifying those. And for those that there are changes, identifying what, if any, significance that may have beyond just linguistical changes or something more substantive.
So some of the changes that I've come across, there was something about fully insured MEWAs contemplated under the version last year. I don't see any language along those lines in the version we have today. There was more explicit language about rate setting for small groups by health status, gender, age, and industry. And the plans, I think, in the latest version are not guaranteed in case of insolvency and won't be subject to fees and taxes that other small groups are assessed. So certainly it's written. So I just, are those what you've found, or are there other differences as well that you've identified?
It's still being reviewed at this time, Senator.
Now with regard to the chair's question about underwriting on the basis of race, I agree that explicit discrimination on the basis of race is not permitted. But would you also agree that you can do that by proxy, by looking at claims history, that there are other ways where there will be a strong racial correlation based on medical underwriting, by looking at if you heard the testimony from the previous testifier?
Yeah, no, I did hear the testimony. Potentially, it would be on a case by case basis. It would be something that the department would have to review based upon the policy.
Okay, and then can you just expound a little bit on the qualification about whether or not if an insurance plan issued pursuant to this goes insolvent, whether or not it should be able to access the guarantee fund and have those protections?
Yeah,
and if not, what protections could you assure small business or associations worried about absorbing unlimited risk?
Thank you, Senator. As the version was last written last year, that these plans would not be part of the Guarantee Association. So should a company go insolvent, there would not be that backstop of Guarantee Association protection.
And when you look at the landscape across the country, there have been a number of MEWA insolvencies. I mentioned New Jersey earlier. Is that something that the department has been following?
That one I'm not familiar with. We do know that early on with the creation of MIWAs, I would say in the 1980s or so, there were a significant amount of MIWA insolvencies. That was part of the reason why the Department of Labor permitted insurance departments to have oversight over the financial condition of those companies. But yes, that as with many other insurance companies, that insolvency is a concern, and is, one of the primary charges of this insurance department is not only consumer protection, but the financial solvency of insurance companies.
One last question. Just I heard a question earlier from Senator Wong, and I just want to make sure I understood what CID can and can't do. I think he had mentioned something about the insurance department overseeing or regulating the health risk assessment performed by the MIWAs. I thought your role was limited only to safety and soundness and to the financial aspect, not into specific underwriting. Is that something you would have oversight over, or is that not something you do?
No, it's the financial condition of the companies.
Thank you very much. Thank you, Madam Chair.
Thank you. Any other questions? Thank you, Deputy Commissioner, for joining us.
Thank you.
Next up, we have Senator Kevin Kelly.
Good morning, Representative Wood, Senator Cabrera, Representative Pavlak-D'Amato, and Senator Wong, as well as the distinguished members of the Insurance and Real Estate Committee. It's always great to be in front of this committee. I loved my time on it, and I do miss it. So good morning to everyone. It's been nearly 14 years since the Affordable Care Act passed. But here in Connecticut, we see double-digit health insurance rate hikes on pretty much an annual basis. Healthcare in Connecticut grows more and more unaffordable. Health insurance premiums are the size of mortgage payments. Working and middle-class families are struggling, finding it more and more difficult to find, get, and pay for quality healthcare. That's really unacceptable, and I think there is a better way. Senate Republicans and I have offered policies which, if adopted, will significantly lower healthcare costs for these working and middle-class families. That's real money for real families, real money that can make a big difference in household budgets. One of those ideas is House Bill 5247. A similar version of this bill nearly finished, got it over the finish line last year. And middle-class families were disappointed that the legislation stalled because it had widespread bipartisan and bicameral support. We hope that 2024 is the year that this common sense legislation becomes reality. Why? First, because the small group insurance market is broken and only a few carriers remain active. Because rates have sharply increased in recent years. Because it helps working and middle-class families by helping small business, the state's largest employer and backbone of our economy, to offer more affordable healthcare insurance. Because by allowing small businesses to pool together under the umbrella of a trade association, these groups can pool their resources and risks to reduce cost. Isn't that the basis of the Affordable Care Act? The more individuals in the pool, the lower the healthcare risk and cost. What kind of groups? Groups like the Associated Builders and Contractors, Connecticut Association of Realtors, Connecticut Business and Industry Association, the Connecticut Nonprofit Alliance, the Connecticut Medical Society, the Connecticut Brewers Guild, and the Credit Union League of Connecticut. These groups will be able to create large self-insured health plans for their employees, dramatically reducing costs. These plans would offer high-quality health insurance subject to the same state and federal rules, regulations, and coverage mandates as fully insured plans, but at a significantly lower cost than is currently available in small group markets. And this can be accomplished without public funds or taxpayer liability. And that's really the point of what we as lawmakers must focus on. making Connecticut more affordable, making Connecticut more accountable, making Connecticut more transparent, making Connecticut more focused on the struggles of working and middle-class families. So I thank you very much for raising this bill again once more this year. I thank you for the opportunity to be with you this morning, and I look forward to its progress throughout this legislative session. Thank you.
Thank you, Senator. I believe you are also, when you're not a senator, you run a law practice. Is that correct?
I do.
And how has been offering health insurance as a single law practice been for you?
It's really cost prohibitive. And I've been blessed with either having family who works with me or employees who are covered under a spouse health plan. So we've been able to compensate them to pay for those other policies. But when, as an employer, I look to purchase insurance, it's really cost prohibitive, particularly for businesses of less than 10 people.
We received a lot of testimony in support of this from small law practices, and a lot of the urge for us to take this on was that attracting talent. You really need to provide this type of benefit. Would you say that pooling with the Connecticut Bar Association would give you the ability to be able to offer better quality coverage?
I think it certainly would.
Thank you, Senator. Senator Wong.
Thank you, Madam Chair, and welcome, Senator Kelly. I want to thank you for your length of work on the insurance. You've shared and educated me quite significantly, so I always value your tutelage and insight. Speaking in regards to affordability, can you just kind of refresh to our constituents from your experience and your long standing, the cost increases for the fully insured health plan in the past 10 years from a standpoint of your involvement with rate increases and how it has become beyond unaffordable?
Well, I think, there's no single silver bullet here. I think you have to look at more or less in all of the above perspective. Health insurance and premiums are really a reflection of the healthcare system. And so while we can look at ways to offer lower cost insurance, at the same time, we have to look at also the cost drivers, which is looking at the provision of healthcare and also prescription drug. So that's why in many issues, we've come forward with ways to lower premium. We've also looked at things such as benchmarking and also the cost of prescription drugs, because those are equally as important. If we want to get our hands around insurance, you got to look at the cost drivers. So we need to be persistent in this lane, allowing our small businesses, which employ most of our working and middle-class families, to offer a better benefit to their workers. But at the same time, we also have to be serious about those cost drivers, because that also is part of this equation.
Thank you. And it echoes the same testimony as provided by Dr. Gifford and OHS in regards to this is one part versus the escalating and unaffordable cost of healthcare in itself. And I also want to applaud you the fact that as leader in the past of the Senate Republicans, you focused on that in regards to benchmarking, reinsurance, PBM study reviews, and also really understanding that it is a whole ecosystem. But I wanted to compliment you on your leadership in that arena. But in regards to looking at this as a cost, you've also heard in the testimony some of the criticism of the MEWA program, one of which is that it would discriminate based upon health risks, and number two, that it would eliminate protection for pre-existing conditions. What do you say to those kind of experience from your background and your familiarity with health insurance products in your tenure?
Well, from my experience, I think that is where we as legislators need to step in. It's something we looked at and we've talked about with regards to benchmarking out of the Commonwealth of Massachusetts, where they had a certain experience. But then what we wanted to do is make sure here in Connecticut that we deal with it differently so that marginalized patients don't lose their health care. The same thing would go here. I think that's where, as legislators, we've got to be mindful of what various things can and can't do, but also based on the experiences that we know, make sure that we protect groups and individuals so that along the process, we leave no one behind.
And I think that is the most important role as we've undertaken this, is to create a more affordable healthcare insurance product. Now, the challenge is we've worked and gotten feedback, just as you cite as an example of Massachusetts and its benchmarking. And as we have adopted it in the state of Connecticut, we have learned from the pitfalls and the shortcomings of Massachusetts to be able to build up a more robust and better educated system of efficiency. Wouldn't you say, from your work in the past on this bill, that we have taken feedback from CID, from OHS, from the health advocates, from many of the people, and particularly some of the concerns that have been raised? We have accommodated that to within a uniquely Connecticut MEWA bill. If all of those issues have been addressed and legislatively accommodated and learned and heard from those challenges, why do people still continue to resist this?
Well, I don't know why people do what they do. Okay. But we are blessed in the state of Connecticut with the Connecticut Insurance Department. They are one of the finest regulators in the country, if not the world. And so I'm going to say the aptitude and skill set of that department is second to none. I know that they're currently evaluating, you heard this morning, this same bill. And so as people come forward, I don't look at it with concerns. It's with, I'm going to say, constructive criticism. The people who want to add to the dialogue, I think, is important. I think we need to listen and make sure that anybody who has an issue, that issue is heard, it's made part of the process. And we'll see what the recommendations of CID are. But they are some of the best regulators and will, I'm sure, no doubt, have a good product at the end by the session's end.
Thank you for that input. And I'll close by simply saying we do have one of the best insurance department in the world. And Connecticut, rightfully so, is called the health insurance capital of the world. We have tremendous expertise employing hundreds of thousands of people. This is a MEWA plan that incorporates the best of what we offer. There may be opponents of this that says perhaps a government-run or a one-payer system is a better way to go. For me, I find that difficult, that we don't utilize some of the best talents that we have. Let me be clear. Our insurance companies have a ways to go in regards to consumer responsiveness and accountability and transparency. But nevertheless, they have actuarial experience and management experience that we should tap and utilize to create the best plan that addresses the healthcare insurance needs that we have. So I want to thank you for your testimony and thank you for your leadership on this matter. Thank you, Madam Chair.
Thank you, Senator.
Thank you, Senator. Any other questions? Representative Pavlak-D'Amato.
Thank you. And thank you for your testimony, Senator. I think I've asked this in the past, and so I'm always confused, but the Connecticut State Employee Plan, now, is that insurance or is that technically not insurance?
Well, I don't run the plan, but as I understand it, it is not insurance.
Okay, so that's my
Technically.
understanding too. And I think after several times asking other people, I think we've established that. So it's not insurance either, and it's pooling. And I believe maybe it was 2010, a there was a bill passed that allowed municipalities to also pool, called the partnership plan. Is that correct?
Yes.
I'm sorry, I feel like I'm making this like testimony, right?
Yes.
On the stand, I apologize. But that partnership plan, I think we realized a couple, maybe it was more than one session, a couple years, there was a shortfall in the, I think in the funds for that plan and paying out on claims. If you recall, do you,
Yeah, that's my recollection.
okay. And do you remember, was it just once or was it twice? I'm not sure at this point.
I think there were multiple years.
Yeah, I think so too. And I think there was also money. I'm not sure where this money came from. I want to say 20 million or so that was taken from somewhere to make that plan solvent, if I recall.
My recollection, and you're testing me here a few years, but my recollection is that when you have a government payment program that overruns a budget, ultimately it's backstopped by the taxpayer.
Right.
That's, however you want to look at a general fund and an omnibus budget, at the end of the day, the tax bill falls on the kitchen table of working and middle class families.
Yeah, and so I think I'm trying to wrap my head around. I don't mind as far as the testimony that's happened so far, the questions, the criticism of the plans that were the health benefit consortiums, but at the same time, when the partnership plan has that exact issue, doesn't seem to be a problem. Nobody minds, nobody says anything. And in fact, I believe we put in a bill to, I want to say like audit and review and look into that. And that bill was shot down just last session. So I do appreciate the concern. Nobody wants a plan to go under. Nobody wants claims not to be paid, but I don't know why we hold one standard for this bill and these plans, but not for the state employee, the partnership plan. That seems to get a pass. There's not a problem there. We're just going to look the other way and pretend that didn't happen. So again, I don't know why we can't be consistent in this building, in this room. I find it very ironic, but thank you for your testimony.
Very welcome.
Thank you, Representative. Any other questions? Seeing none. Senator, thank you so much. Good to see you.
Likewise, thank you for the opportunity to speak this morning.
Thank you. Up next, we have State Representative Francis Cooley. Good morning, Representative.
Thank you, Senator Cabrera, Representative Wood, Ranking Members Wang and Pavlock Damata, and the distinguished members of the Insurance and Real Estate Committee. I want to thank you for raising House Bill 5253, an act requiring a feasibility study of the insurance pooling for nonprofit entities. We're going off of health insurance onto vehicle insurance. This has become an issue that was raised to me by Reverend Townsley, who I'm going to turn over to in just a second, about the skyrocketing vehicle insurance rates nonprofits are paying. And in looking into this, every nonprofit that I talk to in my district, including Park in Plainville and the Farmington Seniors Organization, which provides Meals on Wheels in Farmington, said that the insurance rates that are going up so high, they're thinking about actually dropping services. So I think this is a major issue, and I'm hoping that the idea of pooling insurance will allow a method to bring down or control costs that are it's not costing the taxpayers and will benefit the nonprofits. And I think that Reverend Townsley can speak more accurately to this since he's dealing with the situation. So I'm going to turn my time over to him. Thank you.
Thank you, Representative Cooley, and I appreciate Madam Chair and all those on the committee. This would seem to me to be a lot less complicated than some of the things we've been listening to this morning. But I've been a pastor of Central Baptist Church in Southington for 49 years. So we have a bus service where we pick up children. We go to Bristol, we go to New Britain, we go to Waterbury, and some of these come from drug-infested communities and crime-ridden communities. We teach them the Bible, we give them the gospel. We've seen great results to see some of them become very respectable citizens. And, you know, it's a nonprofit ministry. We don't charge anything for it. You know, it's that's what we do as a church, what churches should do. There are other nonprofits which perhaps others will speak toward for handicap, for seniors, for others that have gotten caught up in unintended consequences from a bill that I believe was passed 2 years ago. So it increased the amount of liability insurance to something like $5 million. We have maybe 4 or 5 insurance companies that insure churches. They know and understand all the liability aspects of churches and property and casualty. We've carried $1 million liability insurance for a number of years. It has seemed to be adequate according to their understanding. You know, they're very cautious and would advise us if they felt it was not enough. But the increase to $5 million is, for us, it's a couple $1,000s per premium. For some other churches, it's even more than that. So we would hope that that would be something that could be carved out of that bill. I think it worked fine the way it was before. And I know that would be a help to those that we care most about, trying to help those that are unfortunate, helping those that need help. So we appreciate your time looking into this situation. And again, I think it's a unintended consequence. We are not a mega bus. We do not operate 5 days a week. Sunday morning, other than that, the buses sit there all week, and that's true for many other nonprofits, just like ours. So I believe the liability would be much, much less for us than it would be a commercial bus company that runs their buses every day, sometimes several hours a day, and sometimes from New York to Boston and so on and so forth. So I hope that, and I appreciate Representative Wood is very interested in this, and appreciate all the committee and the work you're going to do on this. So hopefully it'll turn into a bill and be able to give some relief to those that could use it.
Thank you, Pastor. Thank you so much for good work that you are doing. Just have a quick clarifying question. You said from $1 million to $5 million. That's over the course of a year, or over the course of multiple years. And could you give us a sense of I'm assuming you went out to shop around, was it all over the place, or did it kind of stay towards a $5 million range?
So the bill that was passed 2 years ago mandated $5 million liability coverage for bus transportation. So the yearly cost to us for premiums is a little over $2,000 per year. And for others, it's a little more than that, depending on other variables. But it's not the insurance company, it's the mandate from the state that's caused this.
Thank you. Any other questions? Yep, Representative Wood.
I want to thank Representative Cooley and yourself, Pastor, for coming. We brought this issue up at the recent Nonprofit Alliance breakfast, and while it was not on their agenda to discuss this year, it did bring hundreds of nonprofits to the table to share in the story. So we did not realize the intent of this and how wide-ranging this was. So I want to appreciate you both speaking up and bringing this to our attention. You have our commitment to work on it.
Thank you so much.
Thank you. Any other questions? Seeing none, thank you so much, Pastor. Appreciate that.
Thank you.
Thank you, Representative. Up next, we have Michael Azam. Michelle. Oh, I'm sorry, Michelle. Sorry, Michelle. You are showing up on my list. Well, with an S. Sorry, my mistake.
Good morning, Representative Wood, Chair Cabrera, Ranking Members Pavlik, D'Amato, and Wong, and members of the committee. My name is Michelle Azam, and I'm here today in support of HB 5245. I'm joined by Allison Kossip, who's the Senior Vice President of Strategy and Growth for Surest. As many of you know, United Health Group is deeply committed to Connecticut, employing over 6,200 residents and insuring over 580,000. I'm here today to discuss an innovative health insurance product offering and a minor statutory change needed to introduce this product in the large group fully insured market in Connecticut. Surest is already offered in the self-insured market and is growing in popularity with large national clients like Best Buy, Culligan, and Lumen. In addition, United Healthcare and Medtronic, both of which are large employers and state partners here in Connecticut, also offer Surest. We have sought and gained approval in 36 states and the District of Columbia, with more to come. With the national plans and the 37 local jurisdictions, we have over 800 clients and almost 700,000 members. In Connecticut alone, we have over 7,100 members. Surest is a copay-only plan with no deductibles or coinsurance, no gatekeeping or referrals. It is transparent about cost. Consumers choose their provider and they know what they're going to pay for their service before the service. We created this product to respond to consumer frustration about unknown and high out-of-pocket costs in high deductible plans. We want to increase consumer choice. We are not looking to remove plans or force anyone into this plan. But the numbers speak for themselves. Employers are adding Surest to their employee health plan offerings and keeping it after the initial year. And employees like it too. Nearly 20% of eligible employees elect Surest in the first year that their employers offer it, and the numbers grow in subsequent years. The plan is fully ACA compliant, and when approved in Connecticut, it must comply with all Connecticut Insurance Department regulations as well. Introducing new offerings in a state-regulated market requires insurance department approval. In discussions with the Connecticut Insurance Department, we were told that current law would not allow for this product and that we would need a statutory change. Current law caps copays for imaging, physical therapy, and occupational therapy. Like all state laws, and has kind of been discussed earlier today, the law only applies to about 20% of the market. And within that, high deductible plans are already exempt. Given that many, if not most, residents in Connecticut have high deductible plans, it makes the application of the existing statute even narrower. It's a very, very narrow application. In high deductible plans, consumers often do not know how much they will pay for a service until well after the visit. With Surest, members know exactly how much they will pay at the time of service. They choose the service, the provider, the location, and the cost. In addition, copays are bundled for full visits. So for example, for a surgery, all of the surgeons, the facility fee, the anesthesiology, and the imaging are all included in the copay. The plan is
Your 3 minutes are off. If you could please summarize, thanks.
with Surest, employers save 11% per member per month over traditional plans, and members lower their out-of-pocket cost by 54% compared to traditional plans. The statutory change will allow for employers and members to save money while ensuring first dollar coverage. Thank you.
Thank you so much. Any questions? Senator Lesser.
Thank you so much, Mr. Chairman, and it's good to see you both. And I just want to thank you for meeting with me before the meeting and briefing me on this. As the author of one of the imaging laws that you are seeking to be carved out, it did help me get a little bit of a reassurance about what you were doing and understanding that. So I really appreciate it. Just one point of clarification, that we do have some requirements around the pharmacy side of things, specifically with regard to insulin and some other provisions. My understanding is that you're not seeking an exception for that. You're seeking to comply with Connecticut's existing pharmacy rule.
Correct. We will comply with all of those.
Terrific. Well, thank you very much. Appreciate the committee's time.
Thank you, Senator Lesser. Are there any other questions? Seeing none, thank you so much
Thank you.
for coming.
Thank you.
Oh, I'm sorry.
Are you not speaking?
Are you speaking?
I'm happy to.
Oh, I'm sorry. You are welcome to speak.
Well, so we heard from Dr. Gifford earlier, right, about how the balance of affordability and innovation is paramount here in Connecticut. We really think Surest is going to enable us to provide more options and choice, specifically to reduce member out-of-pocket expenses. You heard at the very end of Michelle's comments, right? We're really proud that this plan can actually reduce member spend 54% through the bundling of these copays and the more affordable design of the plan, deductibles are becoming exorbitant and unable for families to manage. I think 40% of Americans can't pay an outlay of $400 for an unplanned expense. The average deductible now is in excess of $1,600. That's the minimum to even be compliant with an HSA plan under IRS guidelines. Surest is a first dollar coverage plan with no deductible, so we fully intend to offer more choice. And I heard the reference earlier to the putting off care that is really happening significantly. And Surest, we find the exact opposite in our experience. Members get 20% more office visits, have an increased utilization of preventative care, and then all the cancer screenings and necessary follow-up care that comes from that office visit with a PCP. We have a nice reduction in the use of emergent care and a corresponding increase in more appropriate sites of care like urgent care on the Surest plan. We're really excited about what this can do for Connecticut. We think it'll be a great option for you all.
Representative Wood.
Hi, thank you. I love the idea of being able to offer more options in this space. I think that the more we can offer here, will just overall help with competition and pricing. Would the plans on the exchange be able to offer copay only plans?
Yeah, I think our hope is to be able to go onto the exchange in the future, and obviously removing this barrier to it would be helpful. Right now, we are focused in the 51+ market, at least at United Healthcare. We are mostly just a self-funded employer option and 51+ at this current time. But our hope is to be able to expand into that space as well.
And I believe when we did meet, you had said that at the end of the year, patients or customers that transitioned from a high deductible health plan to a Surest plan were saving about 20%. Is that still the case?
Yeah, it's actually up to 54%, honestly. The ability to pull the actual cost you're going to have ahead of time to a member makes them make more informed decisions. Like, I can have a better understanding of what having a baby will actually cost me, regardless of what type of delivery it turns out to be. I have an understanding of the additional components of any given procedure, radiology and additional surgeon anesthesia, all of which are balance billed to members now. And all of that transparency and upfront pricing leads members to make the right choices for their family, not reducing care. It actually leads them to seek the most appropriate and more efficient care, and leads to significant reduction in their out-of-pocket costs.
And when I reviewed the slideshow, it seemed like a very technologically savvy way of managing your care. Are there any challenges or barriers, do you think, with older populations with this, or are you seeing that they're also getting on board?
We're seeing them also engaged. I mean, everybody likes to use their phone for everything. My parents online shop for their groceries on their phone these days. I would say we started with trying to make it easy to use via your app. Traditional health plans started with a paper directory of providers and then brought that to the web space. Surest offers the ability to get that price quote ahead of time for any service on the phone. But for those that feel more comfortable speaking telephonically, you can call us and we will walk you through that exact process and provide you all that information on the phone as well.
Great, thank you.
Yeah.
Thank you so much. Any other questions? Representative Barry.
Thank you, Senator. Thank you. It's nice to see you both in person. I've enjoyed our Zoom conversations in the off season, and I'm really intrigued by this product. So I'm happy to hear more about it today. Allison, can you explain a little bit? You kind of touched on this, but how this product is changing things for the consumer, how they're getting the right care at a better price, and increased access to care.
Yeah, absolutely. So we set out to really provide a digital experience that sort of helps members navigate the healthcare system. It's full of gotchas. We kind of heard that all morning here. The idea being I can go in and with easy to understand language, understand what components are going to happen as part of a procedure I'm going to have, whether it's a knee surgery. A nice example that I like to use is having a baby. You can have the best laid intentions on your birth plan about a normal delivery, and life and children sometimes have other thoughts about what that's going to turn into. With Surest, you know your copay ahead of time, regardless of whether that delivery is a normal delivery or ends up being a C-section. The member cost share is held consistent. There is no balance billing on the back end because we know the copay ahead of time. Members find that transparency and that certainty so helpful. It leads them to access care more often. And they have the tools in front of them to have a more informed conversation with their provider about the site of care, the location they're going to have. It also prompts them with information on alternative treatment options for them to consider in case they were debating something more conservative, perhaps. So we think of it as a tool to help them navigate the healthcare system.
And have you heard from businesses and brokers in Connecticut? Is there a demand for this product?
Yeah, absolutely. You heard Michelle mention, we already have 7,000 Connecticut residents on Surest already, either through self-funded plans or fully insured offerings in other states. We have brokers, constantly asking us to provide more innovative options too in the fully insured space. I believe a number of them have submitted testimony to you all in support of the plan offering. I think everybody's looking for more choice. And I think the best feature about Surest is traditional high deductible health plans. And, we're meant to get at consumerism with the tools of, I think of them as a little bit of the tools of yesteryear. We're trying to provide future state tools, and that copay price certainty is something that I think all of us could use when we're accessing healthcare. I find it invaluable to manage the care of my family, and I'm certain Connecticut residents would think so as well.
Great. Thank you so much.
Absolutely.
Thank you so much. Any other questions? Oh. Rep Denning's online. Proceed, Rep Denning.
Thank you, Chairman. Hi, good morning. Thank you for your testimony. I'm going to bring up some things that I had found in our conversation that I'm just a little concerned about. And that is when you have a maximum out of pocket, and then you also have a high deductible, you also have a maximum that you spend over the year. And if, let's say you're on a high deductible and it says when you spend $5,000, you spend no more. With your particular plan, that could be $8,000 to $10,000 to $12,000, depending upon how many people are in the plan. Am I correct?
Single coverage or family coverage, I think you're referencing. We do provide maximum out-of-pockets for individuals as well as families on our health plans.
So for a family.
I'm sorry?
For a family of 4.
We offer a range of coverage from extremely rich traditional plans. We call them A plans in our Surest language, with very, very low maximum out of pockets for those that are looking for really rich benefit offerings, to those on the leaner end of the spectrum. We would offer the full suite of plans in Connecticut, and employers would be able to choose from them. And out-of-pocket maximums range from the very low end of, I think they're 4,000 on perhaps even 2,500 in some of the very rich plans, to much higher numbers in the 8,000, 9,000 range.
So you could have an employer who couldn't afford much for insurance buy not an A plan or B plan, let's say it's a D plan, and tell the employee that, yes, your expenses are done when you have paid $8,000 to $10,000 for all 4 of your family members. You are no longer responsible for any more debt. Am I correct?
Yeah, that's correct. And I think what's wonderful about Surest versus traditional high deductible health plans, like even a non high deductible health plan on average it has a deductible of $1,500 today. That's just sort of the levers used to manage plan design and actuarial value. And on Surest, without that deductible as a barrier to care, members are able to seek care earlier in the year, January, March, the springtime, because they are not putting it off because of a deductible. And then I would say it's a much more steady outlay for the member to understand what the cost would be for them. And then once they reach their out-of-pocket maximum, just like on traditional or high deductible health plans, the rest of the expense would be borne by the insurance carrier.
Except, is there any chance that, I'm sorry if you hear, I have 2 birds in the background. They may be making some whistling sounds.
The sign of spring, it's good.
Yeah, anyway, But we don't have any health savings account that you can put money into to help defer the cost of that. Is that correct?
Yeah, the IRS guidelines require a minimum deductible of $1,600 to be HSA compliant for an individual and $3,000 for a family. So unfortunately, we don't have, IRS, we are not going to be able to be an HSA compliant plan right now. I do hope that will change in the future. And then I'll just say you can have an FSA, a flexible spending account, or a health reimbursement account to pay some of those out-of-pocket costs on Surest. And again, both of those tax vehicles are available to you.
Okay, thank you very much. I appreciate your testimony.
Yeah.
Thank you.
I should just add that one more point that I didn't highlight there. Only 1% of members on Surest plans do hit their out-of-pocket maximum. So that, that cost certainty and more stable copays really help them manage their healthcare, where we see that number much higher in traditional or high deductible health plans.
Thank you.
Yeah, absolutely.
Thank you, Representative. Any other questions? Seeing none. Thank you very much for your testimony.
Thank you so much.
Up next, we have Dawn Holcomb. Dawn here? Oh, she's online. Dawn, can you hear us? All right, we'll come back.
Oh, okay. Can you hear me now?
I can hear you now, Dawn.
Okay, perfect. Sorry.
Go ahead.
Hello, I am, thank you much. I appreciate the time of the honorable members of the Committee on Insurance and Real Estate. I am Dawn Holcomb. I am the Executive Director for the Connecticut Oncology Association. I am a resident of South Windsor. I have submitted written testimony, and I wanted to go a little bit more off cuff here. We do oppose the passage of HB 5054, the Act addressing healthcare affordability, and we oppose it for reasons that you may not feel are conventional. When we take a look, and obviously we care for very vulnerable patients that are in the middle of complex medical disease, and we look at the affordability questions, we see affordability perhaps in a different way than you do. We do see patients concerned about the cost. We see employers concerned about the cost, but we also see middlemen stepping into the process between the providers that care for the patient and when the patient actually receives the product. Those middlemen are adding to the price of the drug as much as 40% or more. And it has nothing to do with what the drug will do for the patient. It has nothing to do with whether the drug is appropriate, is the right decision. And benefit design also comes into play. We are seeing benefit design challenges where a whole new niche of industry, offering supposedly affordable funding programs that will go to an employer and say, we can get you this drug for free. And they then tell the employee that they are not allowed to receive that drug, or they have to wait for this company to do its work. And what it does is it goes out and it tries to secure free drug from the charitable drug programs, which that patient may or may not have been eligible for. So there's a lot of games being played. And what I think we're missing is the fact that we are trying to get the right treatments to the right people. And so I would ask, when we're looking at this question of affordability, are we truly looking at affordability for the consumer? Because if we are, we would have a panel that is full of the people that are caring for the patients, the people that are on the front line saying, this is why we're using this drug, and these are the drugs that are of greatest concern. And by the way, these are the most important drugs they have. We don't relegate, when we're the treating provider, and I'm not a physician, but I represent many, the economic choice. We're looking at the medical choice. And when we create a board of non-medical, non-actively treating participants, not patients, not patient advocates, not consumers, what we're basically doing is non-medical decision-making and relegating this concept of what is intended to heal and help for complex medical situations to a mere question of what does the spreadsheet say? What are the dollars and how are we going to change that without thinking about the impact on the patients and the people? So I would submit that yes, this is the buzzword of the year for many states. They're all jumping onto the bandwagon. We're going to create a PDAB. We're going to create a PDAB. But if you see, every single one of them is different. And not one of them has figured out how to do it really well. And not one of them has figured out how to really have the voice of the provider and the patient. In fact, providers are specifically excluded in this bill language, saying if you're treating, you can't be on the board, as an assumption that the provider is the problem. But it's not the provider that's the problem necessarily. It's all the middlemen. So I have submitted written testimony, but I would like to also suggest that we may not be looking in the right direction. We may not be barking up the right tree. We don't have to jump just because every other state has and spend state resources to make this into a huge exercise and a huge study when the question may already be in front of us in terms of management of PBMs, management of middlemen that are not in the business of actually treating the patient that needs the care. And I know that there are a number of patient advocates that are very concerned that their voice would not be part of this. And to have
If you could please summarize.
okay, and to have a five-person board that are basically economists and not medically involved with patients, have no access to patient records, etc., I think is just jumping in the wrong direction. I appreciate your time. Would be happy to talk about this further. Would be happy to contribute to the discussion and trying to develop a reasonable way to look at this. But I'm not sure that the PDAB is formed here and is being formed in other states.
Thank you. Thank you so much for your testimony today. Any questions? Representative Wood.
Thank you for your testimony. I just really wanted to make a comment that you have made some really credible points here, and we will definitely ask these questions as well and maybe improve the board. Just because this bill is written the way it is doesn't mean this is the final language. So we'd love to work with you to make sure we have the correct voices on the board. So I appreciate your feedback. Thank you.
Thank you so much. Seeing no other questions. Thank you very much, Don. Appreciate it.
Thank you.
Have a good day. Next up, we have Joanne Breen. Is she online?
Good morning. I just got online. Yes,
Good
thank
morning.
you. I guess it's almost afternoon, but I want to thank the committee for allowing me to testify this morning. I'm Joanne Breen. I am a past president of Connecticut Realtors, and I'm a licensed real estate broker. I'm speaking on behalf of Connecticut Realtors, submitting testimony in support of HB 5254, an act concerning broker price opinions by real estate brokers and real estate salespersons. CTR represents nearly 19,000 members involved in all aspects of real estate in Connecticut. Our members work with tens of thousands of buyers, sellers, landlords, and tenants annually. HB 5254 would permit real estate brokers and salespersons to estimate the value of real estate for a fee or other valuable consideration, and to perform comparative market analyses and provide price opinions or estimates of the value of real estate. CTR believes real estate licensees should be compensated for a professional service routinely conducted and widely respected as an expert opinion. There are many instances not related to listing a property for sale when homeowners consult with real estate licensees to estimate the value of their property. In addition to requests from lenders, we often are asked to provide broker price opinions for court proceedings or divorce situations when one spouse plans to buy out the other, in estate situations when one heir is planning to buy out the other heirs and keep the house and not sell it, or when we even get asked to assist with providing comparable sales to appeal revaluations for tax purposes, or simply because a homeowner is contemplating refinancing a mortgage. And before they actually get into the process and start spending any money on appraisals, they want to get a general idea of whether or not they have enough equity. Real estate licensees are the ones who assist clients now in pricing their properties when they're going to be putting the property on the market. And these same licensees should be able to provide and charge for a service to anyone who needs that information for whatever other reason they may have. We are unaware of any other profession which is statutorily unable to charge for a professional service or is required to grant such service as a credit or a rebate to a consumer. Attorneys and lenders can pay for these services, and our licensees should not be required to waive their fees. This legislation will allow Connecticut to join other states in improving the ability of lenders to have access to timely market home price analysis information, which can help both the consumers and the lenders in being able to make informed decisions when transferring property or evaluating their portfolios. This tool would prove to be extremely valuable in the current competitive housing market. Connecticut Realtors supports providing statutory clarification stating only an appraiser may claim to be an appraiser. The proposed language would allow real estate licensees to charge a fee for a price opinion, a comparative market analysis, or a value opinion, and shall not be referred to or construed as an appraisal. Connecticut Realtors strongly supports the statutory requirement that only a licensed certified appraiser may perform an appraisal. CTR requests your support of HB 5254. Thank you very much for your time and attention to this important matter. And if anyone has any questions, I'll be happy to answer them if I can.
Thank you so much for testimony. Representative Wood?
Thanks, Joanne. You spoke about it a little bit towards the end, but can you just share with our committee the difference between an appraisal and a BPO?
Yeah, I mean, most of the time appraisers really are looking at historical data on closed properties. And the purpose of the appraisal is usually because they want to make sure that there's enough collateral in the property for a lender to provide a mortgage on it and not have a high risk. Real estate licensees are often asked to be brought in to determine a likely asking price for a property. We don't deal so much in a fixed number the way appraisers do. Appraisers have to come up with an actual number that they feel is the value of the property. And from our perspective as real estate licensees, we're looking at a range of value. We're looking at what may be the highest and possible price we can get for their property. And while we're looking at historical information as well, we're also looking at market trends, competitive market conditions, and all these other aspects that go into bringing a particular price on a property.
And there would be a difference in price, right? An appraisal is valued, that service would be charged a higher rate than the BPO.
Oh, yes, I would think so. Absolutely. Yeah.
Okay.
And I think that's why a lot of people reach out to real estate licensees to get an idea. They're looking for a range of value. They're not in need. The homeowner doesn't need that absolute number that the bank needs. It's not as scientific a process that we use.
I appreciate that clarification. Thank you.
Thank you so much. Any other questions? Seeing none. Thank you so much for your testimony today.
Thank you for giving me the time.
Up next is Paul Kidwell. Good morning. It's still morning.
Good morning. Is it morning still?
Still. We're hanging on by a thread there.
Good to see you. Thanks for the time. Good morning. My name is Paul Kidwell. I'm with the Connecticut Hospital Association and always appreciate the opportunity to be in front of this committee to testify and answer your questions. Today, I want to touch on three: HB 5054, SB 210, which make changes to the cost growth benchmark, and SB 211, which seeks to study health insurance in the state. CHA opposes those sections of HB 5054 and SB 210 that affect the cost growth benchmark. I think, as you know, CHA and our members have been at the table with the benchmarking process since it was created by executive order in 2020. Our members have served on the varying steering committees and committees that have helped form the benchmark. And so we have a pretty good understanding of the process that has ensued thus far. To that respect, in our mind, before any amendments are made to the existing cost growth benchmark statute or additional authorities are granted to OHS, the real and material deficiencies in the implementation of the cost growth benchmarking process should be addressed. As Senator Huang noted from our testimony, in our view, OHS has yet to implement a reliable data process for accurately assessing performance against the benchmark. If the intent of the benchmarking process is to help guide healthcare policy in our state, then the bare minimum standard for that process must be the use of accurate data. So let me just give you one example. OHS uses data from payers to assess benchmark attainment by large physician group practices and data from the All Payer Claims database to assess providers that OHS has the authority to describe as key drivers of healthcare spending. In both cases, providers don't have access to the granular level data so that they can confirm OHS's calculations. And OHS's answer to the request that at least the APCD data be made available was answered actually yesterday with an instruction that providers should make a request to for the data through OHS's laborious and oftentimes unsuccessful APCD data request process. If this is going to be a partnership about understanding what the data is, then we think at the minimum, the data should be made available to us so we can actually cross-check the assumptions and the calculations that OHS is making that then would have ramifications related to, as this bill proposes, performance improvement plans. Additionally, the benchmark has only been assessed once thus far for 2021. In that case, spending rose 6% from 2020 to 2021. That amount exceeded the benchmark. Taken completely out of context, under this bill, OHS would have had the authority to assess a penalty by imposing a performance improvement plan. Would that have been fair? Our view is that it would have been legal, but certainly not fair, because the year before, in 2020, spending decreased by 3.1%. Why? Because of the impact of COVID in 2020. In 2021, patients came back to get all the care they couldn't get in 2020.
Your 3 minutes is up if you could.
I'll just conclude by, in thinking about what's before you, would you have preferred that healthcare providers tried to slow spending when patients were coming back for care? Because under this bill, OHS would have been within its right to impose a plan to do just that. I'm happy to engage in many questions that were brought up before that you have today.
Thank you very much for your testimony. I think Representative Wood has some questions.
Hi, Paul. Thank you for being here.
Thank you.
So I just want to go back to the accurate data collection.
Yeah.
Or the reliable data process that you had referenced. So you were saying that the APCD data goes in from providers. And you're saying you want to then look, you want to see that to make sure it's what? Like what?
The calculations are actually being done correctly. So for example, in a previous job, I did a lot of, every year Medicare comes out with a rule that says, here's what we're going to pay you for the next year. And Medicare gives providers all the data that they've used to make those calculations. And then every year from where I sat, we actually did all the calculations that Medicare did to make sure that the calculations were actually done correctly. And every year we found instances where there were inaccuracies. And then we went to Medicare, to CMS and said, hey, there are inaccuracies. Can we fix this? We can't do that today with the benchmark. OHS takes the data from the APCD, they draw conclusions from it, present them to us, present them to the committee, present them, and we have no way to determine if they're accurate or not. We don't have the level of granularity to do that. We think that's a bare, if we want this to be successful over the long term, which we do, then we have to come to some agreement around how can we all assess the same data in the same way to come up with the same answers? And then we can draw our own conclusions from that, but we can't even do that today.
Well, I mean, I think you have ears on this committee that hear you in this aspect. I mean, I think all along have been very excited about the idea of the benchmark, but knowing it's going to take time to like ramp up. I'm going to do what I hate to do, which is say, we always look to Massachusetts.
Yeah.
Does Massachusetts benchmark allow, or the benchmarking process have that reliable data component that you're seeking? Because we're always saying, well, look what Mass did, but we should do what Mass does. I mean, is that something that works?
Massachusetts has a much more robust apparatus in place. They have an entire group of individuals who that's all they do. We don't have the same thing in Connecticut. We have a consultant who does much of the work. And certainly there are wonderful staff at OHS, but they're not doing the work on their own. So the comparison between us and Massachusetts, I think, is leaps and bounds different. Certainly, are we modeling the benchmark off of Massachusetts? In many ways, yes. But as far as the fundamental infrastructure that underpins the benchmark, we are not.
Okay, so if the implementation of the PIP was moved out a few years, and you were an active member, you and the entire team were an active member, of getting to a point where we have more reliable data, would you be on board with something like that? Or are you opposed to having a performance of PIP?
Yeah, we're certainly opposed putting something in statute and then hoping that the data becomes better by 2026. Absolutely opposed to that. If we get to a comfort level with the data where we can all agree that the APCD data is open, the payer data is available, and we can work together to assess data together, then we should talk about those plans into the future. But right now, the hope that in 2026 we will, or in 2028, that we will be able to create a process that works is we're not there.
I just have one last question. Have you asked OHS for the APCD data to review or, compare, and have they said,
Yeah.
you can't have it, or we don't do it both ways, or?
Well, for the APCD data, actually yesterday there was a steering committee meeting where this came up, and the answer was either hospitals or I guess CHA could ask for the data through the APCD data process. So that's an application where you specify what you want to use the data for. Then that request goes to a committee of the APCD to decide whether or not you can get the data or not. If they say yes, then we get the data and we could then do the study. If they said no, then what? And so it occurs to us that OHS has absolute access to the data, right? They can use it, they can make assumptions, they can make public presentations. We have a 3 or 4 step process by which we would have to go through to get the data. And that seems incongruent to a partnership where we're trying to actually assess things together.
I don't have any further questions. Thank you.
Thank you, Representative Wood. I have any other questions? I have just a quick couple of questions. I was hoping you could help me. You referenced Massachusetts a couple of times. You referenced a robust apparatus was the word you used, I think. Could you, and you don't have to give me all of it, but could you give me some sense of what you were referring to there when you say a robust apparatus?
So they have an entire a separate entity in Massachusetts that all they do is look at healthcare costs. So if you think about OHS has multiple responsibilities, not just the benchmark. They're responsible for the certificate of need process. They're responsible for overseeing hospital community benefits. They're responsible for overseeing the health estate improvement plan. In Connecticut, with the benchmarking process, we use a consultant to do much of the work of the benchmark. In Massachusetts, they have the Health Policy Commission, and then underneath that, an organization that does all of the analytic work for the benchmark. We don't have that here in Connecticut. So my point is, while we are modeling ourselves after Massachusetts, so says OHS, not in every way.
Mm-hmm. Okay. And that's the approach that you're talking about. It sounds like, and again, don't let me put words in your mouth. Correct me if I'm wrong.
Yeah.
It sounds like what you're kind of alluding to is that the responsibilities of OHS in Connecticut are too broad, and they have too many responsibilities to do it well. And we would benefit from having someone that can do the analytical work in-house at OHS.
I think we would benefit on OHS really focusing on the things that it's currently tasked to do and do them well. And certainly we have thoughts about the certificate of need process.
Sure.
And the energy that needs to go into improving that process. We think with the benchmark, there's energy that needs to go into improving the data analytic process before we give now OHS more authority to do other things. So cost and market analysis in the benchmark, performance improvement plans in the benchmark, subpoena power in the benchmark. Those seem overly extensive compared to where we are today.
Okay, that's fair. Thank you. Any other questions? Someone online? No?
Great.
Thank you very
Thank
much.
you for the opportunity.
Appreciate it. Up next, we have Mr. Jeff Shaw. See you online.
Yes, good afternoon, Senator Cabrera.
Afternoon.
Good afternoon, sir. Good afternoon, Senator Cabrera, Representative Wood, Senator Wong, Representative Pavlak-Tomato, and distinguished members of the Insurance and Real Estate Committee. My name is Jeff Shaw, Senior Policy Advisor at the Nonprofit Alliance. The Alliance is the statewide association representing community nonprofits. Community nonprofits provide essential services to over 500,000 individuals and families in Connecticut every year and employ 118,000 Connecticut workers, or 8% of the workforce, improving the quality of life in communities across the state. Thank you for the opportunity to testify on House Bill 5247, an act concerning employee health benefit consortiums. The Alliance supports the proposal, which seeks to create a new option for nonprofits and small businesses to obtain more affordable, higher quality health insurance for employees. The cost of health insurance for nonprofits has increased significantly. According to a 2024 survey of Alliance members, 74% of respondents reported larger than normal increases to the cost of health insurance for employees. More than 40% of respondents experienced at least a 10% increase in the cost of their employees' health care within the past year. The ability to pay competitive wages and offer adequate benefits, like health insurance, is critical to retaining and recruiting employees to the nonprofit sector. According to that same 2024 Alliance survey, 73% of nonprofits identified being unable to offer competitive salaries as the biggest barrier to recruiting staff. Clinical staff with advanced degrees are moving to private practice, state or municipal employment, or more competitive industries where they will be paid higher salaries for the same or less difficult work. Further, nonprofits are in competition with employers across the retail industry, like Amazon and Target, for positions that do not require advanced degrees. These companies can afford to recruit staff with similar experience and education by dramatically increasing their starting wages and offer better benefits. Without action from the legislature, nonprofits cannot compete. Many smaller nonprofits are struggling financially and want to provide high quality, more affordable health insurance for their employees. Currently, most employers have limited options to purchase health insurance to offer employees. Options on the small group market are limited and costs are high. This proposal could give nonprofits and their workers the same safe and regulated choices that large employers have. The bill seeks to address affordability and quality by allowing associations to band together with their employer members to become one employer, to enjoy the same benefits large employers, unions, and municipalities enjoy in the large group fully insured market. These large group plans are no different than the plans most of the employer market enjoys today. Health plans must abide by ACA requirements like not denying care due to pre-existing conditions. Despite major health gains in health insurance coverage through ACA, many nonprofit employers cannot purchase affordable health insurance in the market. This bill would create more options for small and medium-sized organizations to purchase high-quality healthcare with affordable premiums. Nonprofit employees, many of whom provide essential services on behalf of the state, need and deserve these options. Thank you for the opportunity to testify.
Thank you. Do we have any questions? I just want to go back to the point that you made regarding some of the larger employers that used to not offer health insurance, like Target and Walmart. And the fact that they're doing so now really does show how important it is to offer not only good pay for employees, but the benefits are part of recruitment as well. So how has recruiting been in your industry?
It's a good question. Thank you for it. It's been really difficult, to be quite honest, as many of you or your colleagues who sit on the Appropriations Committee heard over the last 2 weeks. It's really just an ongoing crisis, and it is, not to put it mildly, a disaster, as one of our members was quoted last night, saying nonprofits just simply cannot compete today with what the market is, both for compensation as well as benefits. So again, this proposal just really would create an option that we desperately need to be part of that, funding puzzle.
What I learned at some of the breakfasts that you've held is that those nonprofits that are offering health insurance are offering the high deductible health plans. Do you have any data on how many of your staff in the nonprofit sector are dealing with high deductible plans?
Yeah, we did an industry survey. Again, I mentioned it in my testimony. It was a little bit more broad than that question. So, but I'm more than happy to pose it and get back to you with a better answer.
Great, thank you. Any other questions? Senator Wong.
Thank you, Madam Chair, and thank you, Jeff, and all of your Alliance members for the great work that they do. One of the challenges is we're hearing from so many of our nonprofits that there is a shortage of funding, and that's another area of appropriations, heartbreaking stories. But when we talk about unaffordability, we talk about the escalating cost of health insurance costs. It is a huge impact on your ability to retain employees that you've trained to compete against an unfair marketplace in a dual delivery system that we have in our state, where the state services duplicate our nonprofit work, but the reimbursements and the benefits and the cost are significantly different. What would this plan do to be able to alleviate some of the fiscal challenges that our nonprofits endure, not just this year, but for the past 15, 20 years in regards to trying to make do with less and less. But you now encounter inflationary cost in regards to products, fuel, and all the others that you have no control over. So can you articulate how this kind of a cost savings through an affinity plan can save your nonprofits and in essence be a critical part to survival?
Yeah, thank you, Senator. It's a really good question. And yeah, just the cost of health insurance, as you heard, is, well, as you heard today, or you will hear today, and as your colleagues have heard over the last couple of weeks, is one of the greatest costs in retaining and recruiting the workforce. Just last night, an insurance broker from NFP spoke about 20 to 40% increases that are likely to be up for the July 1 renewal period, with an average increase at the cost of 25%. That alone, has eaten up any previous increases that nonprofits have received over the last few years. So, this new plan really has some promise that we can actually have some really high quality, affordable plans. Again, just, through pooling and, through that buying power that will hopefully really, chip away at that, at just the enormous increasing costs across the board that make operations just a constant struggle. So we think this is a really promising proposal, and hoping to be part of the final group that works out the kinks as we go along.
Now you represent Jeff. Can you just educate the broader audience what the Alliance represents, the number of nonprofit organizations and the number of employees kind of encompassed in the Alliance? And after you shared that, I think, as you've also heard some of the issues and concern raised related to MEWA in regards to health risk discrimination, pre-existing condition exclusions, and fiscal accountability or insolvency. These are all critical and important matters. And for you as an organization that represents that large group and a lot of our nonprofits, you would have never supported anything that does not ensure that those concerns are addressed. Would that be fair to share? But share with the broader audience what the Alliance represent in regards to the vast impact that you have for our nonprofits, big and small, that are the very essence and fabric of our community.
Yeah, sure. Thanks, Senator. Great question. Thank you for the opportunity. Yeah, for those that don't know, we are a membership organization. We have about over 300 member organizations throughout our statewide membership network. And that translates, I was talking to our Vice President of Administration and Finance last night. We could think of probably employees between 10,000 to 30,000 And there's plenty more that are outside of our network, which we're eagerly and always actively recruiting. We'd love to have as part of our group. But yes, to your sort of second questions, we firmly believe in the protections and want to work with any parties with concerns about how to get to a place where everyone is comfortable moving forward. Again, health insurance has just been a huge cost for our members over the years. We hear it every year. And we want to do something for them, and this bill really has some promise to perhaps alleviate, that just massive increase in their costs. And again, it just goes back to what you said earlier with the ongoing funding challenges. And we can't compete at the moment with the broader marketplace. And if we want these services to continue, again, services that our members provide, 500,000, we serve 500,000 people annually. Can't do that without staff. We need to be able to retain and recruit them. And hopefully this bill is a piece of how we can do that moving forward.
Thank you. And I appreciate that. And I appreciate the great work that the Alliance does in giving a greater united voice for many of your members. And that being said, I think it's important. Your voice is welcome as we kind of evaluate this and fine tune this to ensure that all the concerns and uncertainties are addressed. But to get to the bottom of it, why you're here speaking in support of it is the fact, plain and simple. Whether you get the funding from increased appropriations, and we'll work really hard because our nonprofits deserve it. But nevertheless, even if you get an incremental increase in regards to your funding, you're still struggling with double-digit healthcare cost increases every single year. And I think the critical need for this program and why you're testifying in it is we have to do something to be able to create some sense of cost stability for our nonprofits to not only operate, but in some cases survive.
Yeah, thank you, Senator. That's absolutely right. Stability, certainty, as others I'm sure would agree, would be very helpful in this increasingly challenging world. And yeah, again, in that survey that Representative Wood you asked alluded to earlier, one of the things we did find that I think it was close to a third of nonprofits did report trying to increase the employer contribution to avoid increasing the employee contribution to their plan. So, they're really trying to, but at some point you just can't do that anymore. And then, your benefit plans will be reduced, or you're going to have to ask employees to pay more, which no one wants to do when, again, you're trying to retain, if not recruit a staff to fully staff programs that people need. So again, it's a piece of the puzzle, and we're hoping it'll prove promising as we move forward.
Thank you very much for your efforts, and again, my awe of the nonprofits that do great work in our community. They're truly community partners. So thank you very much for your time, and thank you, Madam Chair, for the indulgence of time.
Thank you. Thanks for joining us, Jeff. Next up, we have Kim Daigle.
Afternoon, Senator Cabrera, Representative Wood, Senator Wang, Representative Pavlock-D'Amato, and distinguished members of the Insurance and Real Estate Committee. My name is Kim Daigle, and I am here in support of HB 5247, an act concerning Employee Health Benefits Consortium. I am the president and CEO of CU Insurance Solutions, and I am also the plan administrator for a MIWA in Maine called the Maine Credit Union League Insurance Trust. 5 years ago, we created a MIWA in Maine, and it allowed our Maine credit unions to come together to buy insurance as a large group to help stabilize the large increases that we were seeing in the marketplace. Our successful nonprofit, self-funded MIWA, is currently helping 26 of the 48 credit unions in our state by insuring over 1,000 credit union employees and their families. I wanted to provide some background on how we created a successful MIWA in Maine. First and foremost, it's important to know that our plan is regulated, highly by the Bureau of Insurance, which we appreciate. Before starting our MIWA, the Bureau of Insurance required us to complete many items in order to ensure getting a license to open our MIWA for our credit unions. We had to hire an actuary to assist with the rating methodology. We hired a third-party administrator, which was Anthem. We purchased specific and aggregate stop loss coverage so that not one claim could sink our MIWA. When the credit unions joined our MIWA, we asked for 3 months of reserves to make sure that we remained solvent and able to pay claims. Each group that joined had to sign a participation agreement that requires them to stay on the plan for 3 years, which helped us provide stability in our plan. We also had each group that joined share financials with us, which were audited by our accounting firm. This was to make sure that each group was in a good financial position to join. We created a board of trustees, and we also maintain the proper insurance to make sure that we're protecting our members and our board as well. Now that our MIWA has been running for 5 years, we work closely with the Bureau of Insurance, and each month, as a fiduciary responsibility, we collect our premiums from our credit unions and pay the claims. The Bureau requires us to send financial statements once a month, and on an annual basis, we are audited by our accounting firm and asked to complete a risk-based capital ratio report to make sure that we're doing everything that we need to do to have a successful MIWA for our members. I'm happy to report in the last 3 years, we've received approximately 6% in increases, which is far below what our credit unions were experiencing in Maine. And this association plan has been very important for our credit unions. This year, we're pleased to say that we were able to issue a rate hold for our members, which was very exciting. And I've been asked the question, did our credit unions save money joining this plan? Yes, they did. And lots of instances, it's allowed them to even receive better benefits that they were receiving before. So we're very pleased.
Minutes are up, if you could please summarize.
Certainly. So to say that this plan has helped our credit unions is absolutely true. And I'm able to answer any questions that folks might have.
Thank you for coming. Your perspective is valued, and we love looking. And you have met with our committee and provided a lot of insight that we've included in the bill. We heard earlier concerns about liability, and I was wondering if you can go into a little bit how the stop loss works.
Certainly, that is such an important piece because you want to make sure you have money to pay claims, and knowing that claims can be so expensive and pharmacy benefits. So basically, our stop loss has 2 components to it. It has specific stop loss coverage with a $240,000 deductible. So what this means, let's say one of our employees in a credit union has a $2,500 deductible plan. And let's say they're very sick and they have a $2 million claim. The employee would be responsible for their deductible of $2,500 on the plan. Our plan, from the premiums we collect, pay up to $240,000. After that, the specific stop loss insurance picks up the remaining balance. So no one claim can sink our plan within a given year. So that piece is important. We also have aggregate stop loss, which provides coverage after 125% of expected claims. So even if you're having having a bad year, you have that protection in place. So that's an important piece when it talks about insolvency. You have to have the right coverage in place to make sure that doesn't happen. Thank you for asking that question.
Thank you. And can you explain a little bit about the plans that you offer? Because what we wrote into the bill is the minimum of the bronze, silver, and gold plans. But are you able to offer those or even better plans to your members?
Yes, we certainly do. So we looked overall what the plans were, what the credit unions had in the state before we started this. We offer 4 different plans. We offer 2 traditional PPO plans with co-payments, and then we also offer 2 HSA plans. So the participants can pick from any of those plans.
And you had said before that your plans are regulated by the Maine Department of Insurance. which is great. We took that, you know, as well and put in that the Connecticut Department would also regulate these plans. But, you know, just going a step further, do your plans cover things like preventative care?
Oh, certainly. That's important. These plans are meant to protect our members and keep them healthy. So we do follow the American Medical Association guidelines for preventative care. And I may also want to add that, interestingly enough, our population in Maine and the credit union movement is 77% females. So one of the things that we're adding to our plans for January 1st is an enhancement to preventative care. So let's say somebody goes and gets a mammogram done and it's considered preventative, but they get a call back and say, you need to come in for a second mammogram. At that point, it becomes diagnostic. And on many plans, that would be subject to your deductible. We are going to be waiving that piece. So it wouldn't be subject to deductible because we want to make sure that people are getting the care when they need it.
I think that last point is really important. And, you know, really the federal government is requiring that these plans, you know, look at the data from the utilization from their employees and conform in the way that you had suggested. I mean, every plan is going to be different based on the population. So I'm really glad that you hit on that part. Do we have any other questions from the committee? Senator Lesser.
Yes, thank you, Madam Chair, and thank you for your testimony. You know, I appreciated your testimony about the solvency of the programs, and I'm looking at the protection of stop loss coverage. But I'm really concerned though about a potential insolvency, and I'm looking at a press release not from Maine but from New Jersey from September of last year, and it's titled "Banking and Insurance Commissioner Issues MEWA Caution: Self-Funded Plans That Become Insolvent Leave Patients with the Bills." And it specifically talking about two self-funded MEWAs that collapsed recently in New Jersey, the New Jersey Coalition of Automotive Retailers and the New Jersey Licensed Beverage Association, that were expected to leave claims in excess of $20 million. Those claims will either be paid by covered persons or participating employers themselves, or they will be absorbed by the doctors and hospitals. And just specifically with regard to the members that you represent, are there specific steps that you've taken to limit potential liability to your members, to, you know, because if one of these funds collapses, the potential liability, by my estimation, at least under the Connecticut legislation, could be unlimited. And I'm wondering how you manage that risk.
I have not had a chance to read that article, but I do think it is important to make sure, you know, to understand, did they have stop loss coverage in place and what were their deductibles on that plan? Actuarially speaking, it would be close to impossible to run the plan into the ground in 1 year with these claims, given our $240,000 deductible. So I'm just curious as to what they had in place. We had one bad year, and we did have to give an increase that was larger than we anticipated. However, we still had money to pay claims because of the reserves we had and that stop loss coverage in place. So without reading that report, I don't know whether or not they had those stop gaps in place.
And what, but specifically with regard to the steps, so you're in terms of protecting your members and assuring them that in the event of insolvency, they won't be left holding the bag. The only mechanism you have currently is stop loss coverage.
We also, in our participation, have joint and several liability for the groups that joined. So that's why looking at their financials before joining is a very important piece of that, because the joint and several liability.
And do you have access to the Maine Insurance Guarantee Fund?
It's interesting you asked that. We do not have access to that, actually, but we do pay into it. So the MEWAs in Maine are actually paying a PM fee for that to the state, but we are not able to access that.
Okay, thank you very much.
Thank you.
Great, Kim, thank you for joining us.
Thank
Next
you.
up, we have Rachel Diamond, followed by Ava Bermuda Zimmerman. Next up, we have Ava Bermuda Zimmerman. Welcome.
Representative Wood, Senator Cabrera, Senator Lesser, Representative Barry. Thank you for having me, and distinguished members of the committee. I'm here representing Childcare for Connecticut's Future. We're a coalition of childcare providers, parents statewide, with over 70 different nonprofits and organizations that represent providers and parents and parent voices, all with the sole focus of making sure that childcare here in Connecticut is affordable and that the workforce that is supporting childcare also has access to affordable health care, has access to affordable wages, livable wages, and can really sustain the childcare education system that we have here in Connecticut. I'm here to speak in regards to House Bill 5247. Right now, the childcare workforce has been in crisis for over a decade, really looking for ways to survive and continue providing the very helpful and resourceful educational curriculum that they give to children every single day. But unfortunately, one of the things that are looming on the back of the minds of the childcare providers is health insurance, not having access or not being able to really pay the full cost of health insurance. When we're talking about the childcare workforce, I'm also coming from a place of personal responsibility and knowledge as a childcare, someone who was a sister navigator for several years in the state of Connecticut and has individually signed up 15,000 people here in the state, most of them being childcare providers throughout Access Health's creation. I can tell you most of those providers, unfortunately, were not able to qualify for Access Health CT. Most of them are home-based providers. A lot of them are owner-operators. They do not have affordable resources through Covered CT or Access Health to really navigate the healthcare system that they need. With that said, I do appreciate the committee's creative solutions that they're coming up with to try to tackle the healthcare insurance crisis and give small business owners like childcare providers and home-based providers access to healthcare. But when you look into different legislation that you're trying to navigate those healthcare disparities, I think it's very important that we take in consideration that we're not dismantling existing systems that really do help people. For example, in 5247, when you're looking at lines 173 all the way to line 184. It's a little concerning that it's leaving some language for interpretation and possibly even dismantling some access that we have through Access Health and programs that currently exist. To be more specific, the line item, I'm just going to open it up here, that says on 184 and 185, not limit or excluded coverage for any individual imposing pre-existing conditions or provisions. The not limit or excluded leaves a little that vague area. We want to make sure that legislation like this, if passed, really does have access to language that doesn't circumvent the Affordable Care Act or Access Health Care CT. Right now, Access Health does allow for visits that are completely covered by insurance companies that have pre-existing conditions, and that's not something that we want to dismantle. We also want to make sure that any language in the legislative bill in the proposal really takes in consideration healthcare discrimination, make sure that any healthcare risk and any, again, pre-existing conditions are not part of the proposal. So we do appreciate the creative solutions. We do want to make sure that childcare providers in a whole have access to health insurance that's affordable, that they can actually use. Right now, as I mentioned, that's not quite the case, but we would like to see some amendments and some new legislative language that will get us to a place where consortium is a solution. Thank you.
Thank you for your feedback. So can you just tell us, like, for a childcare provider, how many people are employed, or a range? Like, what is the size of the current business that's trying to provide health?
So for a home-based provider, there is a state requirement that if you have up to 9 children in your space, you have to have at least 1 employee. I would say most who have a full house are looking at 2 to 3 employees. Some childcare providers, home-based, that are providing round-the-clock care, 24-hour care, they're doing different shifts, have even 5 employees because they're trying to make sure that there's enough people there during the shifts and they're still incorporating those 9 kids in each shift. For childcare centers, it varies. Those numbers are much higher because it's by square footage of the space. So you could have a childcare center provider that's a small business owner with just a minimum of, 5 employees to cover each classroom. But you could also have childcare centers that go all the way into 60 to CLC in Stanford or HRA New Britain that have 100+ employees.
So does the child care industry have a consortium or an association that could potentially, allow the pooling?
As of now, there is nothing that exists in that range. There's been conversations in the past few years, specifically with the Child Care Union, of creating a early ed childcare workforce healthcare trust, where you can allow supplemental costs to be covered through Access Health CT or Covered CT through public funding, but that's still in conversation.
Okay, great. I'm glad that you noted that, this is just one bill. But we are looking at other options. I think you heard from some of the speakers that were here earlier on a copay only model. We're always looking to strengthen the exchange. The exchange is working on additional plans and solutions for small groups. So there's not one thing that we're investing all of our energy in, but we're looking at creating more options in this space. And I appreciate the feedback on the childcare industry, because we haven't had you at the table before, but we want to make sure that any of these options could be available.
We appreciate that the committee is tackling the conversation and is incorporating the voices of early childcare providers. And because there isn't one solution right now that's accessible for childcare providers, consortiums seem like an exciting idea, as long as it's not in the backs of existing legislation that is supporting the workforce.
Perfect. Any other questions? Thank you for your time.
Thank you.
Next up, we have Kevin Zingler.
Good afternoon, everyone. My name is Kevin Zingler. I'm the president and CEO of Mark Inc. of Manchester. We're a nonprofit organization that supports people with intellectual disabilities with contracts through the State of Connecticut Department of Developmental Services. I'd like to thank the committee for inviting us here today to testify on 2 bills. The first bill is HB 5247, an act concerning employee health benefit consortiums, and House Bill 5253, an act requiring a feasibility study of insurance pooling for nonprofit entities. These are 2 things that we've been struggling with as a nonprofit provider. It has been a very costly process for us over the last decade in terms of health insurance. We always, when we have our meetings with our brokers, we always say that before the train goes off the rails type deal, how much can we afford to keep this affordable for us? And it's becoming more and more of an issue, and we want to do what's right morally and ethically to provide great health insurance, great coverage to the great people who provide services to the intellectual individuals that we support. I just wanted to provide you a little bit about our experience. Until 2022, we were a fully insured employee benefit plan, and we kept facing double-digit increases year after year with little to no explanation, no transparency. We were under the 100 group. We were only 56 lives, or I'm sorry, 64 lives that we insured. So therefore, it was like we were going to, just pay for those claims and not know why we were paying for those claims and why we're getting these double-digit increases year after year. In 2023, we moved to a self-funded plan model as claims data supported the move. As we started talking a little bit more about, a level funded plan, as we started talking about, how we could maybe control some of these costs. So in 2022, we went to a level funded plan to get some more transparency. In 2023, we actually moved to a self-funded plan because we started getting some of the claims data, and we understood why one insurer, one carrier was double-digit increases, and another one was 4% increase. So we knew that the claim data was going to support what we were trying to do. We also, during this time, approached the Office of State Controller to join the Connecticut Partnership Program. And we were told as a nonprofit entity, we were not qualified or eligible to do so. Here we are trying to use state dollars to stretch our money to stretch our benefits to provide better care and quality of services, but we were informed we were unable to do so because we're not quote unquote legislatively a state quasi organization. Which we thought was odd because we've been using the state contracts for years to purchase things, supplies and things like that off of DAS contracts. So that's something that I just want to bring to your attention. I think needs to be looked at is why this greater pool couldn't be available to us to help control our costs. So despite these efforts, House Bill 5247 will allow us and small businesses and nonprofits to unite. We are a member of the Alliance. We are a member of ARC Connecticut. We've always talked about as executive directors, why can't we just pool our claims, our costs, and have that greater pool? Why can't we take that wholesale BJ's, Costco, Sam's Club approach to buying health insurance? Why can't we be under the state model, if you will, and utilize those tax dollars as wisely as effective? We're not insurance folks. We're not brokers. We provide services to people with intellectual disabilities, and we do a really great job at doing that. So how can we take that burden off of us? So those are the things that I wanted to just bring to your attention. Just last year, we saw a 20% increase in our insurance costs. And these, although we've received monetary assistance from the legislature and through DDS.
This is up if you could please someone.
Yep. As we move forward, we are looking for ways to basically pool our resources, whether that be health insurance or regular general insurance, to ensure the viability of our services in the future. Our employees are the ones who are providing those services. And if we don't have employees, we can't retain employees. We can't provide services. That's the nutshell and everything we do. So thank you to the committee for allowing me to testify.
Thank you. And thanks for shedding some light on, what you've had to do every year, which is shop around for new plans. I mean, the goal of providing, predictability and quality over the long term is really part of the, Employee Health Benefit Consortium bill, so that you can focus on providing your services. You shouldn't be focused on how do we, come up with a new health plan for our employees every year. I mean, I can't even imagine the administrative burden and time that, just dealing with that has taken. So thank you for sharing your story. Any questions from the committee? Representative?
Thank you, Madam Chair. Thank you, Kevin, for being here. It's always good to see you. One of the things that we are hearing a lot about in the nonprofit realm is recruitment and retention. How has that affected your organization, and how does that affect, or how does offering good healthcare affect the keeping of employees?
Sure. Our employees are living paycheck by paycheck. They need desperate wage increases. And I know we had appropriations hearing yesterday, and we were here till 2 or 3 in the morning to do that. It's a struggle. Prior to COVID, we had about 10 to 15 applications a month. Now we have 2 to 4. And people are looking at other ways that they can get higher paying jobs in this field or in other fields, unfortunately. And a lot of folks are in it for the right reason. They're passionate about providing services, and they're really great caregivers, but they have to put food and turn the lights on at their house, and they have to make ends meet. And that's what we're seeing is that struggle. So recruitment and retention has been huge for us in terms of trying to keep services. We're contracted to provide X amount of services, X amount of hours per week, X amount of days per week to this individual. And it's costing us an overtime because staff are leaving and going to other places where they can make more money.
Thank you.
Yep.
Senator Lesser.
Thank you, Madam Chair. Thank you for your testimony, Kevin. And first of all, I'm cognizant of the fact that all the arguments that you made are unimpeachable, right? The status quo is unacceptable and doesn't work for your employees. And if the question is change versus more of the same, anybody would say we need to change something. But I also take to heart your comments that, your mission is social services. It's not, you're not in the insurance business.
Right.
And yet, when I look at this legislation, it actually seeks to empower you to set up an insurance company, and not fully licensed insurance company, with all of the risks and potential liability attached to that. And so while I fully acknowledge that the status quo is broken and is not serving your needs, and we need to find affordable health insurance options for everybody in the state, I'm questioning, is that moving in the direction of setting up your own insurance company seems like a potentially perilous decision. And is that something that you wrestled with or have thoughts about, you know, are you looking for more options, or is there something, is this particular option particularly attractive for something?
I do like, I mean, we have talked about, thank you for your question, Senator. We do like the idea of pooling our risk because we are such a small, we only 64 lives we insure. So therefore we're a small ocean. We're a small drop in a pool, if realistically. If we could pool that with a larger risk through the state of Connecticut, through the Alliance, through the ARC Connecticut, through another trade organization, that would give us some flexibility and have us be more stable in that realm. I agree with you. I'm not looking to set up a insurance company as us for not marketing of Manchester, but I do think that there are resources out there where we can piggyback off of other systems that are already up there, other options that could help us out through this process. And through the shopping around, we thought it was first a broker, book of business, you know, that type of deal, because we thought we were getting steered towards different carriers because of the do not quotes we were getting back. And we knew that there was books of business, and that's really what we were being told, that, you know, everyone has their own relationships and that's how the world goes around. And we understood that. But at the end of the day, I need to provide health insurance to 64 people, and we're not the big fish in the sea, if you will. So that becomes a very tedious task, a very costly task. Our insurance has pretty much gone up 40% over the last 6 years because of that process. And we just keep using taxpayer dollars to try to fund those shortfalls and fundraising money. How many fundraisers do we have to have health insurance?
Well, without beating a dead horse, we did have a bill a few years ago that would have allowed you to pool risk through the state, but obviously the status quo is not working, and I think that that's important. I would just suggest that maybe one other option that this state should look at would be supporting the existing small group market and finding ways to bring down and stabilize the market. And I think that may be something that perhaps all sides could get around.
You, Representative Pavlik Tomato.
Thank you. I just want to thank you for your testimony and giving, I think you clearly discussed what you go through as an organization. I know my family has a small business. I am a solo practitioner, and also, so we deal with these things all the time, and it's nice to hear your perspective and keep, you know, for us to keep in mind that it is happening to different organizations. And it has always bothered me that organizations have to pay taxes and then pretty much go back to the state and beg for money, beg for your own money back, right? And then beg for money for increases that aren't your fault, that really are our fault. And I have to say also, the previous speaker, when it comes to daycares, I mean, they just can't compete anymore. They can't compete with the public schools or with the town funded and town run, you know, preschools. And people are leaving. I mean, it happened to my son, lost several teachers, and I just can't imagine an organization such as yours not being able to provide the services that you do. And you made a great statement, you know, how many spaghetti dinners can we have, or how many, you know, whatever fundraiser that you have, but you can only do so much. So I really appreciate you coming up, and I think your testimony had a big impact on us. So thank you.
Thank you.
Kevin.
Thank you.
Next up, we have Mary Claire Capetta.
Hi, good morning. Can you hear me okay?
Yes, we can hear you.
Okay, great, thanks. So Chairpersons Cabrera and Wood, ranking members Wong and Pavlik Tomato, and members of the committee. My name is Mary Claire Capetta. I'm the Public Policy Chairperson for the Connecticut chapter of the American Physical Therapy Association. I also serve as the interim director of the Doctor of Physical Therapy program at UConn. Thank you so much for the opportunity to testify today to voice our opposition of two particular sections of HB 5245, specifically sections 2 and sections 4. We strongly support price transparency in healthcare and are fully in support of providing small businesses better and more affordable healthcare options for their employees. But we feel there is an irony in the proposed changes in section 2 and section 4 of this bill. The provisions that are there to limit physical therapy and occupational therapy copays were written into law specifically to protect consumers. This limit has also effectively provided price transparency since the law went into effect in 2015 by limiting the allowable copay for physical therapists and occupational therapy services at $30. So just for some background, PTs are typically paid around between $85 and $120 for a visit. At the time the language went into effect, we were seeing copays for patients in their health plans as high as $75. So because insurance were classifying these physical therapists as specialists, so $75 out of pocket cost for an $85 visit is not a copay, it's a cost shift. So just to, what we were seeing as far as for, just like typical medical specialists, patients will see maybe once a year, maybe sometimes once in a lifetime. A PT episode of care is provided over multiple sessions in a shorter period of time. So typically something like 7 to 12 visits over 4 to 6 weeks in order to optimize the body's healing process and ensure optimal recovery and return to work and life's activities. Representative Linda Orange wrote this provision in 2013 because she knew that her constituents couldn't afford the out-of-pocket expenses of physical therapy copays that occurred at the time. So she knew that if her constituents had a $75 copay for PT, they would just forego that care altogether. And this would result in delayed and even prevention of their recovery altogether, or just downstream costs to the healthcare system, including increased pharmaceutical use, including opioids for patients to manage their pain, imaging, surgery, and further lost time from work. So Representative Orange originally actually proposed a $5 cap in this original language because she felt that that's what her constituents could likely afford. We believe Connecticut's current law capping copays for PT and OT at $30 per visit is a reasonable approach to cost sharing that promotes the appropriate health care and outcomes for patients. The proposed changes here would effectively remove the limit for these for these specific copay only plans. And that would effectively limit access to this service to only the people who could afford, a higher copay. And they probably just wouldn't seek the care that they need. We further don't believe that this.
Are up, if you could please summarize.
Thank you. Yes. So we appreciate the overall intent of this proposal, but we believe it does not take into account past actions, and we wanted to that led to the passage of this legislation. So thank you for the committee for allowing me to testify, and I'm happy to answer any questions you might have.
Mary Claire, thank you for bringing your perspective to our committee. I just want to share with you that from what we've learned just from previous speakers on this bill, that there would be no premiums every month. So, just from paying health insurance, I know you pay anywhere from $800 to $2,000 per couple a month in premiums. Plus, you would pay the copay. From our understanding, the copay only plan is there's no premiums being paid. So the copay is, yes, higher. So maybe instead of a $5 copay, it's a $50 copay. So there is more cost sharing on the copay side, but there's no premiums. Does that change your mind about the bill, or do you still have the same concerns?
Yeah, the concern is really that, patients of physical therapy don't expect they need physical therapy, right? So they don't ever, they're not planning to get injured. They're not planning, so they don't necessarily have budgeted $1,000 to account, which would be, a typical plan of care at a $75 per visit copay, for instance. They don't necessarily have that budgeted or ready to spend that money on physical therapy. We think that it's more likely that they just wouldn't go get that care. People don't want to need to go to physical therapy. And I'm saying that as a physical therapist myself. They go because they have to, because they need to get back to life. And so, I think, it's an unpredictable cost. and a burdensome one. And and it's not, just to be clear, it's not $5, right? Linda thought it should be $5, but the limit is $30. And so right now, that's what, removing that provision would allow an insurer to actually charge whatever they wanted for that copay. So just, using that $75 as an example, would be about $1,000 out of an unexpected cost out of pocket just in a 1 month time period.
Well, we appreciate your feedback and we'll definitely keep that in mind as we move this bill forward. So thank you for your time. Any other
Thank you.
questions? Great. Thanks for joining us today. Next up, we have Paul Pescatello.
So good afternoon. I'm Paul Pescatello. I'm Executive Director and Senior Counsel at the CBIA for the Bioscience Growth Council. I'm also Chair of We Work for Health Connecticut. I'm here today to speak in opposition to HB 5054, an act addressing healthcare affordability. You have, or you will have, my written prepared comments. So in my 3 minutes, I'd like to go off script a little bit and focus on 5 key points. First, the goal of HB 5054 is laudable. The CBIA, the Bioscience Growth Council, members all share the goal of making medicine more affordable. Unfortunately, 5054 is based on a misunderstanding of the science and economics of new medicine R&D and the real drivers of healthcare cost inflation. Second point, price controls. I'm here really today in opposition to 5054 because in all the duties and recommendations, the small 5-person governor-appointed prescription drug affordability board is charged with, 5054 is really about building a runway for government price controls. I'm here to underscore again, as I've done many times before, that government-imposed price controls never work. Wherever and whenever they've been tried, they fail. Worse than failing to control prices, price controls cause shortages of whatever product they aim to reduce the price of and stifle innovation. Third, as high as drug prices may seem, a robust new medicine innovation pipeline drives healthcare costs down, not up. 2 quick examples. Cardiovascular medications, for example, which treat high blood pressure and high cholesterol, now cost pennies a day. But even when they were on patent, they brought healthcare costs down dramatically. They reduced the incidence of heart attack and stroke, and thereby diminished the need for a vast number of surgeries, hospitalizations, and long-term care. Consider also hepatitis C medications. Today, a course of treatment is about $25,000. The medicines that cure hepatitis C, the medicines that cure hepatitis C cure a devastating, ultimately fatal liver disease. Before they were invented, the only potential cure was a liver transplant. The cost of that liver transplant and all the aftercare was $878,000. So it's $25,000 for the drug versus $878,000 for the surgery and aftercare. You've heard me say it many times, but this is the way things are. A new medicine costs $2.7 billion to bring all the way through research, development, clinical trials to FDA approval. If we want the new cures and treatments, if we want biopharma companies to take all the risks of investing in developing new medicines, the biotechs have to recoup that $2.7 billion investment. If price controls get in the way, the companies won't be able to recoup their investment and the research will not happen. Fourth point, the political problem. It's really true. Drugs account for only 15% of healthcare costs. Only 15% of what we spend on healthcare is attributable to drugs. The other 85% is hospitals, doctors, insurance, middlemen like PBMs in the supply chain. If drugs are such a small part of the healthcare equation, why do they loom so large in many consumers and policymakers' minds? The answer lies in the super complex healthcare system we have. The middlemen in the drug supply chain take about half of the
Your
spending
3
on
minutes are up.
brand
If
name
you could please
drugs.
summarize.
Okay.
Thank you.
Insurance plan design, especially high deductible health plans, mean that some patients pay full list price for medicines, where some don't receive the benefit of the huge discounts and rebates the drug manufacturers pay to the middlemen. The solution, I'll just summarize, the solution is really, it gets to the question so many of you ask me all the time, why do we pay so much in the United States compared to other countries? And the answer is that the other countries don't pay their fair share of the R&D costs. And that's where the real solution lies. It's an international relations problem. It's something to be dealt with at the federal level, not at the state level. I'd be happy to answer any questions you have.
Is anything happening at the federal level to deal with the R&D issue?
There's always a lot going on at the federal level, but no company and no administration has been willing to fight that battle of saying we will not provide drugs to another country unless they pay their fair share of R&D. What the other countries pay in the single payer systems is manufacturing cost plus a little bit of profit on the manufacturing cost, but that doesn't compensate them for the R&D. And if they don't get compensated for the R&D, they won't do the R&D.
Right.
We put up with it in the United States because we get the benefit of the drugs, and it does reduce healthcare costs. It really does. And we get those medicines and those cures and those treatments much quicker than other foreign countries do.
You had mentioned that government controls like a PDAB has never, ever made, drug pricing go down, or has not done, but the outcomes that the intent of it is. Can you explain that a little bit? Do you have any other states that you've seen this be implemented in?
I mean, there are already many other committees and working groups that are working on drug prices and reducing healthcare costs. This is a 5-member committee. There's not a 5-member board. There are no members of the biopharma industry, of the very industry that it seeks to regulate and to find ways to reduce costs. It has no representation from the industry.
We hear you. We've made similar suggestions to improving the bill, and we'd love to continue to work with you on this going forward. Any questions from the committee? Representative Berry.
Thank you. You had mentioned that you had 5 points of why this didn't work. I think you got through 4. Was there one more you wanted to add?
The fifth was my last point, that the solution really lies at the federal level, and that is an international relations problem. And I think understanding that the solution is not to go to the single payer systems that other foreign countries have, which don't pay the R&D costs, but to have those other prosperous developed countries pay their fair share of R&D. It's a huge battle, but that's where the solution really lies.
Thank you, Paul.
Thank you.
Next up, we have Eric Morrissey. All right, we're going to go backwards and get Rachel Diamond, who has now joined us. Hi, Rachel.
Hey, how are you guys?
Good. Thanks for joining us.
Thank you for having me. Do I just start whenever? Is this a good time?
Yes, please.
Okay. Well, I just want to say thank you again to the Insurance and Real Estate Committee for having me here today. My name is Rachel Diamond, and I am the Executive Director of the Connecticut Brewers Guild, and I also have a home base here at Broken Symmetry, which is our brewery in Bethel, Connecticut, where I am the head of distribution and brand development. I am humbled and honored to be here today to speak on behalf of Connecticut's 120 breweries. In 2019, our guild proposed an association health plan that could help breweries obtain easily accessible and affordable health care. We had overwhelming support then with 50 co-sponsors here in Hartford, and we're truly grateful that you have kept the torch alive and have all seen the merit in allowing associations to benefit from the access to reliable and affordable healthcare. I've listened in the past few weeks to other trade associations, the past few years really, about the importance of keeping healthcare low for small businesses, the importance of enticing, retaining skilled labor here in Connecticut. And these are all very valid points. Small businesses are the backbone of our state, and finding ways to keep costs low and providing a better workforce is incredibly important. It keeps industry growth moving, and that is wonderful. However, Today, I'd like to discuss something more personal. My brewery employs about 20 people. Being a job creator is something that we are incredibly proud of. We are very small in comparison to the other breweries in the state, and these employees are the reason that we exist. They come in every day with positivity, creativity, energy, commitment, and dedication, and we are not unique. Every brewery in Connecticut feels this exact same way about their staff. Without their high level of care, we would not be nearly as successful as we are. Obviously, beer is a business where you get to make a lot of people happy, right? And we see smiling faces more than most industries. But breweries truly abide by their belief in community, local and far-reaching. I know here in Connecticut, our breweries have raised over $3 million for charities just in 2023. That is, here at least, money for local food banks, money for veterans, critical causes like leukemia, cancer research, local families that have lost their homes in fires, and even us, we've donated to the International Rescue Committee to help children in Ukraine. Global humanitarian crises are something that we care about too. Our owner and head brewer here at Broken Symmetry, Chris Sanzini, says, beer is family, and our Connecticut breweries live and breathe by that. It goes beyond how we feel about our employees and our patrons. It also applies to how we feel about each other. The brewing community in this state is filled with the smartest, kindest, warmest people, and we help fellow craft breweries at any time that they need. We will supply them with, if there's manufacturing troubles or if there's supplies that they need, we would be more than happy to do that. And our idea of supporting the care for our community really is firmly established in our breweries. Caring and service is a large part of what we do, and our employees have waited patiently for us to provide them that care that we preach.
Your
We
3 minutes are up. If you could please summarize, please. Thanks.
Yeah, we have, can you still see me? We have 2,200 people in all of the brewing industry here in Connecticut. That is the size of a small, large company. We would love to be able to provide them that. We looked into healthcare for our brewery. An individual would pay we'd have to pay $649 per individual. That's not including ones with families. But if I go on the ACA and I get my own personal, it's $270-ish. There's just no way we can provide this healthcare. We need collective buying power. Thank you.
Rachel, thank you very much for your testimony. And I think you summarized really what we're trying to do with this bill. Purchasing health insurance with 20 lives versus 2,200 is a huge deal. And that would not only provide better quality plans, but predictability going forward. So we appreciate your feedback. Any questions from the committee? Thank you, Rachel.
Absolutely. Thank you.
Next up, we have Carrie Dyer.
Morning, members of the Insurance and Real Estate Committee. Thank you for allowing me to testify on Bills 5253 and 5247. My name is Carrie Dyer. I am the Executive Director of Reliance Health. We're a nonprofit mental health agency serving all of Eastern Connecticut. I have not yet submitted written testimony, and I'm actually glad that I haven't yet because I've been listening all morning and I sat through about 12 hours of testimony for appropriations yesterday, and it's really helping me to formulate what I want to say. Very much I want to echo what Kevin Zingler and Jeff Shaw said ahead of me. There's two aspects of this that I want to drill down to with regard to liability insurance for nonprofit agencies and some of the issues that we have personally run into, and the medical insurance and some of the complexities there and the sort of hamster wheel that we get on. So I'm going to start with liability insurance first. We have 18 properties. Some of those are houses where people live, and we get referrals for individuals. We work with, again, people who have a mental health diagnosis, and not to further stigmatize that, but there are a handful of people that we work with who are considered high risk. They may be people who have had arson in their history, who are on the sex offender list, or who have just had complicated legal involvement. Our insurance company, as you can imagine, is not necessarily thrilled with that idea. We have a lot of safeguards in place. We do everything we can to have everyone be in a safe environment. But we had an example at one time where we had an individual who started small fires in one of our residential programs. We were not able to successfully house that person, and they had to return to the hospital. Our insurance company said to us, with no uncertain terms, that we will not continue to insure you if you continue to bring in people who have histories of arson or recent histories of risk of arson. I had to argue with a doctor at the state level because they were making a referral of a person who had fire setting risk. And I was being told that I needed to take that person. And I had to explain that no, if I lose liability insurance for our residential programs, you will have nowhere. There will not be any house that I can offer you that will provide support. So that's, to me, it was just this stunning realization that there are people who we contract with who do not understand some of the implications of the things that we as a business have to maintain, never mind the increasing costs. So we have cars that we also insure. So that's a piece of it. But that particular example I thought was really just stunning, and I think you should hear. The other aspect I want to touch on is the medical insurance that was spoken about earlier. We have about a $14 million budget. About $1 million is spent on health insurance. When we submit, we do get denials for a decline to quote because we are a high risk group. This is where we come full circle. So with appropriations, we talk about underfunding the nonprofit sector. We are struggling. We're struggling to recruit people. We're struggling to retain people. And in turn, the people that we do keep are high utilizers of support because—
Your 3 minutes are up, if you could
Okay.
please.
All right, so I'll summarize. I appreciate, I hear the genuine concern. I know that really what we're looking for are lifelines, and these things have to happen not in silos, but all together. Appropriations needs to be supportive. All of the lifelines that we can offer to nonprofit sectors, I think we need to have these discussions, whether they move forward or not. They start the discussion and they can bring out these examples that we can share and benefit from. So thank you for your time.
Carrie, we thank you for your time, having spent all day at appropriations, now spending all morning and early afternoon with us. We really appreciate your testimony, and it does mean a lot to hear from you. Do you have any
Absolutely.
questions from the committee? Great, thank you, Carrie. Next up, we have Jamie Jones and Will Della Camara.
Hi, how you doing? Members of the Insurance Committee, Rep. Wood. I'm Jamie Jones. I'm a farmer, 6 generations of farming in Shelton, Connecticut. Last minute, I was joined by Will here. He didn't have an appointment, but I welcomed him to come on with me. But we have about 500 acres of land in Shelton, part of Monroe. We grow strawberries, blueberries, pumpkins, Christmas trees. We have greenhouses, vineyard, winery. We invite over 100,000 guests to our farm every year to sell those products, direct marketing. What you need to know, farming is not getting any easier. And one of the biggest challenges is the weather, the extremes in weather. Just last year alone, we experienced probably over half of our vineyard crop being lost to a frost. And then September was historically wet, the second wettest September in the history of Connecticut. Back to, I think it was 1938 when we had those hurricanes that affected our state. So that's kind of puts you in perspective. So I think it's Bill 5255 that I applaud you for bringing forward for a study of a captive insurance company. I don't know if that's the right answer for what we need to do, but there's a lot of things this legislature can do to move ahead. I've mentioned some in my testimony, but in recognition's time is short, and I will be able to say a few words too. I'll defer the rest of my time to Will.
My name is William Della Camera. I own and operate Chick-fil-A Harrison Hill Farm in Northford. I'm here today to support Bill 5255. I thank everyone before me considering this bill. My farm operation covers 300 acres, approximately 125 are tillable acres of fruits and vegetables, from asparagus to zucchini and strawberries. Remainder being unused meadows, woodlots, and for my farm complex. Over the past 20 years, our farm has made a commitment to ourselves and the environment by using modern cutting-edge growing practices, some of which are the first large-scale farm in the state of Connecticut to use these practices. In 2018, we started alley strip cropping on other lands to reduce and control water runoff, control flooding of fields, and lower our water usage of these fields. Use of intensive cover crop to bring overall soil health back. We employ 14 to 16 workers throughout the season. We have a diverse customer list from small mom and pop stands to supermarkets, a CSA, a small farm stand with pick your own strawberries, and fall activities. We're looking to diversify our value-added product line, but the lack of funds at this time are unavailable, so we can't do that this year. In 2023, although we are not located on the Connecticut River, we did suffer immense losses, not only from weather events, but also lack of market and high input costs. In our situation, we did not lose everything, mostly because of our growing practices we have implemented. We still had a harvest, but barely crossed the threshold to trigger losses on our insured crops. So we basically had to pay premiums for insurance, but still lost over $165,000. We do participate in RMA and NAP insurance. Both come through the USDA. Both have their fair share of problems and uncertainty. Many farmers choose not to participate because of this. We did receive a minimal payment to offset losses this year. I could run on and on about the lack of support that many of these programs provide, that although at first look one may seem that these are viable programs, which they are not at this time. All many of us farmers want to do is not be faced with unsurmountable losses and bills that put us at a disadvantage by not being able to progress, or at the very least maintain what we already have, and possibly spend more time with our children and families, maybe go on vacation that doesn't entail 85% of it being shaped around something for our farm. If this does not ultimately be the answer to solve these problems we are faced with, I, as well as many others, beg you to please find a way to help us keep agriculture alive in the state of Connecticut. We are a big sector of the state's economy. Nonetheless, we bring you the finest agricultural products anyone can find, and that's a fact. And then I have just 3 headlines from the past week. Net farm income, a broad measure of farm profitability, and the latest report anticipates a decrease from 2023 numbers of 155 billion to 116 billion in 2024. That's a 40 billion or 25% drop year over year, and the largest recorded year-to-year dollar decrease in net farm income on record in the United States. And as of Friday, shut down Part 4, USDA and FDA will shut down on Friday at midnight unless Congress takes quick action this week. It's not looking good for us. And the Congressional Business Office of the United States says that crop insurance costs will surge 29% over the next decade. And we just can't afford to go on anymore like this. And I appreciate your time in bringing this bill 5255 up.
Thank you both for coming. My first question is to Jamie, and did you bring the strawberry champagne?
I'll remember next time, Representative. Thank you.
Good. So I just want to let you both know, and your colleagues that are at home listening, because we received tons of support from your colleagues, that really what we're trying to do, I know it sounds complicated here and it sounds like a study bill, but we wanted to get something put forward so that we can have a public hearing, but we're really working behind the scenes on creating a captive insurance model. And this is really insurance of risk. And it's similar to what we rolled out in 2016, the Crumbling Foundations Captive, which basically when you have pyrrhotite, I believe it's called, in your foundation and it crumbles, you're able to apply to this captive model, and they will come in and I mean, it's a huge cost. It's about $300,000 to replace someone's foundation, they lift up the house and put it in. So we wanted to create a similar fund for farmers. So you tap into it when you need it. So it would be a consistent funding source rather than what we're seeing now, which is complete devastation happens and you're all going to your congressmen, your senators, your mayors, your state representatives saying, hey, we need help. I mean, that's not a sustainable model. So we want to help you to have this, sustainable fund. We want you to focus on farming. We don't want you to have to hire back office people to apply to the USDA, to apply to FEMA. We realize that these are mom and pop teams. These are husband, wife teams. These could be a brother and sister. You're busy doing your work farming. You don't have a big back office to apply for all these grants and do all this. The last thing I just want to say is that we know that you are on your third or fourth loan and you're still paying interest on the one from 10 years ago. We know that that low interest loan solution that the state has been doing is also not, a solution that's sustainable going forward. You actually need a funding source because listen, hopefully, fingers crossed, the next 5 years, we don't have, a catastrophic weather incident. But when that happens, we want you to be able to have that source without having to go through the hurdles, the time frame, the decision making of, do we even continue to do this next year? I mean, we need you to keep going. So that's really what the purpose of this is. And we would love to work with you going forward if we need to make tweaks to that, look at different models. I don't know if you have other models from other states. I do know other states did designate funds anywhere from 10 to 20 million based on the last storm. We did not. So we didn't like not doing anything. So this is the solution that we came up with.
Yeah, I do think that's important to recognize what other states are doing. These problems are not unique to farms in Connecticut. They're across our country, just the perils of weather slightly different in each areas. I think there's things that can happen as soon as this session. For example, I believe there will be a bill coming out of the Finance Committee for a farm investment tax credit. You look at things like those that will allow us to invest in some of the things that Will had mentioned doing, whether it's new equipment or other things to help mitigate some of these weather risks that they have. So, I mean, I don't think there's a silver bullet answer to any of these things, but it's offering more tools that the farmer has to work with to, prevent this. Because weather is wind, extremes in temperatures, too dry, too wet. Is it irrigation equipment? Is it tile drainage? There's just a lot coming at us, supporting the University of Connecticut Cooperative Extension, the Connecticut Agricultural Experiment Station. These are vital resources that they can help our farms with. So I just, I really appreciate this committee and looking at that, and there's absolutely no doubt that that should be explored. But as a collective whole, you guys have the ability to do things right now, this session, to make things better for us in this upcoming growing season. And although I'm getting a little bit out of my area of expertise, I'm hearing Senator Kelly, talking about healthcare. I mean, that's, we have over a dozen employees that we got to pay healthcare for. Every year, it's a double-digit increase. So if you want to take care of your employees, like all these other small businesses have talked about, that they're vital to your team to do work, that's that much less that we have to invest in the other parts of keeping our farms running. So appreciate the committee. And
we're working on both those topics today. Thank you. We have a question from Senator Wong.
Thank you, Madam Chair, and thank you, Mr. Jones and your counterpart. Farmers have earned a reputation for being such a hardy, resilient group of entrepreneurs in some ways. You're kind of focused on self-determination. You live and depend on the land. You work hard at it. The idea of government getting involved in you is something that's very foreign to many of you. What this bill, as the good chairwoman proposed, was that came to light in regards to some of the severe weather that we have seen this past year in regards to the Farmington riverbeds flooding and a lot of the farms virtually having their entire crop destroyed. Jamie, I think you mentioned earlier the severe temperature changes that have impacted traditional growing seasons and expectations. And ultimately, we talk about climate changes, how it's going to impact your ability to be on a predictable business cycle. Could you share with this committee and the audience a little bit more about your economic model? From what I understand, you yield what you plant and be able to sell and produce and take that money to plan toward the next season. You don't set up a deep reserve. Your next year is really dependent on what you do this year. And if an entire crop is wiped out, what do you do?
Senator, thank you. Yeah, where you started, there's no doubt. If you want to know what a libertarian is, go talk to a farmer. So there's an independent streak. We're probably those who stick around are probably eternal optimists because we're always looking to next season's going to be better, right? But there's absolutely no guarantee at that. I'm very fortunate. I'm a 6th generation farmer standing on the shoulders of 5 generations in front of me, and there's not a lot of us left. And I feel for the newer farmers or just upstarts that don't have that. Will had mentioned that the crop insurance models for the Northeast specialty crops, in my opinion, they just don't work for us. But what we're looking is a lot more self-insurance, diversifying our risk. You heard of all the different crops that we're trying to grow. We're trying to, that old saying, don't put all your eggs in one basket. I mean, it's kind of agrarian in its root. I mean, that's what we've decided to do. I mean, 50 some odd years ago, our farm was a dairy farm. My grandfather recognized the future and just having one crop of dairy was not going to do it. And we've started that evolution of changing. So, you know, we're kind of self-insuring and making sure that we have, relying on the expertise of the other resources. So, as the good senator, pointed out, we are in a little bit of a unique circumstance that others don't have, but it's still a hardship for us. I mean, one of the ideas, we're talking more about healthcare here. I mean, you're all familiar with an HSA is. I mean, why can't a farmer have a farm saving account that he can, when you have a good year, normally you have a good year, we pay taxes on it. So but you take a model like that, why can't you have a savings account that's a set aside? So when you have that hard year, you can take it out and use it to recover from, crop losses. So I think there's a lot of different, like I go back to my analogy, there's a lot of tools in the tool chest that you can offer. And I just think depending on how that independently minded farmer wants to tap those resources, you give them the opportunity to do so. Thank you.
I appreciate that, Jamie. And you are a unique model because you're a 6th generation and you've innovated your business model to evolve from a dairy farm to now having fruits and trees, Christmas trees, and even for the good chairwoman, there are strawberry champagne wine tasting that you're offering at your farms. I think the key is you've been able to adapt and have a greater economy of scale. But think about the small farmer, the 1 or 2 or 4 or 5 farmers with employees that don't have that scale, that a bad severe weather or a devastation or freeze or excessive heat destroys their entire crop line. What alternative do they have other than to be able to have to shut down their business, sell their land, and get out of the business and lose open space and farming? Can your colleagues be able to share some of that from that standpoint, that if you had one bad year where your entire crop is just destroyed beyond your control because of severity in weather, what next steps do you have?
Aside from borrowing or a GoFundMe website, it's not good. So that's not a good business model to operate under. And I don't know if Will has to add anything to add from the farmers who has, but I admit I'm familiar with my business very well, but others who don't have the backing that I have, it's a tough road to hoe.
Any of the other farmers can offer their viewpoint, and if a devastating loss of their crop due to the climate change initiative, severe weather, what does that do for you?
I'm in the whole climate change thing that we got now. There is a lot of money to go towards that through the federal level, but a lot of them become matching grants, and when we don't even have the money to match the grant, we're kind of set out from that too. So, I mean, there's just so many avenues that need to be addressed in the whole agriculture community in the state of Connecticut, from many different angles needs to be looked at, but it's a good start to keep us at least viable from year to year with these losses, and then, you know, work on it from there. There's a lot of grants through the state of Connecticut. A lot of them become matching, and when we lose everything in a year, we don't have the money to match that grant anymore, and it's a downward spiral from there. So, I mean, those are things that all need to be addressed, and I think every farmer is willing to sit down at the table and work with anybody in the state at this point to try to keep our families alive and our businesses alive. I know everyone wants to see agriculture keep going, so let's work towards that.
So with this grant, if I may, would that be a supplement to help you to ascertain more grants and available federal funds? Because one of the reasons we've heard from that was that in light of the devastation that occurred this year, there was limited federal money to be able to help with crop replenishment. Are you saying that there are grants that you can get access to in the federal that you need matching? And would these kind of funds be a resource and help for you to be able to apply for those grants?
Well, there's two parts to your thing. I think when these floods came along, there was a lot of talk about low interest loans. And I know there's at least farms in the state that had applied for those low interest loans to USDA. Although their loan application was accepted, there's no money in the account from the USDA to pay these farmers their loan. So you have farmers right now in the state of Connecticut that have unsurmountable losses, probably towards $1 million, that had to become creative to find money from different avenues and different places. And not only they're capped at certain levels, and then some of the accounts don't even have money in the account to pay these farmers. That's on the insurance side. But then when you get onto the side of climate smart ag and all this other stuff, there's different programs to USDA that will give direct money. And then there's different programs where they become grants. And now when the grants are matching, you don't have the money. So where you got to become creative where you're going to find the matching 25 or 50% of that grant. So that's like two different sides. It's the climate smart ag side to be proactive, but now we're also talking about the insurance side of losing your farm because you lost your product.
Okay, I appreciate that education. So there are USDA grant applications that, in light of the loss that occurred, many of our Connecticut farmers applied, and the application was accepted, but there's no money in it. So even though you said that there's federal grants, the idea may be great. When there's no money forthcoming, that's not a real solution from the federal side. The second part is there are grants and allocations that you guys can apply for, but without resources due to the loss of crop, due to your need to be able to spend money to buy seeds and plant for the upcoming season, you're not eligible for those grants. That's where I think our proposal right now in this bill that we're contemplating in the committee could be a resource, right? Could be a allocation of some additional money to help you apply for those grants with matching requirements. Would that be of resource and help to you if we look at that model to be able to give you some supplemental emergency funding for you to make ends meet and move forward for the next season and truly to be sustainable and in fact survive as a small farm?
Certainly, yes, it could be. I would just caution is just keep it as simple as possible. A lot of these grant programs are wonderful. They're well intended, but remember, a lot of our small farms, you almost need to, I feel like, hire a grant writer to write and achieve, and they are competitive grants. So you put a lot of time into it, and it's certainly no guarantee that you would receive them. And of course, some of them, there's a match to it. And as Will pointed out, if you have no money to match it with.
Well, Jamie and Will, we appreciate your time. We're going to look into the Venmo app to make sure it gets right into the account. And thank you. For
Thank you, Madam Chair, and thank you, Jamie and Will. And again, it's the goal for us to be able to support our farms. It's not only about producing the best state-grown products, but it's also preserving our land and open spaces and helping an important segment of our economy survive. So thank you. Thank you, Madam Chair.
Thank you. I appreciate all your time.
next up, we have James Sharon.
Thank you, members of the committee. My name is Tim Sharon. I am president-elect of the Connecticut Bar Association. I appreciate your time. I submitted written testimony, so I want to just highlight a couple of comments. And I've been sitting here for a while listening to the presentations by others, so I will try not to repeat them. But going off of what the speaker from Broken Symmetry said and Representative Wood's comment when you're trying to negotiate with 22 bodies, that's exactly where most small and mid-sized firms are in this state. Bar Association represents about 8,000 lawyers who in turn employ thousands and thousands of employees. There are another 15,000 lawyers registered in the state. Many of them are also at small and mid-sized firms. Most of those firms are under the size of 50. And so they are negotiating with that same small number of lives. In my firm, which is slightly larger, we come to the table with about 150 lives. I can assure you it accomplishes nothing. Each year, we struggle with the assistance of an advisor to find acceptable insurance that we can provide to our employees at reasonable rates. We fail, frankly, each year because the options are few when you have no bargaining power. And the beauty of 5427 is through combining the lives of association members, you come to the table with greater bargaining power. In essence, that's the beauty of the proposal. And with that, you also accomplish not only being able to offer your employees lower rates for their insurance, but greater options and a greater extent of care that we're not able to do right now. So I applaud you for the legislation. I encourage you to support it. It's an answer to a very expensive problem. Happy to answer any questions you might have.
Representative Pavlik Tomato.
Thank you. Thank you. And thank you for your testimony. I was wondering, would you be able to send me, I'm sure as I think I remember when you sent up on the bar website, you put in like your firm details, whether you're a solo practitioner and so forth. And I was wondering if you have a breakdown of what your, the makeup of your membership as far as women, men, and the size of the firms that they belong to. I'd be curious to
I think
know.
we can assemble that, Representative Tomato.
Okay. I imagine that a lot of, I know there are some male solo practitioners, but for the most part, I have to say that most of the ones that I know have a partner. And so I'm going to guess that most solo practitioners are women. And I just wanted to bring it back to, there was somebody who testified earlier about that she thought that, you know, people of color have, would be adversely affected by this statute that this bill that we're putting forward. But I have to say that knowing that most women are solo practitioners, I don't know why we get ignored all the time, but it definitely would be beneficial for us. I'd love to go look at work at 100-person firm, but I know that's just not going to happen. And most of us have children and are raising kids. And I think this is a good option. And I appreciate your testimony today and speaking up for the lawyers and solo practitioners like myself in the state of Connecticut. So thank you.
You're welcome. Most of our members are from smaller firms, and I don't read the legislation to either be gender or racial discriminatory. If it were, I wouldn't be sitting here testifying in favor of it. Thank you.
Thank you, Jim. Next up, we have Christine Capiello.
Good afternoon, members of the Insurance Committee. My name is Christine Capiello, and I normally am here testifying on behalf of Anthem Blue Cross Blue Shield. But today I'm testifying on behalf of the Governor's Partnership for Prevention, of which I'm a board member. Anthem has been a founding member of GBP, and we're here, and I'm here in support of the legislation regarding the opioid disposal packets. One of the things that we have learned over the years, being part of GBP, is the importance that it emphasizes on prevention. And I think one of the things that has been one of the things that I think we've discovered as we looked in our medicine cabinets is how much excess medicine we have, whether that's painkillers, whether it's regular medicine, whether it's prescription medicine. And finding an easy way to dispose of that medicine is really critical. You can do it. There are home methods to doing it, putting it in coffee grounds, but honestly, people aren't going to do that. It takes too much time. But I think having an easy packet, an easy way to dispose of excess medicines, particularly with opioids, in your is really critical. One of the things that became clear to me, my father-in-law had some medical challenges over the last couple of months, and thankfully he's fine and everything worked out. But in between, they had been giving him all this medication, some of it painkillers, some of it other things, and he literally had a Ziploc bag full of medicine, and he brought it to my husband and said, I don't know how to get rid of this. I don't need any of it. I really don't want it in the house. And we immediately opened up our doTERRA packets that we got from GBP, put them all in there, shook them up, watched them do whatever they do. And the bag got bigger and it was very cool. It was like a little science experiment. And then it was safely disposed of. And, you know, if we didn't have that, I think my father-in-law might have just thrown it in the trash. He might have just thrown it down the sink, thrown it down some other way that gets into the water system. And so this really was a nice way to be able to dispose of it cleanly, easily, and safely. And so just from our perspective as being members of GBP, we wanted to support this legislation. And I never say that. I never say support legislation.
Yeah, I
never.
Is this
So
being
this
filmed?
might be the only time.
Is this being filmed? Good, because we're gonna go back and play that clip. No, thank you for sharing the story about your father-in-law, because we're putting forward the bill as you guys wrote it. But when we were in screening and we were talking about this on our insurance committee, we're all using it for everything. We're putting our expired over the counters
Yep.
in there,
Mhm.
non-opioid prescriptions, like everything. So I hope that we continue this discussion to talk about where we go with this,
Yep.
because we really don't want anything sitting on the counter, and we also don't want anything going down into our waterways or
Yep.
in our sink or sitting in landfills that then leach into our rivers and streams. So
Yep.
we love the idea of this. Our committee has been championing it. The Governor's Prevention Partnership has come into our districts and distributed the bags. We've
Yeah,
done this
great.
all over. So thank you for being a great partner at it, but we
great.
hope we can go even farther
Yeah.
with it.
Hopefully.
Any questions? Representative Delnicki.
Oh, come on. Seriously?
It's not really a question. I was actually going to say something nice to you.
Get that on tape.
So I'm glad you're doing it the right way. I'm glad you're advocating for it. There's a misconception that pharmacies have the product for free
Yeah.
there. I have a constituent that actually did that research for me and checked the pharmacy down the street from my house and found out that they weren't there.
Mm,
So
That's too
this
bad.
is a problem with a solution.
Yes,
Plain
absolutely.
and simple.
Absolutely.
And again, it's nice thanking you for coming up and saying something nice to you.
Yes.
Any other questions? Thank you, Christine.
Great. Thank you. Thanks so much for your time.
Next up, we have Kelly Juleson.
Hello, good afternoon. It's so good to see you all. And I'm Kelly Juleson. I'm the co-president of the Governor's Prevention Partnership, and Christine makes it a very hard act to follow, but I shall try. So I am here today in enthusiastic support of House Bill F249, and so appreciate this committee's leadership on bringing that important legislation forward to co-dispense drug deactivation and disposal pouches to all opioid and benzodiazepine recipients in Connecticut. And I know that there's going to be a lot of discussion. I very well know that just because the language exists as it does right now doesn't mean that's going to be the completed language, but I applaud the committee for looking specifically at opioids and benzodiazepines because we know that they're misused at a higher rate. But you are absolutely right, Representative Wood, that it's so critical that we're doing everything that we can to properly dispose of our medication, whether it's over the counter with cough medicine, or I have some Aleve here that I'm just going to very quickly show you how this type of product works. So with the Governor's Prevention Partnership, we currently have 50,000 of these pouches that we're distributing throughout Greater Hartford and Greater New Haven as a pilot initiative. I'm very proud to say that we are just 5 months into the program and we've already distributed more than 15,000 pouches. So we estimate that if people go home and use them, and statistically they do use them within 48 hours of receiving them, that we could have deactivated up to 675,000 pills and taken those fully out of circulation and rendered them useless. So if you'll allow me, and when you get one from us, you get this little card that explains how to use it. So I've already ripped the top off just for time purposes. I'm going to put some Aleve in here. This pouch will deactivate 45 pills. It also does 6 ounces of liquid medication. It can also do patches or illicit medication, excuse me. So I'm going to put some water in here. I don't know if the mic can hear, there's a little sizzle action. I'm going to close it up. And then if there was a trash can near me, I would be able to throw it right out. This pouch is made from a sugarcane product. And so what happens, there's a carbon adherence in the process that the active ingredients in the medication will no longer be able to be used. I think one of the fallacies we hear a lot is, oh, well, you should put it in something that is not attractive, like kitty litter or coffee grounds. And okay, sure, that's not attractive, but the reality is even by putting your medication in there, they're still fully active. So I don't know about you all, but I have a very active dog who most recently got into a fire starter, which has disclaimer information on there. You should not be eating this, children or dogs. So if my dog happened to find, my expired medication that I put in kitty litter or coffee grounds, there is a likelihood that he could eat it. And that's an unintentional overdose. We're talking about our young people. We're talking about people who may be intending to misuse prescriptions. And so it's so important for us to really take a step back and consider what is in our home medicine cabinets. I literally empty mine almost every time I do a disposal demonstration, and I'm constantly finding expired medication, whether it's cough medicine, old eye ointment, prescriptions from when I had my wisdom teeth out. The reality is we all have it and we can all benefit from this. And even by us giving out 50,000 here in Connecticut, it's just not enough. This is something that needs to be done regularly and often. I think we can all agree that you wouldn't just buy one toothbrush and consider yourself done for that prevention of cavities over the course of a lifetime. And it's the same thing with these types of pouches. You use them, but throw them in the trash and then get another one for use in the future. So again, I appreciate so much the committee's work on this. I was actually Representative Delnicki's constituent that went this morning to our town pharmacy and asked for a deactivation pouch and was told that they didn't have any. They had some a few months ago that they used as a sample, but they didn't have any now. And I also had to ask, and the person that I asked initially had no idea what I was talking about. So that person then had to go to the pharmacist. So just in terms of an awareness perspective that these are out there, yes, we have take back days. We have drug disposal receptacles. In just my town alone, there's 20 pharmacies within 3 miles of my house. The closest non-police take back opportunity is more than 12 miles away across 84 here in Hartford. So we're talking about 45 minutes, there and back by the time I took them to a non-police disposal place. And we're not talking about an or take back days, these at home. We just want to get medications out of the wrong hands and make sure that we're doing the best that we can for our children, for our constituents, and for our environment. And we surely believe at the Governor's Prevention Partnership that this type of legislation is going to get us there. So I appreciate your time today.
Thank you for referencing the data on how often or how soon people use them, because we had students here earlier who said that their fellow students are definitely getting into, prescription drugs that are sitting on the shelf. So you know, if we change the, you know, behavior of people getting prescribed these, going through the prescription, not finishing them all, getting them into the bag, you know, we really can save lives and protect the environment.
Absolutely, 100%.
Representative Delnicki.
Thank you, Madam Chair, and Kelly, it's good to see you there.
It's nice to
And
see
I want
you.
to thank you on behalf, not just of myself, but on behalf of everyone here about the fact that the pharmacies don't necessarily have them. You did the legwork there, you found out, and I'm glad you reported back. And likewise, I want to thank you for having spent, what, half a Saturday morning with the mayor and myself going over the entire program so that we would know what it entailed, and we're fully aware of it. So keep up the good work. And by the way, you did some great work on the crumbling foundations when you were a legislator up here.
Oh, thank
And I
you.
appreciate that more than you can imagine.
Thank you, Representative. I appreciate that.
So, thank you.
Thank you, Kelly.
Thank you.
Oh, sorry, Representative Pavlik Tomato.
Thank you. Thank you for your testimony. So we had talked before, and I think we talked about, you know, as far as when somebody overdoses, some of the things that are, what is it called, that to revive somebody?
Naloxone?
Yeah, some of those important, but we also talked about the prevention part and how I think that's always been important, that, you know, we are trying to resolve the problem before it becomes a problem,
Mhm.
right? And I know our kids are young, so we have, my son's 5 now. And so for me, I'm like, oh yeah, I want to hold on to, you know, some of the extra meds I have. But I can definitely see when my son becomes a teenager, not wanting to have to go down that path, and really just getting rid of it in a safe way so we don't have to deal with that. So I do appreciate this, and just the extent, and I mean, everything from the packaging, it's amazing how much has gone into this. But let's say, you know, in Bristol, it's not that I don't care about the environment. I care about the environment, but I'm not necessarily sitting here thinking about what's going in, you know, seeping into the ground and out of my garbage and everything. I don't have time for that. I have a 5-year-old. So, but I know we had also discussed where else maybe this, I do care though, of course, what goes into my son's body, right?
Of course.
So how, you know, how are the drugs? Where are they ending up? How far? Or I don't know if you can go into details, some of that, like if you can explain that, yeah, maybe my 5-year-old is drinking water that has something in it if it's been found, or can you explain in any further detail?
I would love to, but I don't want to misspeak. Would it be possible? The CEO of Deterra, or Verde Technologies, who makes Deterra, is here. Could I defer the question to him? Could he join me up here?
Thank you.
And just while we're waiting for Mr. Sunby to join us, Representative, I just would encourage you, even with a young child, here at the Governor's Prevention Partnership, we are all about advocating for conversations and helping caring adults to lead those conversations with their children at an age-appropriate way. I know I've shared before in other committees that when my older daughter was 5, she one time went to take fruit gummies that were not vitamins. They were just gummies, and said I had to take my pills. And it was a teachable moment in that moment with my 4-year-old to say, Zoe, this is not you taking pills, you're taking fruit gummies. We don't joke about that. Where is this coming from? And she said she had seen my, I think it's septuagenarian mother, so my 70-plus-year-old mother, take prescribed medication on a daily basis when she was with her. And so that's where it came from. And so to have that conversation about what's safe to put in your body and what's not, I really think you can start it at any age. And I would love to introduce Jason Sunby, who's the CEO of Deterra and Verde Technologies, who's with us now, who can answer your question about the environment.
Thank you. First of all, I'd like to thank not only this committee, but the state of Connecticut for taking a really big step forward on prevention. As Kelly said, it is so critically important to prevent something before it starts. We have preventive medicine. We pre-treat things, and it's like this as well with abuse and environmental contamination. So we work on those two big societal challenges by getting unused drugs out of people's homes, and doing it in a safe and convenient way, but also out of the environment. So I'm from Minnesota, and we have an area in Minnesota called the Boundary Waters Canoe Area. It's a federal wilderness. No one lives there. You can't have a motorboat in there. You paddle in, what you paddle in with, you paddle back out with. The Minnesota Pollution Control Administration our agency, did studies on the water 200 miles into the boundary waters and found that there were over 150 different pharmaceutical compounds in those lakes, rivers, and streams. And they got there through rain, so incineration. But if you,
Scary.
yeah, and it will drop down, and especially in rural parts of your state, if you are have septic systems, it goes into the drain fields. It won't get your septic system won't filter out those pharmaceuticals necessarily, and they drop down into the aquifers, which then go downstream. So it's really important from an environmental perspective to get these unused drugs out as well. But it's really simple science. I don't know, I have 2 minutes to go through the science so you can really understand how it works. So inside this pouch is a certain amount in kind of activated carbon in a water soluble pod. So think like a big dishwasher detergent pod. You open it up, it's 3 simple steps. You add pills, patches, liquids, sublingual films, creams, ointments, as Kelly said. And it works on over-the-counter drugs, opioids, illicit drugs like illicit fentanyl, carfentanil, crank, all of those downstream. They're all organic compounds. You fill it halfway full with warm tap water. That opens up the pod. It dissolves any pills or capsules that are in there. You leave it open for 20 seconds for the air to come out after it's done sizzling and however you describe that. And you zip it closed and shake it and throw it in the household trash. And through the process of adsorption, the molecule of the drug is bound onto the surface of the carbon. That bond can't be broken. It can't be back extracted. And we all have independent studies on all of these things. It's all evidence-based. But it can't be back extracted and it won't leach out. And again, we work on those 2 big societal challenges, and we didn't want to be disingenuous by throwing yet another plastic bag in the trash heap. So that pouch material is, as Kelly said, made predominantly out of sugarcane in a plant in, appropriately enough, Sugar Land, Texas, that runs on nothing but wind power. So we've won 4 international environmental awards for this, but it's really, really important. And I applaud the work that you're doing on this. And I'm really very happy to hear that it's getting support. We've seen this done in every state in the country. There are 2 other states that are looking at legislation modeled after Connecticut, New York, and California. And you can imagine that the California bill is really heavy on the environmental side.
Now,
Thank you.
you had, this one though, that I have is in a mailer. So there is an option, like if somebody or a group wanted to mail it out.
Correct.
So what would, if I wanted to do this, how much would this cost me?
Yeah, so we were mailing these out. There were a lot of counties that were using their opioid monies that they had received, settlement monies, to mail these out. But the postage, because it's a non-uniform pouch, was, this is about $3, give or take. In volume, it goes way down from there. But the postage was $2.80. So they were spending half their budget on postage. So we listened, learned, and worked really, really hard. We have some really smart people. And we redesigned the pouch. So inside this package is a pouch. It looks like this, but the carbon is spread, it's displaced further. And there's and then it's folded up, and then there's over this card, you can have any educational materials you want on it. Now, your logo on it, your state's logo on it. It can have why you're getting this, who you're getting it from. By doing this and making it uniform, we've lowered the postage cost to 50 cents. So this is a really convenient way of doing it. In fact, no one has to touch the product. We get mailing lists and out they go.
And if I may add to specifically, I think of when we were with you, Representative Wood, in your district at the senior center, we had so many seniors, I'm embarrassed to say, come up and say, oh, I don't need this, to even begin to process what they have in their home medicine cabinets. As we began those discussions with them about what they may have, they really did understand the danger. And we were there right before Thanksgiving. And so we talked about the holidays coming and people coming into their home. And that opened a whole other world of understanding that what is in their medicine cabinets may be dangerous for a loved one, and that they really could benefit from something like this And truly, we believe that anyone in our state, we all have various types of medication in our medicine cabinets, whether over the counter or prescription, could really benefit from this and benefit early and often. There's often not things that are good policy and good politics. I think this is one of those things where we really have an opportunity to save lives here and start at the initially. And to Representative Pavlak's point about naloxone, I think it was easy to draw to that because it was something tangible. You're seeing the effects, and with prevention, it's harder to see those tangible tools. And that's why we at the Governor's Prevention Partnership were so drawn to a product such as this and coupling it with the conversations and building people's quite literally their toolbox as it comes to prevention, and starting early and often in our homes and giving us that own power back to take action.
Thank you. I appreciate that because you're right. I don't, even as a 5-year-old, I think it's age appropriately and done appropriately. It's a conversation that has to be started because they do see us taking medication. There's just no way around it. Then when it comes to this, though, you're saying it in here, it's deactivated. So if I am an addict and I go into this bag to try to get something, get high, I'm not gonna, there's no effect.
Correct. It's
Okay.
unabusable and irretrievable for all practical purposes, like our friends at the DEA require of those of us that are DEA registrants. But yeah, no, you can't get it. If you were to accidentally overdose on pharmaceuticals, the first thing they do in the emergency room is give you a stomach lavage of activated carbon. Does two things. It adsorbs any residual drugs that are in your stomach, and it makes you rich. So yes, after a certain amount of time, very short amount of time, those drugs are completely unabusable.
Okay. So I think the issue really then is just how to do this right. What are our options as far as, do we make the pharmacies distribute it? Do we have different nonprofits doing it? So would you be able to provide us something that other states and other organizations in states, what they've done? I'm just curious to see what has been effective and what people, just what our options are. Cause I think there are definitely different options out there. And, of course, I don't want costs being passed on to consumers. I don't want their costs going up any more than they already are. So that's, of course, important to us as a committee. But I do appreciate all the work that you've put into this. I hope we can find a way to make this effective and distribute it in Connecticut. So thank you.
Yeah, absolutely. And I can share with you, and I think I've gone way over my allotted time, but I can share with you how other states have done this, how counties have done this. And there's a wide variety from mailing them out. Iowa has set up their own basically a PBM to adjudicate from the pharmacies, to pay the pharmacies for distributing them. And then they get those funds reimbursed to them. That's one way of doing this. We've seen distribution models that vary. Again, mailing is becoming more and more prominent because it's so much easier. If you don't have warehouses, you don't have ways to distribute these. That's becoming, I think, that's how it's going to be distributed quite a bit across the country. We've even seen it distributed in West Virginia through Meals on Wheels for elderly or mobility challenged people. They drop them off twice a year, and everything in between. So we'd be more than happy to share with what we've seen and what we know.
Yeah, and I've always told certain groups or people, I do doors every year. I mean, I would be happy to, there's a lot of different things and information that I'm always happy to hand out, and I do almost every door. And Meals on Wheels is a great example. There are so many different organizations and ways to get this out here. And mailing, I think I agree, mailing might be the one of the best options because you've worked on the cost, getting the cost down so much. But I do want to explore those further. So as much detailed information as you can get us would be very appreciated.
Great.
Thank you so much for your testimony.
Thank you.
Great. Thank you both for joining us.
Thank you.
Next up, we have Dr. James Carden.
Good afternoon. Thanks. I'm Dr. James Carden, Executive Vice President and Chief Clinical Integration Officer for Hartford Healthcare. And I appreciate the opportunity to testify on HB 5054, an act addressing healthcare affordability. Hartford Healthcare agrees that affordability is an imperative that must be addressed. We have been focused on transforming the delivery system to ensure that the communities have access to quality care that addresses issues of inequity and affordability. We've made progress. We've made the care more safer and of higher quality. Recently, Leapfrog looked at Connecticut and found the state is now ranked 6th in the country on those measures. Just as a data point, in 2016, we were 43rd in the country, so great progress. We've been creating access, moving care to lower cost care settings, ambulatory surgery centers, ambulatory imaging centers, urgent care centers to allow us to take care of people not in the expensive hospitals. We've been supporting patients with multiple chronic health issues and those with rising risks to try and keep them stable and not decompensating, requiring hospitalization or other higher cost settings of care. And lastly, we've been accepting full capitated risk payments for Medicare population to try and get to a place to where we have a sustainable model for outcomes-based care. All these efforts are really with the intent of making the care growth benchmark a reality, and they're all aligned with the overall aspirations of the entire initiative. However, before we proceed with granting further amendments, additional regulatory authority, we need to address the current deficiency in the implementation of the statute. If we want to have sustainable impact of the rising spend in healthcare, we need to recognize that all stakeholders need to be involved in the process to identify the drivers of the spend, prioritizing the actionable items, and developing mitigation plans that we then can be held accountable for. And all of this starts with data analysis. Data should include a comprehensive view of all the payer segments, including commercial, Medicare, and Medicaid, and acknowledge the interdependency of those payer sources for providers. Data must provide insights into the drivers of total medical cost, including risk adjustment for disease burden, a well-recognized standard in order to understand total cost of care and allow you to look at comparing apples to apples. Changes in utilization, the impact of taking more complicated procedures in patients that we can receive care in a facility, but taking the less complicated, appropriate patients so that they can receive care in lower cost settings like an ambulatory surgery center or otherwise. Understanding the impact of service mix. Our hospitals are taking care of more and more sick, complicated people and the less complicated. And that means that the overall average cost of any hospitalization is going to continue to change as we move this forward. And lastly, the payer mix. How much is government? How much is our commercial payers will very much influence the overall cost of care and the total medical
Your 3
spend.
minutes are up. If you could please summarize.
Sure. Perfect timing. So the current data really does not provide any of this detail, and therefore understanding what is driving the cost of care is lacking. If you don't understand the problem, you can't come up with solutions. Granting more authority in this environment at this point would be misguided. Thank you very much for my testimony. Happy to answer any questions.
Thank you very much for coming today. We heard from some of your colleagues a very similar sentiment, so I won't ask the same questions, but can you just share with us what you believe the drivers of the cost of care are?
Sure. I think there are really several. And again, getting to the buckets. When we look at it, we understand that our patients that are seeking care tend to be sicker. We are aging in this state, and therefore they're presenting with much more complicated problems and expensive problems than otherwise. And so at the moment, a lot of that is driving some of that cost. Part of that problem is certainly access. Anybody who knows they're trying to access healthcare right now is extremely frustrating. We see that rolling into our emergency departments and otherwise. And so if we're not providing adequate access to get ahead of these problems, it's going to be a problem. And we have real challenges of workforce recruitment. Everybody's aware of what the challenges with our nurses, physicians, and otherwise, all of which is expecting or impacting access to care. Third, we are in the process of reimagining what care needs to be in our hospitals. We are doing a lot less lower cost, lower complicated things. So our hospitals are becoming increasingly looking more and more like ICUs pretty much across, and less people had an appendectomy done. With that, It very much, if we continue to be able to provide that care in lower cost settings, we may expect that overall hospital costs may continue to rise somewhat, but total cost of care will fall. And we have to understand the nuance between those things for this to make any sense. So if you look at the drivers, price is part of it. There's no question about it that that is going to enter into it. But without understanding the entirety of the payer landscape, all the different revenue sources, Medicare, underpayments from Medicaid, uncompensated care, all those that don't have a payer source whatsoever, and the impact that the only people we negotiate with is a commercial payer. And we have to come out with some sort of positive operating margin to make this work. All of those dynamics enter into the impact that this is having on the commercial payers as this goes forward.
That's a great point. We heard earlier today that Medicaid pricing has no effect on the commercial market, which I don't agree with, but I was just wondering what your take is on that, considering that we've basically tripled the amount of people on Medicaid over the last 7 years.
So, just as a common sense kind of thing, as I look at this, when we look at the revenue that a provider takes in, it comes from three sources: Medicare, Medicaid, and commercial. That's it. Somehow that all has to add up to getting us some ability to have a positive operating margin so we can keep the business running. We don't negotiate with two of those. So the only place we can look up to make up any underfunding that's happening is the commercial payers. In this state, that's also a declining number of people. And we have all of the dynamic of employer-sponsored versus the fully insured book of business that is in that dynamic as well. So that I understand that there's people who say it doesn't directly correlate one-to-one. But logically, if you're trying to run the business, you only get so much revenue in, you got to pay all your bills. There's only some places to find dollars, and that's where it's going to come. Also, it's not just price. It's the utilization, cost, revenue, the payments that go to providers is both the number of things you're doing, the type of things you're doing, and the price for those things you're doing. And if you don't fully have clarity around those three things, you're going to make assumptions that aren't inaccurate and won't bring us to solutions.
Thank you. Representative Meskers has a question, not a statement. You have a question?
I'll try to remember that. So I did get, I was the one who prompted the question on the payers. So there are two things that would be helpful in the way of information, given the size of your organization. I'd like to know what the revenue stream on Medicaid looks like for you, for services rendered. What an increase in the level of Medicaid compensation would do to the private payers in terms of how you would get the cost shift out, and what kind of commitment. We're going to have to reach an agreement in the next 2.5 years, I think, on the hospital rates and how we treat the hospitals. And I need to know what further compensation is going to work out to be in reducing the payments to the private sector, or the cost to the private sector for the insurance policies. And then one day when I have an insurance person sitting there where you are, I want to know if I increase my Medicaid payments, where my premiums are going, because I'm not going to be putting it into the profit margin as well. So, but I'd like to know what the hospitals are going to look to as a new commitment, and the economic impact of that. I think we don't have that data. I haven't seen it in an effective way of what you're going to return to us in the way of reduced premium costs if we begin to shoulder more of the burden from the Medicaid. And I'm not sure, because I haven't looked at it and I should know what the incremental dollar is that we're getting out of the federal, the ratio of federal funds that we will capture if the state steps up its payments. I think those ratios we need to have in front of us publicly to advocate for the position, and need to know your position if we improve your payments on that. I think that commitment's important.
Sure. And I appreciate that, recognized your question and appreciate it. And I think it's entirely valid to try and get clarity around all these things. So here's the, I don't have the, we know that government payer right now, Medicare, Medicaid combined is consistently more than 50% of all the revenue that the system takes in. Oftentimes I'm seeing 60 and 70%, depending on the hospital, its location, its community it's serving. So they are variable by region and by where it's situated from a hospital and provider perspective. we look at total revenues in and try to make sure that we are needing for price increases just what we need to make sure that we can meet the margin expectations that we have in order to ensure that we have the appropriate dollars to allow us to borrow and other things at an affordable level, as we are very capital intensive as this goes forward. So
You're just defining to me the cost shift, basically.
that's exactly right. And there is a cost shift. There is just no way there's not. It has to be, because you can't just control one if the other two are not determined by us. And those increases that we get in the government are not at inflationary increases by any. They just don't meet that, and certainly Medicaid is not. So that the other part is that so what we need in terms of price increases is what we negotiate. But that doesn't, again, and I just need to keep reinforcing this, that does not equal total cost of care. Because as care, if we're seeing an increase in utilization and an increased complexity of what we're doing, cost of care will go up without a single change in the unit price of what we're charging for. And so that as we look at it, and I know the payers are held accountable to this, but they're looking at both price increases and utilization changes and mixes that are happening that we need to accommodate for. So from our perspective, we've been doing this for a long time, and our negotiated increases are something that we factor in already, and that will continue to go forward.
And lastly, in terms of elective procedures, is there a possibility one day I will see congestion pricing on elective procedures?
I'm not ready to answer in terms of that impact. Is it?
I mean, I'm not sure what we're doing on the weekends and after midnight. And I'm not sure what the price, because I can't find a price of any procedure ever in my medical. I don't think I've known what one thing I've had done to me has cost, except for my copayment or what their insurance company is willing to cover. And I don't walk in knowing. So I'd love to see some utilization pricing and some transparency. And ultimately, it may sound amusing, but congestion pricing on elective procedures, because I'd like people to be able to shop for their procedures to a certain extent.
I think there are a host of interesting things that we need to take and bring on the table to help this problem. This is not just, I think you were the one said, there's no silver bullet to this. There's no single thing that's going to fix this. This is going to take a holistic and very creative approaches to a lot of what we do. I agree with you 100% on transparency. People should know what they're paying and getting for the prices that they have. It's something that we have, and we have been at Hartford Healthcare recognized for the transparency data that we're putting out, for the completeness of it and the accuracy of it. So it's there, but it's hard to interpret, and it's not readily available to people who are coming in for care.
No, Home Depot does a better pricing, better job of pricing what it sells me.
We also provide patients as best we can the estimate of all that. So we have a front end that's doing that.
Thank you.
Thank you so much, Doctor. Any other questions? No, seeing none. Thank you so much.
Thank you.
Appreciate it. Up next is Garrett Sheehan, which I believe is remote.
I emailed Katie Ambrosio from the Greater New Haven Chamber. I signed both of us up just in case he would not be able to attend. And unfortunately, he can't attend, but I think I'm next on the list.
Okay, you can.
Okay, thank you. Senator Cabrera, Representative Wood, Senator Wong, Representative Pavlak D'Amato, and members of the Insurance and Real Estate Committee. Thank you for the opportunity to testify today. My name is Katie Ambrosio, and I'm here representing the Greater New Haven Chamber of Commerce. I'm here today to testify on House Bill 5054 and House Bill 5247. The Greater New Haven and Quinnipiac Chambers of Commerce represent over 1,200 businesses across 15 municipalities in our region. Our mission is to be an advocate for business, a valuable resource for our members, a venue for connections, and a promoter of economic growth that is shared and inclusive. On behalf of members of the chambers, I'm testifying as an advocate for the bioscience industry in the Greater New Haven region, and also as an advocate for all businesses who are dealing with the high costs of healthcare for their employees. We're concerned that House Bill 5054 will negatively impact bioscience businesses in our state. We have a growing cluster here in Greater New Haven that are working in bioscience, and the chamber has worked closely with the industry to support career awareness and the industry's continued growth, including by convening the regional sector partnership. We are concerned that the proposed Prescription Drug Affordability Board language included in House Bill 5054 will quickly dip into price control territory, harming the thriving bioscience industry that we have here in Connecticut. This has the potential to threaten the loss of Connecticut jobs and annual economic output for the state. As we focus on further investment to the bioscience sector, one of the state's most critical components to the economy, the state should not deter biotech companies from further investing. These types of policies freeze future innovation by discouraging research and development into the hardest to treat conditions. Given the close coordination the state has undertaken with the bioscience industry around economic development, it seems a similar approach here could produce better policy. At the chamber, we're equally concerned about the rising cost of healthcare. The costs impact all of our businesses, which is why we're supportive of House Bill 5247, which aims to address this issue. Employee health benefit consortiums will lower costs and expand options for our small businesses who struggle to provide comprehensive benefit packages to their employees the most. By allowing small businesses to bundle through their previously established associations, many will be able to take advantage of the same opportunities as large employers. By allowing trade associations to purchase these plans, small employers can negotiate directly with the insurance carrier, implement plan designs that work for their employees, and achieve cost savings. On behalf of the chamber, we ask that you oppose House Bill 5054 and support House Bill 5247. Thank you for your consideration.
Thank you very much for your testimony. Representative Meskers.
Yeah, I'm going to ask you to repeat or clarify. Having sat in Commerce, I've been taken to a couple of different forums, and the small businesses owners and associations have come out in favor of the MEWA, the plans we're looking at, right? The association. So
Yeah.
So it's your feeling that this is the type of legislation we should bring forward to support our small businesses. Is that correct?
Yes, the MEWA House Bill 5247 bill.
Yeah, there's been varied testimony. That's why I wanted to repeat that and emphasize the fact that I'm hearing this across the board from small businesses, their interest in this. So I appreciate your coming to give testimony. Thank you.
Absolutely. Thank you.
Thank you, Representative Meskers. Any other questions? Seeing none. Thank you very much for testifying today.
Thank you.
Up next is Kelly Ryan. She's also. Good afternoon.
Good afternoon, members of the Insurance and Real Estate Committee. Thank you for your time today. My name is Kelly Ryan, and I'm here today to express Pharma's concerns about House Bill 5054. I did submit detailed written testimony, so I'll just summarize a few key issues here. I know it's been a very long day. This bill would establish a Prescription Drug Affordability Board, which is comprised of 5 members appointed by the governor to advise the Office of Health Strategy regarding prescription drug issues. There are already 2 entities that advise OHS in this space: the Benchmarking Initiative Steering Committee, the Pharmacy Cost Containment Work Group, which then feeds into the steering committee. Far from a broad policy advisory role, these 5 appointees are empowered to conduct detailed analyses of specific drugs, determining in their view what is, quote, cost-effective, innovative, or best for patients as compared to therapeutic alternatives. Reliance on cost-effective analyses raises some real concerns, especially in light of OHS's stated focus on equity. Single centralized cost-effectiveness determinations do not reflect important differences among patients or the need of real-world decision makers. While there's little detail regarding what sort of cost containment strategies may be considered or offered by the PDAB, we've heard a little bit about this today, and the structure of the bill, repeated references to other state and federal activity quite clearly show the intent is to lay the groundwork for price controls and/or access restrictions. The singular focus on prescription drugs is frankly confusing. Despite some rhetoric in their presentations, the data in the benchmarking reports from OHS do not identify prescription drugs as a key driver of spending in the state. Just last month, the benchmarking committee was presented with data identifying retail pharmacies the 4th lowest of 5 categories in contributing to per member per month growth from 2017 to 2022.
Further, the same presentation indicated that commercial spending on physician-administered drugs was driven more significantly by utilization than by price. This is consistent with the most recent benchmarking report released last March, data we see in other states that have benchmarking, and nationally. In fact, total spending growth for other healthcare is projected to grow at more than 7 times the rate of that of prescription medicines throughout the next decade. And net prices for brand medicine have stayed flat, averaging 0.0% growth in 2022. This bill does also not meaningfully consider the impact of supply chain actors. It is true there are some nods to the supply chain and out-of-pocket costs throughout the bill, but the focus of the bill is squarely on manufacturers and indeed on individual medications, not broader systemic reform. I know we have all had this discussion before, and I really appreciate this committee's thoughtful dialogue around these issues. We continue to believe very strongly that there are policies that will meaningfully help patients at the pharmacy counter and address the distorted incentives in what honestly is a broken system. But price controls and unaccountable appointees deciding what is valuable or worth it for patients is just not the right way to go. I'll stop there, and I'm happy to take any of your questions.
Thank you so much for your testimony today. Representative Wood?
Thank you for your testimony. Are PDABs, are we just putting forward PDABs like around the country because, that's,
It's a great press
new thing
release.
to do, or are PDABs actually, do you see in other states where they're actually working? And I don't even know what working is. I would say that, is there a success story somewhere that we can look at?
There is not. So no PDAB anywhere in the country has actually implemented a reform that helps patients, period. It was mentioned earlier in the day, there are a couple that do have the concept of price setting. No state has actually implemented that yet. Colorado is the furthest along. Just last Friday, they decided that one drug they've determined is unaffordable, and they indicated it's going to take them 6 months of rulemaking to even come up with a concept to try to set a price control on that one medication. And that board was established about 3 years ago. Maryland was the first in 2017. They actually haven't done anything. There's lots of conversations and no real reform for patients at the pharmacy counter.
I want to turn to the makeup of the PDAB. We heard a lot of pushback on, just room for improvement in that space. And I think you're also saying if the PDAB was to move forward, that the makeup of the 5-member board would need to change drastically, or at least have different slots on it. Is that something that you support?
Yeah, I would agree with that, right? There are no clear role for patient or provider representatives. And while there is a very brief mention in the bill that the PDAB would have to seek stakeholder input, it seriously is about 3 words that says seek stakeholder input. There's no process for that. There's no opportunity for patients to weigh in. And speaking of other PDABs that are attempting to set price controls, I would just urge the committee to take a look at how patient groups have reacted to that. I know that they are not feeling like they are heard in this process. And there's some real concern about that. And the authority that the board would have to conduct these cost-effective analyses or to determine what is innovative really would rest with these 5 people that, I think we heard earlier today, are not clinicians, are not patients, are not looking at, how these medications affect individual patients, right? By taking very broad population health views, you're masking a lot of disparities within the system. So the whole thing is just constructed to not have the patient voice involved. That concerns us.
Thank you.
Sure.
Any other questions? Thank you for testifying today. Up next is Jody Young. I think he's online.
No.
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 Okay, moving on. There's Tim Phelan here. Here's Tim. Hey, Tim. How are you? Floor is yours, Tim.
Am I on? Representative Senator Cabrera, Representative Wood, Representative Pavlak-D'Amato. I'm not sure if Senator Wong is still online, but if he is, welcome and good afternoon to him. I'm Tim Phelan, president of the Connecticut Retail Network. As you know, the Connecticut Retail Network is a statewide trade group representing some of the world's largest retailers, the state's Main Street retail businesses. I'm here today to testify in support of House Bill 5247, an act concerning employee health benefit consortiums. I have submitted written testimony, so I won't read that, but I do want to make some brief remarks and then answer any questions you might have. On behalf of the thousands of small retailers in the state, we appreciate your raising this bill again this year and look forward to its passage. And we believe that this is a viable option for groups of businesses like my members who want to lower healthcare costs. We all know that health insurance, while not a mandated coverage like workers' comp or other insurance, is a necessity. And the reality is that no business in Connecticut cannot offer health insurance to their employees. Yet the market for such businesses, for each business, especially small retail businesses, is not the same. Small retail businesses cannot enjoy the same rates on premiums, and therefore they cannot compete for employees, and with larger businesses who offer better health insurance packages for employees. This legislation would allow groups like CRN to pool members together and negotiate with carriers based on our collective size, just like big unions can and like big business can. And our goal in this bill is not to eliminate any of the mandated coverages that are currently called for in Connecticut law. Rather, we just seek the ability to go into the market as a group to do our best to lower rates and provide better choices for our members. This bill, as drafted, after a lot of hard work on both sides, does that and represents a solid work product that protects consumers and allows employers the chance to lower costs. So it's for all those reasons we think the time is now for this committee to give Connecticut retailers that opportunity by passing this bill. This bill will benefit small retailers on the bottom line, where the cost of providing healthcare coverage is considerable, and it will help retail employees with coverages that they can receive. We view it as a win-win, and it will also help grow our economy as small businesses thrive and employees are provided with excellent healthcare coverage here in Connecticut. That's my statement. I'd be happy to answer any questions you might have.
Thank you, Tim. Representative Wood.
Thanks, Tim. Thanks for joining us. I remember 4 years ago when you came to the committee and you said it's desperate that we get this passed. And here we are 4 years later, and we're still trying. You've been there from the beginning, really championing this for your members. And you know, what's happening there with the small businesses and over these last 4 years?
Well, let me first say that the reason we came to you 4 years ago was we were desperate, and we did see other states taking action. We had our colleagues in Massachusetts, for instance, have a similar type of group, and their independent retailers were able to pool together and get lower rates. Since that time, the challenge has grown even more now. Less carriers are covering for small, have opportunities for small retailers. So it's just increased. The price has increased. The choices have decreased. So we really think now, based on your hard work, Senator Cabrera's work, Representative Pavlak D'Amato and Senator Wong, and all of you working together to come up with a solid work product that protects all those things that everybody was worried about. Now's the time to do it and give us all a shot at trying to lower rates and trying to help smaller retailers in my case.
Yeah, well, we thank you for bringing the voice to this committee every year, and we just appreciate your time and energy on the bill.
Happy to do it.
Thank you. Any other questions? Thanks a lot, Tim.
You're welcome. Thank you.
Appreciate it. Up next is Ben Shaken.
Good afternoon, Senator Cabrera, Representative Wood, Representative Pavlak D'Amato, members of the committee. My name is Ben Shaken. I'm the Director of Government Relations at the Connecticut Community Nonprofit Alliance. You heard from my colleague Jeff Shaw earlier today about a different bill. We don't usually do this. Usually try to cover both in 3 minutes, but they're two important bills on your agenda. So we're each going to take some of your time. He probably told you that we're the statewide association of community nonprofits. And what I want to tell you is that our members, while we represent all sorts of different kinds of nonprofits, we also are the sole trade association for the nonprofits that provide the Health and Human Services system on behalf of the state of Connecticut, serving challenging populations, people with disabilities, people facing homelessness, people coming out of prison, adults and kids with mental illness and addiction issues in the community. And so I'm here to testify in support of House Bill 5253, an act requiring a feasibility study of insurance pooling options for nonprofit entities. These nonprofits are facing an insurance crisis right now. And Jeff talked earlier about the health insurance crisis that they are facing for their employees, similar to many of our colleagues across the rest of the business world. But I'm here to talk about a liability and property insurance policy crisis that they are facing as well. In addition to significant cost increases, they're facing a severe shortage of providers, insurance providers in the market that are willing to insure the type of services that they provide, these essential services to Connecticut residents that the state relies on them to provide. We did a survey of our members when we started hearing from folks that this was an issue. And what we found was that 64% of our members report a larger than normal increase in their liability insurance. Insurance goes up every year. Everybody knows that. Everyone's prepared to see their renewals go up a little bit, but we're seeing much more significant increases. In addition, for what seems like, because of the type of services that they provide, in some cases at least, about 20% of our members reported that carriers have threatened to drop some or all of their programs entirely from coverage, and they've had to scramble, convince them not to do it, pay sort of exorbitant increases, find other providers. 9% have been dropped from their coverage entirely. You heard earlier from Carrie Dyer from Reliance Health, who serves primarily adults with mental illness and substance abuse issues, who's had to tell the state she can't accept a client who presents with a certain clinical diagnosis because they've had a claim, and their insurer says, look, if you take any more of these folks, we're going to drop your entire agency from coverage. Another nonprofit in Bristol that serves people with IDD reported that they were dropped from their auto insurance provider. They had a claim, and their rates rose tenfold from $31,000 a year to $300,000 a year. And in addition, their agency's liability insurance rose 46% year over year. So it should go without saying, without these insurances, without liability coverage, without coverage for your property, for your vehicles, you can't operate your programs, right? You cannot do this work on behalf of the state and this work that the state's residents depend on. You also are, I'm sure, are all well aware, state funding does not increase automatically. Many of us were here into the morning last night with the Appropriations Committee talking about that as it relates to the state budget. And so there is no mechanism besides the legislative budget process for nonprofits to absorb.
If you could please summarize.
Sure, to absorb even a small increase in cost. So we appreciate the committee raising this bill. It's a study bill. We urge that the committee use its time to work with us and anyone else that need to work with this session to make it more than a study bill as time goes on. But I'm happy to take any questions, and thank you again for your support on this issue.
Thanks, Ben. Have you talked to the carriers and or have your nonprofits and part of your alliance spoken to the carriers and gotten some feedback as to why the exponential increases and why the dropping of coverage?
Thanks. It's a great question. So we are sort of in process of this. I will be honest, in a short session, you are compressing a lot into a short period of time. And this issue sort of only started bubbling up for our members over the last few months. One of the things that we have heard is that for at least some of our members, and when they go out to the marketplace, they're only finding one or two carriers that are even willing to quote them on a policy, essentially through the brokers that they use. I'm not sure that's a universal issue. Like I said, it's only about 50 or 60% of our members report this problem, but I would say it's in process, and we are very open and willing to try to have a conversation to figure out if there are solutions. As you know, Madam Chair, we presented the committee with an idea to sort of create an insurance company, essentially, that the state helped put together that would exist for these purposes exclusively. And I think we still are very supportive of that, but we also recognize that we aren't an insurance company at the Alliance, and we're not experts at all in property insurance. And so we are very open to trying to have a conversation with everyone who is an expert to try to figure out how to make this work for our members.
Yeah, we are too. I know that we really just started working on this topic together, but we're going to work as fast as we can with you and your members to try to get something that we can get our arms around to, provide some, relief. Any other questions? Yeah, Representative Pavlik Tomato.
Hi, thank you for your testimony too. I did hear that there was only one commercial insurance auto carrier in Bristol, or that would cover Bristol as far as commercial goes. So I don't know. I've heard that from a few. So I don't know if maybe that organization's had somebody else and as a result had to go to was forced to go to the one remaining one that covers most of Bristol, and that's probably why I don't know why the premium went up. I'm not sure if that was the case, but I can probably figure out who you're talking about. And yeah, I'd be happy to work on this further because it's, I know they don't have budgets to add increases like that. So it's very frustrating.
Yeah, it's what, as you all know, on the insurance committee, nothing is quite, as it relates to how insurance companies work with businesses, with people, nothing's quite cut and dry, black and white. And so my suspicion, having been talking to our members about this over the last few months, is that there's a variety of other intervening variables that are beyond just the populations that are being served across the state are challenging, and insurance companies are taking a very close look at their exposure. And that is, I was unaware that there was only one commercial insurer left in Bristol. Certainly that's an intervening variable, maybe for this particular provider. We have heard from our members, some of them have experienced a loss, a claim, and that has caused some of these issues with some folks, but some of them are also experiencing these challenges with no change in the insurer's experience in their programs whatsoever, with no claim, with no loss, or nothing above, an ordinary course of what happens, what's happened every year for a long time. There's some other things going on in some other states as well that aren't happening here, that may have a factor, that may be factoring into it. I think there's probably a lot of different things going on in the insurance marketplace. I should say, we've also heard from businesses that have nothing to do with the work that our members do, that they are having some concerns and issues around liability insurance renewals generally right now. And so it's probably a confluence of factors that are all sort of coming together to create this crisis for our members. I don't think we think there's all of a sudden been this sort of collective industry decision that, foster care is just not able to be covered anymore. No one wants that risk. But it seems like that has been the outcome, even if that wasn't, there wasn't one thing that caused that to happen.
Thank you.
Thank you, Ben.
Thanks. Have a great day.
Next up, we have Bruce Adams.
Oh, I do definitely need my glasses. Good afternoon, Senator Cabrera, Representative Wood, Senator Huang, if he's online, and Representative Pavlik Tomato, and all the distinguished members of the Insurance and Real Estate Committee, who I'm sure are glued to their screens right now. My name is Bruce Adams, and I'm the President and CEO of the Credit Union League of Connecticut. And I will be testifying in support of House Bill 5247 and taking a somewhat higher altitude view of the issues surrounding this bill. And quickly, a word about credit unions. Our business model really does offer a unique advantage to the financial services consumer because we're cooperatives. We're a cooperative business like your local food co-op. When there is more money left at the end of a month, at the end of a year, we give it back to our members and we invest in our communities. So it's helpful for purposes of this bill to think of the credit union, an important member of our financial services sector, as a typical nonprofit. And that's why, competing proposals that might offer tax incentives don't do anything for the nonprofit sector or the credit union community. We need real help to be able to collaborate and cooperate with each other to scale up our groups and drive down our healthcare costs so that we can invest more in our communities. So the time has come to bring these employee health benefit consortiums to Connecticut. These are not so-called Trump era association health plans. Rather, EHBCs will enhance the ability of small businesses, especially nonprofits and not-for-profits, to manage their skyrocketing healthcare costs. But let's just think for a second. To preserve the status quo in Connecticut, would allow our large businesses to further entrench market dominance by leveraging their enormous bargaining power to drive down their own healthcare costs. Large businesses do not need the state's help to compete with their smaller counterparts. So by paving the way, and they would do that by paving the way for them to increase price pressures on our small businesses and reduce competition. Not-for-profit credit unions are a prime example of a business that can least afford and should not be forced to subsidize these cost savings enjoyed by larger employers. Opponents will argue that this bill will encourage small employers to move their employees off the exchange, fragment the risk pools, destabilize the market. We've heard this time and time again. But again, they're essentially arguing that Connecticut's small businesses, in sort of a regressive business tax, if you think about it, should be forced to stay on the exchange in order to keep premiums lower for all other participants. We should not be forced to blunt the impact created by large employers on what's going on here in Connecticut. You've heard from Kim Daigle from CU Insurance Solutions and the Maine Credit Union Insurance Trust. Kim is a good friend and offers very compelling testimony. And I'll give you a brief summary and then take your questions. MEWAs have been allowed in Maine since 2019, and between 2019 and today, no one needs a reminder about what has happened in our world. We had a global pandemic. It stressed our businesses to the core. It stressed our healthcare systems. It stressed everything and killed thousands of people. But through it all, the MEWA in Maine provided affordable, high-quality health insurance. Its employer members were better able to weather the economic shockwaves. There was more complete coverage, and Maine had a more resilient workforce. In January of 2022, the Maine Insurance Trust provided a payment holiday to its participants, allowed them to skip 1 month of premiums. In 2023, even though it had an increase of claims representing deferred elective procedures, it passed that financial stress test.
Please summarize.
And this year, it held rates flat. We have experience to draw upon, and I commend her testimony to you, and I'll take your questions.
Thank you, Bruce. You've hit on some really great points that we haven't talked about, or we just kind of glossed over. But you know, our fully insured market has been asked to do exponential increases. I mean, I think we were asked last year to do 25%, and here we have a MEWA in Maine, you know, that is able to, you know, do a single-digit increase. So we're seeing, you know, the difference, and then the destabilization of the small group market on the exchange. There's only 2,000 people on the exchange in small group. So there's not a market to destabilize. And since I have been up here, the exchange has had the same amount of people. And most recently, the new members on the exchange are from the unwinding from Medicaid. So we're not signing new people up. We're putting those people on to the exchange. So I mean, I think that's a separate entity. Like, we're not destabilizing the market by, putting these pooling plans forward. Those are individual plans. Those are individual people. And so I think we have to stop saying that we're going to destabilize that market because that's really not what we're doing. What we're doing is offering another option in the small group market that they're tapping into now. They're tapping into a level funded plan. They're tapping into a fully insured plan. All we're saying now is you could tap into those things as well, but you can do it with a larger buying pool. And I think we sometimes think we're doing something else, but that's really the simplicity of it. You know, at the same time, we heard today of providing additional options, whether it's a copay only plan. I heard someone say they wanted to support, you know, the ICHRA model on the exchange. That's something the exchange shared with us the other day. I mean, there's all kinds of things that we could be doing to help the small group market, and everyone may pick a different option. This isn't, you know, the savior for every single, you know, small group, but at least it's another option out there that people can shop at too, which, you know, what we heard from Tim and his group earlier and others is that there's just a limited amount of options right now, and it's causing a lot of stress and a lot of, you know, expense on the small group. So you know, thank you for sharing that. Representative Meskers.
I think the insights or the commentary were very useful in terms of the credit unions particularly. You know, I sit on insurance and I co-chair commerce, and if we don't have economic growth and the engine of economic growth are small companies, and if we're not supporting a creative solution to their insurance costs and reducing their costs, then we're in the way of economic growth, which lifts all of us. So I think the testimony is very important, and I want everyone in the building to hear that there is strong support for a product that solves people's cost problems. And you know, I really thank you for getting up to testify.
Thank you, Representative. Thank you.
Good afternoon. It's a pleasure to see you all. I'm Susan Halpin, and I'm here today as the Executive Director of the Connecticut Association of Health Plans. And I wanted to comment on a number of bills on your agenda. I'm pleased to support a number of them and lend our support to Senate Bill 210 regarding the reinsurance program, healthcare cost growth, and site of service provisions. Also lend our support to HB 5245, the copayment only health plans as another option in the market. Also to HB 5246, which modernizes the delivery of a lot of documents by electronic means. And also 5248, health benefit review. We've spent a lot of time today talking about the affordability of healthcare. The one thing I would say about the health benefit review, it's kind of a perennial issue in this committee. And you know better than me, although we both know that you see, 20, 40 mandate proposals a year. And this is an idea, I think, whose time has come. A lot of the work that OHS does, this seems to fit within their scope of determining affordability in a way that's real and meaningful and timely and deliberative and has an immediate outcome. So I hope that the committee does choose to go forward with that bill and that the legislature as a whole passes that provision this year. I also want to lend our support, actually, I just want to comment on our position on HB 5247, which is the benefit consortiums. As we were last year, the association is neutral on that policy, but we do have some technical issues that we hope to support to you in the near future. I was glad to hear, I think it was Chairman Wood who asked the question about whether all fees and assessments would be charged on the MEWA, and the answer was yes, and that is one of our primary concerns, is just that level playing field in the same manner there. So we'll be looking at that just to make sure that is what the legislation says, and look forward to working with you on that. Just very quickly, also want to just touch on the HB 5054 and addressing healthcare affordability. I think if there's one issue that I would like to leave with you, it's that the Office of Health Strategy was really built around voluntary cooperation. That was a centerpiece of when it was created. And that was part of, the health plans, and you heard the hospitals earlier, all coming together to have these conversations and discussions, and really to make OHS the engine of strategy and innovation in these areas. I think this bill takes it in a bit of a different direction. It really starts to take on the field of a dually regulatory structure. And it also changes the scope and the authority and creates a bit of an adversarial atmosphere that I think hasn't existed in statute before. Now, some of the conversations get quite robust, and I think you heard Dr. Gifford say that's healthy. And I think that's part of the nature of, bringing these types of stakeholders together. And we would just hope that that is the continued direction of OHS, as opposed to granting subpoena power to the Attorney General, which is a pretty drastic and significant move. And, I would be remiss if I didn't talk a little bit about the cross purposes with the Department of Insurance and the affordability standard. The department looks very closely at the affordability of rates for the small group and individual market. And they are charged under statute with making sure that those rates are not excessive, I always forget this word. Inadequate is the one I can never remember.
3 minutes.
Excessive,
Please
inadequate.
summarize.
I'm summarizing. Inadequate or unfairly discriminatory. So in other words, they don't want rates too high, but they also don't want rates too low because they don't want people coming in and buying the business, right? So they have a very actuarial, mathematic responsibility that doesn't take into account subjective measures like affordability. Affordability means something different to everybody in this room. So I'll just leave you with that thought and thank you for the time.
Thank you, Susan. Any questions from the committee?
Wow, this is a first.
Well, you're at the end, so.
Okay. I thought at least Representative Meskers was going to ask the question, but I'm getting up. Bye.
I'm not allowed to, I was told.
Tom Swan. Wyatt Bosworth and Jeff Hogan.
Good to see all of you. Chairs Wood, Cabrera, ranking members Pavlik D'Amato, Senator Wong, distinguished members. My name is Wyatt Bosworth. I'm Associate Counsel with the Connecticut Business and Industry Association, with the largest trade association in Connecticut, representing thousands of members, 93% of which are small employers. Joined today by a good friend and colleague of mine, Jeff Hogan, who's president of Upside Health Advisors, as well as an executive committee member of the Moving to Value Alliance, a board member of the Connecticut Business on Health, and an advisor to a number of self-funded employers, as well as he does advisory work for two of the largest purchasing coalitions in the country, as well as a number of state employee plans as well. So here today to testify in support of House Bill 5247, an act concerning health benefit consortiums. Please note that I've also submitted testimony on two other bills, House Bill 5245, the co-payment only plan, and House Bill 5248, the mandate review, which I've attached substitute language to as well. Let me just begin by saying that this bill, House Bill 5247, is the most comprehensive, consumer-friendly MEWA legislation in the country. Pooling, the idea of different entities coming together, pooling risk, being an active purchaser, is not a new concept in Connecticut. It's not a controversial concept in Connecticut. In 2010, the legislature voted unanimously to allow municipalities and Board of Educations to pool. Today, dozens of municipalities pool together through a number of consortiums. They're not regulated by ERISA, they're not regulated by the insurance department, but they provide damn good benefits for their members. 37 other states also allow either fully insured pooling and or self-funded pooling. The state partnership plan pools municipalities. A program raised 2 years ago wanted to allow small businesses to pool. Taft-Hartley Union Trusts pool across the country. There's 9 active trusts in Connecticut that provide pooled benefits to union members. Small employers should be able to do this. This bill follows the legislative success in Virginia, a bipartisan victory down there last year, where comprehensive MEWA legislation was passed. And today, the Virginia Chamber of Commerce recently was just licensed and approved by the Department of Labor and their Department of Insurance to set up a similar program that we're looking to set up here. They're projecting enrollment of 100,000 members by the end of next year. So you've heard a lot from different employers and the struggles that healthcare costs have on small employers. I'll let them speak for themselves. What I'm here today to do is to go through the bill, the technical aspects of the bill, and explain why it's the most comprehensive MEWA legislation in the country. Number one, these trusts will be regulated and licensed by the Connecticut Insurance Department as full licensed insurance companies. The same reserving requirements, the same solvency requirements, the same risk-based capital requirements, the same ongoing market conduct review, all of that, these MEWAs will be subject to. Why? Because we need to ensure that these things are solvent and that they're working for the employees that take advantage of them. Second, consumer protections. All 10 federal health benefit mandates, all state benefit mandates, minimum actuarial values of 60, 68, and 78% respectively, equal to bronze, silver, and gold plans offered today in the fully insured market, have to be offered on this plan. It will not offer junk plans because small employers and their employees do not want junk plans. They're guaranteed issue, guaranteed renewable. All of the ACA consumer protections, contrary to what I've heard today, whether it be not being able to discriminate against individuals, covering preventative services without cost share, out-of-pocket maximums, all of the things the ACA does apply to self-funded plans in the same manner they apply to fully insured plans.
3 minutes, please summarize.
So we're here today. I have an expert with me who works with small employers, large employers, states, other MEWAs across the country. We're really hoping to get this bill over the finish line this year. And I just want to thank the committee. I want to thank the Department of Insurance, OHS, the governor's office. Everybody came together last year and tried to figure out a way forward on this. And we look forward to continuing that conversation. So happy to take any questions.
Jeff, do you want to give us? No. Okay. Sure. I would like to jump in with questions. First is, I don't know if you were here earlier, the Office of Healthcare Advocate, Sean King, spoke, and he suggested that we need to do more in the value-based care section, yet we wrote it into the bill. I was wondering if you can speak a little bit on that.
I'd love to. I'm obsessed with value-based healthcare. That's pretty much what my career trajectory is right now, is dealing with value-based healthcare around the country. So I think this is probably the strongest and most important point in the bill at this point, is that we can discuss the trajectory of health costs. If we take a look even at our benchmark, we talked about Massachusetts. I'm from Massachusetts originally. They had a cost benchmark set in Massachusetts and studied in the last year, but inpatient hospital, outpatient hospital was 16%. So we're not really controlling the cost of care. And what has happened around the country since the passage of a federal law, the Consolidated Appropriations Act of 2021, mandated that all employers who have a health plan, small group, middle market, large group, have a fiduciary duty to buy services that are only in the best interests of their beneficiaries. What does that mean? That the employer, typically the CFO or another appointed person, has to know what they're paying for services, hips and knees and babies and shoulders and cabbages and colonoscopies and things of this nature. And they have to purchase those things in the best interests of their beneficiaries. So if they're paying for bad quality, infections, complications, if their folks aren't being given the opportunity to go to freestanding facilities to have their surgeries done, that is a personal liability of that fiduciary. So what has this caused? It caused a huge change. We've seen the big insurance companies have really moved to create separate health services companies. And in our marketplace, in the last 16 months, we've seen 12 different tech-enabled advanced primary care organizations move into the state by provider groups, including primary care and multi-specialty groups, to help to move them into risk arrangements. Why? Why Connecticut? Because we have huge variation in cost and quality between our systems. And employers now need to control these costs directly. So we have supply side value-based healthcare solutions in Connecticut that can be contracted into our plans to create predictability around cost and quality, particularly for employers with large cost items that are highly repeatable. We heard this morning about pharmacy. Pharmacy is very expensive. We now have a focus with many employers in Connecticut on the reduction of pharmacy costs. Curiously, what I heard this morning was discussion around PBM. 52% of specialty is on the med pharmacy side, on the hospital side, without any discussion around that at all. So CBIA, as part of this bill, is committed to putting in value-based solutions for site of care, primary care, direct contracting, which comes from large groups having power to negotiate and contract in the marketplace. It's veritably impossible to do this on a small group basis in the marketplace, but certainly as a large group, you can do it. How do we know that? About 4 years ago, that's what the state of Connecticut did. That's what the comptroller's office did, which was to go out and create an IPO with about 2,400 primary care physicians to steer into episodes of care for an aspect of the state of Connecticut employee health plan. So we've already seen this happening in the marketplace. We now need employers to pick up the ball and to create this predictability in their plans. And it's also an opportunity, certainly, to reduce costs for these plans.
Thank you, Jeff. Just to piggyback a little bit on the CAA. So Kim Daigle had mentioned that they are now going to be covering diagnostic preventative care measures for their population based on the needs of the MIWA in Maine. And and that's, I think, the power. So basically what we're saying is not only are these plans have to be in compliance with CID, with the ACA, with ERISA, now the CAA component comes into it. And, it sounds great. We now are looking at the data of our employees' needs, but what happens if a company doesn't come into compliance? Are there repercussions out there, or have we seen the impacts of not following the CAA?
Yeah, so CAA was just passed in 2021, and there's been some phase-in of provisions on December 31st of this past year. Every employer had to attest to the federal government that they have removed gag clause language from their contracts, and that basically was language which would keep them from receiving data and analytics on their own population, what they're paying for services at specific providers and health systems, and the quality that they received. So that just occurred. We just saw in the press, it's been quite popular, a class action suit against Johnson & Johnson for breach of fiduciary duty, specifically around prescription drugs, that in fact, Johnson & Johnson as a fiduciary, this is the allegation, was paying something like $10,000 for a dosage of a $25 drug. So these are the first lawsuits that we're beginning to see. We've actually seen a lawsuit here in Connecticut. A couple of the Taft-Hartley groups are suing a certain payer for not providing them with their data and analytics. So we're only just starting to see this, but the market has already reacted, as I said, with provider groups that are moving into states where there's a lot of variation in cost and quality, where it's their desire to go into predictable value-based arrangements that are, here's what you pay for this, and you have that predictability. And that's really what we're talking about in this bill.
So we heard from the Connecticut Bar Association, which I think they said they have about 15,000 members. And obviously, if you start adding families, that's, they could have 30,000+ people. I envision that they would probably go forward with like the self-funded MIWA and set up the trust, and do the data collection. And, it's a pretty big undertaking. But we also heard from childcare providers, early childhood sector, that have 2 to 6 employees. What model would you see that they could have access to?
Yeah, go ahead. I'll go first and then hand it off to Jeff. sorry to keep repeating Virginia, but I'm just really impressed by what's going on down there. And I think it's an awesome case study you all should look at. So what the Virginia Chamber did was they had similar legislation that would have allowed any organization that met their CID equivalent requirements to set up a MEWA. What they ended up doing was they entered into MOUs with all of the chambers in the state, all of the trade associations, as well as the Farm Bureau. And what that means is the chamber is hosting the trust, but all of the organizations are feeding their members into that umbrella, right? And to me, that's one of the most effective ways to do it, right? Like I said, they're going to have 100,000 people enrolled, 500,000 the following year, right? That is 5 times the size of the state employee plan. That's how you're able to implement the value-based insurance design components that the state implements, that Electric Boat implements, that municipalities implement, that the partnership plan implements. You need that scale to be able to do that. So if this were to pass, I really think the most effective way is to have a couple of players that are able to build up that scale. And I envision organizations like CBIA, a regional chamber of commerce, a nonprofit alliance, right? Groups that have experience doing this stuff and have the membership to scale up to be major players in this. That being said, the trust components in this bill are also robust. So the employer members, let's take, for example, a regional chamber that would set this up and have 1,000 employers. Those 1,000 employers would have access to become board of trustee members, right? So the employer members are directing the benefit plans, right? Not the chamber, but the actual plan participants. That's required under the bill. And we propose that because that's good governance. You want the members directing, right, the type of plan designs that are being offered, the rules for participation, et cetera. Jeff?
Yeah, and you want the members to be able to understand the unique needs of the population they're serving. I think that is something that we don't, it gets lost. We think like we're going to provide the same thing that this company is doing over here. Well, we're setting a baseline of bronze, silver, and gold. We hope, I think, in creating the pooling and creating the buying power, that the plans are much more unique and even better than a gold level plan.
And let me just respond to that, Representative. There was some criticism last year that these plans would just be junk plans, right? Junk plans meaning 60% equivalent bronze plans that are offered. Employers don't want those plans. The employees don't want those plans. If CBIA set up a trust and we had 300,000 employees in that trust, we would be foolish to only offer junk plans, right? So I think if anything, that language is more belts and suspenders, because what the market wants is the market wants a wide array of plans, right? They want high deductible plans if they desire them. They want those benefit-rich platinum equivalent plans, right? Some may want catastrophic plans, but the employer gets to choose. That's the beauty of it.
So just to comment on that, and to your point, each population is unique and has unique needs. So there may be a certain percentage of polychronic diabetes, hypertensive, hyperlipid population who drive more costs. And the nice thing with value-based healthcare is that it includes digital health assets as well that help people comply with their drugs or to deal with their insulin, to have virtual care if they need it to check in. These are critical aspects of value-based healthcare. So I'll give an example. It was about 3 years ago because it was during COVID. Everybody knows Stu Leonard's in Connecticut, and it's a great place, by the way. But they were suffering from high costs and volatility and high deductible plans. And they entered into a value-based arrangement. 2 plan designs, one that was open, you could go wherever you pleased, and the other that mandated the use of a primary care physician, but did steerage to lower cost and higher quality hospitals. And they saw huge savings in the first year, in excess of 30%. So they went to copay plans from high deductible plans. They saved money. They were given raises as part of it, meaning they recaptured capital back to their employees. And think about that. It just doesn't happen with the products and solutions that we have in this marketplace. And that opportunity exists with not only this financing mechanism that's described here, but also by putting in value-based attributes that are important to the specific employer, to have those choices that that employer wants and needs. One more thing, small group. In many small group situations, it's not the employer who's paying this. The employee's paying up to 50% of the costs of these plans. So doing things in the interests of those persons is now a fiduciary duty.
I can keep asking questions. Do you have questions, anyone? Representative.
Thank you. We heard a lot of talk about these plans becoming insolvent. What protections are in the bill to address those concerns?
Do you want to go first? Or do you want me to do that one? Okay.
Hi, Representative. Good to see you. So as I stated at the top of my testimony, these MIWAs will be licensed just as a domestic insurance company is licensed. One of the most critical components to that, to make sure that the MIWA, the trust, is capable of enrolling people, is to have a $4 million capital in surplus. Before a license is even granted, you have to have $4 million in the bank. That's very high. It's less than what a domestic insurance company has to post, but it's certainly very high. And what that will ensure is that really the larger organizations, the ones with experience with capital, with membership, are the ones running these things. Second, it has to comply with all of the regulations under 38A of the Connecticut General Statutes. Everything from risk-based capital monitoring to market conduct analysis to visitation by the CID once every 5 years to even the methodology that Jeff can get into. I know there's been a lot of talk about this thing will discriminate against sick people or whatever. That's just not the case, because the rate methodologies that are used under this are ultimately signed off by the insurance department the same way they sign off on the renewal methodologies, or not the same way, but a similar way that they sign off on the rate methodologies that large group fully insured plans use today. The MIWA also has to post a bond with the commissioner. The MIWA is under consistent financial examination with their reserving and capital and surplus requirements. All of these things, I should say, municipalities are not subject to. The partnership plan is not subject to. The state employee plan is not subject to. Single employer self-funded sponsored plans are not subject to. But we're subject to, because it's important that these things remain solvent and that Connecticut residents have confidence that the benefits provided by these trusts are going to be paid out. And like I said, 37 other states have found a way to do this. Maine found a way to do it. We have the best insurance department, I think, in the world. All of the regulation from the insurance department's perspective in this bill was proposed by the insurance department last year, was signed off by the insurance department last year. They have the staffing to monitor these things. They have the resources to monitor it. And we as, CBIA, chambers, trade associations, we welcome that regulation. That was one of the key things that we criticized the public option for a couple of years ago, was that no one would oversee it except the Healthcare Cost Containment Committee, right? The Department of Labor oversees these. The Connecticut Insurance Department oversees it. There's a fiduciary duty under the Consolidated Appropriations Act for these trusts to act in the best interest of the beneficiaries that utilize the programs. Additionally, there's also a stop loss requirement as well. And Jeff can speak to that.
Yeah, the stop loss thing, I think solvency capitalization is really important, but for any of these things, the stop loss piece gives group level protection. So that includes on any individual claims that are at a certain level that's included in the plan would be paid. Stop loss is procured and paid for, and also aggregate claims. And just to understand that real quick, we're probably going to get there anyway. Why did most of the fully insured marketplace go away in the small group marketplace? Because of level funded plans that came in to the marketplace. So I'm talking about level funded plans offered by Anthem and Cigna and Aetna and United Healthcare, all of which, even though they're not monitored or have coverage from the CID, utilize distinct renewal methodologies. These plans, and the reason they became so popular, they were previously called premium equivalent plans. So if you had a fully insured plan, this is what you would pay as an employer in a particular year. And when these came into being, the level funded plans basically targeted a maximum cost of what you were already paying on a fully insured basis. So the level funded plans became very popular because employers would have flexibility in plan design. And if they had a good year, they would save that money. It would come back to plan beneficiaries. That's the design on level funded plans. And it allows them to build a reserve. And that money can be used to smooth out years that they have bad claims as well. And this is why, the marketplace is predominantly handled by level funded contracts in the marketplace at this point. So the stop loss thing is critical because it gives you specific and aggregate coverage on a group level basis for any type of exposure you might have. And we haven't gotten into renewal methodologies yet, but these plans feature renewal methodologies that the CID will have oversight over and knowledge and collaboration with that limits the amount of credibility of the claims of specific groups. That's why this whole notion of spreading the risk, much like a large group, reduces the fixed costs like stop loss and administration that are currently paid on each group basis by level funded employers.
Excellent. Thank you both for the explanation.
Representative Meskers.
I was doing good until about the last 3 sentences, and then you went down a rabbit hole that I couldn't get my way around. So there's a question, and there'll be a statement first, unfortunately, Madam Chair, and Mr. Chair, Co-Chair. The stop loss is essentially an underwriting it's a reinsurance mechanism, if you will. It's laying off the risk in a policy. It is a simple form of it, no?
Yes.
Okay. So what you're doing is you're buying an underwriting insurance policy called a stop loss, which is lowering the premiums because it's being purchased by the entire group and not the individual policyholders. Is that correct? Part of the fee to participate in the group.
So the answer is that each individual group will pay for stop loss on their group, and there's aggregate stop loss on the entire group. So you have duplicative coverage on the MEWA.
And in what ratio are you looking at for the?
Depends on the size of the group. So as it grows, the ratios become much smaller. So right now, on a level funded group, they may have 20 employees. 40–50% of their fixed cost is the cost of reinsurance. As these things grow, and by the way, a MEWA is one way to do what we're describing here. You can use captives, there's VIBAs, there's all kinds of different ways to pull groups together to spread the risk. But as the groups grow, those fixed costs go down fairly substantially because you're spreading the risk over more people.
That's the MEWA itself is the group that buys the stop loss, or the participant groups?
So the participant groups pay for stop loss, pro rata by their size and demographic and what have you, but the MEWA is purchasing that on behalf of the group.
Okay, so there's a subsidy basically at some level or not a subsidy, but there's a smoothing of the risk by the MEWA purchasing the stop loss.
Yes, and that's a design behind this to get the economies of scale. And in fact, the smoothing, I'm going to use a different word. It's a pooling of the risk to, and that's part of the problem, even with level funded plans right now, the smaller groups, have one or two big hits because of the renewal methodology, that doesn't get recouped by the carrier, but they're pulling it over their entire book of business. That's the same design here as well. So we've seen bad actors come into Connecticut. The CID has done a good job when small TPAs come in and claim their level funded plans, and they're not. They're ASO plans, and they slap on stop loss that is completely experience rated. It's not a level funded plan. The design here, as we're describing, pools that stop loss risk over the entire group.
I think it's an essential asset. That's why I'm asking, and I wanted to drill into it because it's going to provide access to affordable health care. Ultimately, that underwriting. I mean, that's the way. This is the only way we're going to get to a mechanism, right?
That's the only way you're going to get there. Absolutely, that's perfectly said.
And the only thing I'll be looking for is the wording of that between the individual members of the group or the institutional members within the MIWA to see how big or where the stop loss is for the entire MIWA versus for the individual groups, so that we can work on smoothing that pricing, right?
And I believe the legislation also requires a pooling point to be developed and equally distributed across the pool as well. So Jeff,
Correct.
do you mind explaining to the committee what a pooling point is? And
yeah, sure. So we've kind of gotten into that. So there's a pooling point for each group, specific stop loss for big claims, that exceed the expectation. They get paid. And also for the group itself. And this is what I was trying to explain before. For individual groups, the way these things are typically rated were premium equivalency. What would they have cost on a fully insured basis? And set that limit. You're going to pay no more than you would on a fully insured basis. That's why people went to these types of plans. Why? Because in the fully insured marketplace, you got no data and analytics on the utilization of your population. Are they going to hospitals that have bad quality? Are they getting overcharged? You had no way to do accountability on any of these things. So a critical aspect is analytics that's provided to each group. So they can look at their problems. They can see if med pharmacy is a problem, or if musculoskeletal, they're paying $100,000 for a knee that should only cost $22,000. So these are critical pieces of that. So you spec and ag on the individual case, and then the aggregate corridor on all of the risk for all of the groups together as well. So it's duplicative coverage.
So in extremis, the alternatives are I go to the exchange on an individual basis with no subsidy from my employer. Or I go with a self-funded plan individually purchased by my employer, which is going to inherently have a lot of costs and questionable coverage, right? Or I look at a plan like this where I can pool my risk. So it's really, you're providing people an exit point from a group plan that we think is poorly designed, with the opportunity to get into a plan that's well designed with tremendous oversight. And those are the real alternatives people are facing. So, I mean, that's what we have to look at. It's not the ideal, what we would prefer versus the reality is either they get a pooled risk plan that's designed with oversight from the insurance department, or they're on a self-funded plan with virtually no oversight or with no oversight from our insurance department. I mean, those are the choices, where stark choices our people are facing.
And let me just say one thing too. Access Health Connecticut, they had a board of directors meeting back in January, and I think finally recognized kind of the perilous situation that the fully insured market is. It's in my testimony that, the CID sent us enrollment numbers on a small group fully insured basis last year, right? 2017, 230,000 lives. Today, less than 80,000, right? That market is shrinking. Connecticut left the market. Harvard Pilgrim left the market. Anthem, and that's off exchange. On exchange, the shop exchange is virtually non-existent, right? Less than 2,000 members. Anthem is the only carrier on there. So if anything should come about our testimony today, I just want you all to recognize that the
the situation in the fully insured market is not sustainable.
Well, but I think you're missing a piece of the analysis.
Yeah.
As our chair said originally, there's been no increase in enrollment on the Affordable Care Act. So if we're going from 230 to 80, that means 150,000 people have gone into basically an unregulated product with a questionable structure because there's no oversight. So they're buying individual plans directly from self-funded plans, right? Without a design.
A lot of them have gone level funded. Some just have dropped coverage altogether.
Right.
Some are embracing, ironically, I heard a lot of Trump era stuff. The Access Health Connecticut is embracing arguably the singular healthcare thing that President Trump did, was institute ICRAs and QSARAs. So just for irony's sake, right? Those are
But if our numbers haven't changed, I'm asking you where you think the 150,000 people went.
Oh, I'm telling you, they're going level funded.
Yes.
Because they haven't gone to the exchanges, what I'm
Well,
saying, numerically.
Some have.
Okay.
They're going level funded. Some have dropped coverage altogether, and some are utilizing these new HRA tools where the employer's throwing $500 into a bank account every month. That employee then is taking that money and going to purchase subsidized coverage on the individual exchange.
Okay.
So, am I missing anything, Jeff? I think.
Yeah. So, I'll just give an anecdote quickly. So, 5 years ago, I was on a level 1 plan. % increase that year. So we have the carriers in the state with level funded plans. It was a Cigna plan. Anthem, Aetna, and United all have these plans. And this has been an interesting conversation. We had it with CID. We had it with the healthcare advocate as well. But since they're not involved in regulating these plans, it's interesting. The carriers have self-regulated themselves with renewal methodologies that are reasonable. They resemble what the fully insured renewal methodologies look like before. They only use a little bit of risk, for rating them to keep people on it. So you don't have big increases on these things. So people like these plans. People like the plans. If you talk to employers in the marketplace, the really interesting thing about this, if you think about it, the irony of this is if in fact this legislation gets passed, you now have oversight on these plans. And likely those people that are on level funded plans are going to look at this opportunity to reduce their fixed costs and get more features as well. So it's a better situation, and the state is getting to look at renewal methodologies, rating methodologies, the marketing aspects of it as well. It's a strange irony.
Thank you.
I have one more question. I could ask another one. Sorry. We heard earlier that there's discriminatory underwriting, and then I asked if that was legal, and it's not. But then we heard that there's a loophole that would happen with plans like this. And I was wondering if you can just dispel that.
Can I do
rumor.
that? Yeah, quickly. Yeah. So please. So it's not a loophole. So ACA plans that are fully insured are ACA plans that are fully insured. Self-funded plans, and we heard from the insurance commissioners before. I mean, we've got 73% of the commercial marketplace or more is self-funded in some way right now. It is, period. So that's an ERISA preemption. It has been around forever. Self-funded medical plans are the way that most people insure their risk in the state. And, why is that? By the way, many level funded plans cover all of the state mandates, but some of them only cover a few because of the cost of things. And on some of these, the employer can choose. Yes, I want infertility. I need autism. Yes, I need these things. But on some plans, they choose only 3 or 4 of the mandates as well. So this is basically what's happened in the marketplace, that people have moved away from that community rating into opportunities where they can participate in savings and get their data and analytics as well.
Yeah, and let me just follow up, because I've been listening for the last year and a half, and there seems to be a fundamental misconception that self-funded plans are not subject to the same consumer protections that fully insured plans are. That is categorically false. The market reforms that Senator Lesser brought up, that we're not subject to the market reforms, that applies to two things, and obviously applies to two things. One, the small group community rating requirement. These self-funded plans are not community rated. The fully insured market is. They can only rate on age, family status, geography, and tobacco use, I believe. Those are the only 4 factors you can use. That is an ACA market reform. The other market reform, the medical loss ratio, 80% in individual and small group, 85% in fully insured. Those 2 things do not apply here. They don't apply to any self-funded plan. But the consumer protections, right? So through ERISA, when the Public Health Service Act, ACA, was adopted, it was codified in ERISA. So whether you're fully insured or self-funded, there is a ban on discriminating against individuals with pre-existing conditions. There is a ban on setting eligibility rules based on health status. It's in the bill as belts and suspenders. If it wasn't in the bill, it would still apply under federal law. You know, and things like dependent coverage up until age 26, self-funded plans have to comply with that. You know, no lifetime or annual limits on essential health benefits, just like fully insured plans, they apply to self-funded plans. HIPAA, right? Like I said, the pre-existing condition component was actually a HIPAA reform. HIPAA applies to this. The Newborns Act, right? So if a plan offers maternity hospital benefits for mothers and newborns, the plan must pay for at least a 48 hospital stay for a normal birth and 96 for a C-section. That applies to self-funded plans. It applies to these plans. The Mental Health Parity Act, which there was a press conference on, right? That applies to self-funded plans. GINA, the Genetic Information Non-Discrimination Act, applies to these plans, all codified under ERISA, as well as all of the ERISA fiduciary protections, reporting requirements, plan document disclosures, all of that. So, you know, when you hear that these self-funded plans have a loophole, there's no loophole. The same ACA protections that apply to the fully insured market apply to these plans as well, whether you're a single employer, whether all of you on the state employee plan, I'm assuming, those same ACA protections apply. But the specific market reforms of adjusted or modified community rating and the medical loss ratio, those don't apply, right? Because you need distinct renewal methodologies, and self-funded plans have a fiduciary duty to establish those renewal methodologies.
All right, this was fun. Thank you. Any other questions? Okay, I would ask 100 more questions because I think it's really interesting, but we have other speakers who just started sweating when I said that. Thank you both.
Thank you.
They do. Kathy Flaherty. Hannah Granfield Horton.
Not. Oh, I'll start again with my jokes. No. So good afternoon, distinguished members of the committee. My name is Hannah Granfield Horton. I'm the Director of Strategic Engagement at the Governor's Prevention Partnership. We are a statewide youth prevention organization that is focused on supporting youth, families, providers, and communities with the best strategies and resources for young people across Connecticut to thrive. I'm here today in support of the raised bill of 5249. You've heard about it a lot today, but you haven't heard a personal story yet. So in 2017, my husband was diagnosed with an aggressive form of bladder cancer. Within weeks, he was prescribed his first opioid for pain. For the next 18 months, he was in and out of hospitals and treatments to allow himself more time with his twin boys, who were 10 years old at the time of diagnosis. On September 29th, 2018, he entered our home into home hospice. I went home with over 50 fentanyl patches, liquid morphine, and an at-home comfort kit to make him comfortable for his final days. He passed away on October 1st of 2018. Within hours, I knew that my friends, my family, my neighbors, and my community members would be at our home to pay their respects. Our home was filled with the medications that I mentioned prior, and I needed to ensure that those drugs were removed from our home so that there was no access for other people to take them, including my sons who were 12 years old at the time. When you have that volume of medication in your home, you cannot just drop it off at a drug take back box. So due to a local connection with our police department, I called and they arrived with police cruisers to remove the medication from our home. It was not a little bit, it was 2 Whole Foods grocery bags filled to the top. This ensured that my sons and those paying respects would have no access to those dangerous drugs. I know that my family was privileged to have the police come take the medications. Not everyone has that connection or feels comfortable with calling the police department. Put yourself in my shoes. In the early moments of grief, I had to stop comforting my sons and think about, how do I dispose of end-of-life drugs? If an at-home drug deactivation system had been co-prescribed with these drugs for 18 months, I could have just done this at my house. The drug deactivation pouches make it simple to ensure that unused medications in our home are safely disposed, and they eliminate any potential risk. You open the pouch, you add the medications in, you add water, you shake, you close, and you throw it in the garbage. I ask that you support Bill 5249 and allow Connecticut residents to deactivate and destroy opioid drugs at their home permanently when they no longer need them. Thank you so much for your time today and listening to everyone's testimony.
Hannah, thank you for sharing your story with us. Senator Anwar.
Thank you, Madam Chair. Thank you, Hannah, for sharing your story and your work that you've been doing to make sure that the people in our communities are safe and children and adults are safe. So we hear you loud and clear, and I just wanted to thank you for the work that you're doing. Thank you. Thank you, Madam Chair.
And thank you for bringing your team here today. We really learned a lot about this. I think some of us may have known a little bit about the disposal system. We're leaving here understanding so much more. So we appreciate your work.
Thanks so much. Thanks for your time today, everybody.
Kelsey Haddow. You're on mute.
I apologize. I've been on mute all day.
No worries.
Distinguished members of the Insurance and Real Estate Committee, thank you for the opportunity to testify in opposition to HB 5054. My name is Kelsey Haddow, and I work for the Rare Access Action Project in Patient Engagement. HB 5054 seeks to establish a prescription drug affordability board in Connecticut. As we have seen in Maryland, PDABs have developed a dubious history of success and negatively impacting rare disease patients' access to essential therapies. These therapies rely on innovation to create low-volume therapeutics. Pharmaceutical products are part of an interstate commercial system. Price controls in one state can have far-reaching effects that will impact patient access and the possibility of innovation. Patients pay copays each month for their rare treatments, the amount set by the plan. For those without coverage, many life science companies offer access through patient assistance, free drug programs, and many charitable organizations offer copay assistance and purchasing support. Supporters have been unable to explain how PDABs will lower copays, encourage lower premiums, and not damage the access that patients with rare disease therapies through their current insurance have worked hard to get. We have seen the effect of PDABs that they're having on rare disease patients in Colorado, as the PDAB there has started reviewing therapies to determine affordability. The emotional toll and time are negatively impacting the rare community, as they have had to take large portions of their time and energy to testify in meetings to keep the therapy that keeps them healthy and in some cases alive. I urge you to navigate this issue with a commitment to ensuring that no patient is left fearful of losing access to the treatments that offer them a chance for a better tomorrow. We believe there are solutions that can enhance affordability, such as copay accumulator and maximizer reform, meaningful PBM transparency, risk pooling, and reinsurance. However, proponents of PDABs are focused on this experimental program that to date has generated zero savings and offers no solution to lower patient costs. While certain products for chronic conditions may seem expensive, the cost of not providing necessary therapy often exceeds the price of the product itself. Without access to essential medications, patients may experience acute care episodes and placing a greater financial burden on payers and society as a whole. In conclusion, I urge you to carefully consider the potential implications of HB 5054 and please oppose this bill.
Kelsey, thank you. We've heard very similar testimony from other patient groups today, and we appreciate your perspective on this. I was wondering if you could maybe get over to our clerk or share with our committee the references you made on Colorado and some of the issues that they're having there with their PDEB, because I think that would give us some good information.
I certainly can. And I was at an event with 900 rare patients yesterday, and everyone who I talked to sees this as a big issue in the rare community.
All right, well, thank you. Keep us posted on it.
I will. Thank you.
Next up, we have Tom Mangello.
Is that better? Thank you very much. Need a reminder, I'm relatively soft-spoken, so at any rate, thanks for allowing me to testify today. It's great to be here at the Insurance and Real Estate Committee. Once again, I'm Tom Mangello, the President and CEO of the Connecticut Bankers Association. And we submitted testimony on two bills today, and that is the Health Benefit Consortiums Bill and also on broker price opinions. We're in support of both of those bills, and we thank the committee for raising those concepts. By way of background, our association, the CBA, represents all the banks in the state of Connecticut. We've got about 16,000 employees across the state and about 1,000 branches. You've already heard a lot of support for the Benefit Consortiums Bill. We'd like to add to that support. And if you already have our written testimony, so suffice it to say that it would help many of our smaller community institutions, our community banks out there, by controlling the ever-increasing cost of their health insurance premiums, some of which experienced 30% increases this year, and at the same time allow them to prevent a much more robust benefit plan for their employees. In short, it's a good bill that ought to pass. I'll spend the rest of my time talking about our support of the Broker Price Opinion Bill, BPOs for short. And BPOs are a common real estate evaluation method, a tool, if you will, that can be conducted by real estate agents and brokers and appraisers. However, real estate appraisers under existing law, Connecticut existing law, can only conduct them in one situation, and that's in relation to a real estate listing that they have on a piece of property. This bill simply would expand the situations in which they would be able to perform a BPO. Some major examples of those expansions would be mortgage refinancings, home equity lines of credit, second mortgages or home equity loans, mortgage restructurings, PMI cancellation request, and tax, trust, and estate matters. BPOs are currently authorized in 44 other states. 26 of those states have these expanded uses for BPOs. Importantly, though, however, BPOs can never be used for valuations on first mortgages. Federal rules prohibit that, particularly through the secondary market, including the largest government buyers of mortgages, including Fannie Mae, Freddie Mac, and FHA. So what are the benefits of expanding the uses of these BPOs? Simply put, consumers save money. Basically, BPOs are less expensive, on average $50 to $300 versus a full-blown appraisal. A full-blown appraisal can be anywhere between $250 and $1,200, depending on average on the square footage of the property that's out there being appraised. BPOs are quicker. They're quicker to order. They're quicker to have completed and to also receive the results. It can take only 1 to 4 days to do a BPO versus 1 or 2 or more weeks to essentially do a full appraisal. And last but not least, this bill would create easier access to BPO providers, particularly because there's 16,000, at least according to Jim Heckman, 16,000 real estate agents and brokers across the state of Connecticut. Don't forget, appraisers can already do this, but our understanding is based on the numbers we've been able to pull. There's only about 560 appraisers across the state of Connecticut. That basically concludes my testimony. Be happy to do my best to answer any questions. If I can't answer them, I've got our super smart general counsel, Art Corey, in the back, and save the tough ones for him.
Representative Meskers.
That was rapid fire. So 44 states are allowing have two questions. I'll start at the end and go to the front afterwards. So 44 states are allowing the BP
Broker price opinions.
opinions. So Connecticut doesn't.
Connecticut does allow it in a very narrow instance, and that is just for real estate listings.
So for all this other economic activity, who's doing it now?
So typically what happens is that you have to wait for an appraiser to essentially go through the standard appraisal process. And that takes time. It's much more, it's much more expensive to do that. And this is a quicker and easier way to get to basically the same result. And all these instances that I mentioned are basically situations where it's almost an abundance of caution. If one of our banks is doing a home equity line of credit, typically right now you're hiring an appraiser. They're not doing a full-blown appraisal. They'll basically do like a drive-by, for instance, right? The real estate agents, your local real estate agents know these markets extremely well. They know what the valuations are. Valuation data is becoming more and more electronic, more consistent, and quite frankly, better. So this is really, I think, modernizing the ability to get these valuations done here in the state of Connecticut.
And you say right now there are only 506 appraisers in the entire state.
Our numbers that we found are 565 across the state of Connecticut. And those numbers are dwindling. It's very difficult to get into the appraisal business. You literally have a long education process, and then you have to do a 2-year, I believe it's a 2-year, might be one. So I'll say 1-year apprenticeship. So you have to get an existing appraiser to agree to essentially give you that apprenticeship to go through the process. So less and less appraisers are getting in. We're trying to make it easier, and obviously for all the benefits that go along with this.
Okay, I think I digested it now. Second question is, or question regarding the credit union, et cetera. You're competing in the field with commercial banks, with national footprints, statewide banks. You've got, and they're a fulcrum of local economic development, these credit unions, right? And right now you are paying or running into costs much in excess of self-funded plans by larger groups. So without being able to form a group, your insurance costs and your costs of operations, which are going to show up, I guess, in the interest rates you charge the creditors who are living locally and trying to borrow from you.
As competition allows.
Yeah.
Exactly.
So if we want to grow the state, or we want to improve the economics and dynamics of credit unions, we should be looking to allow them to pool in a bill like this.
Yeah, we would agree on that. I think any trade association should be allowed to be able to access what this bill would offer. We used to have a plan, and I'm thinking it was 25 years ago, so it was before ACA, obviously. But we can't do that now. We've actually been investigating a captive solution, but this, in our opinion, and I'm not an expert on this by any stretch of the imagination, you folks know much more than I do. This would be I think, a great and potentially superior approach, at least this is what I've been told, than just having a captive. But perhaps, who knows, maybe it's both is the solution.
No, it's good to get testimony from people in the field who need solutions to their problems, who want to operate and live and work in our state. So I'm appreciative of having I'm a failed banker or an ex-banker myself. So I appreciate the commentary.
Well, we miss you in the banking industry, and I say former banker.
There you go.
Thank you.
Great, Tom. Thank you.
Thank you, everybody.
Olivia Rinks. Anyone else want to speak? Great. Thank you, everyone. Wonderful hearing today.
Like I said, we've done this in the past, and we'd love to do it in the future. Nice to see you. We're working with a guy who used to. He was, you probably know,